We are good to go.
Good morning, everyone. Professor Ashok Das and dear delegates, faculties. Today is the second day of National Update on Clinical Diabetes 11th edition. Yesterday we had a wonderful day with many important sessions and excellent deliberations, starting from diabetes in women by Jargar sir, obesity and diabetes, complications in diabetes, modern therapeutic approaches of different molecules like DAPA, PIO, and all other things, mixed fixed dose combinations. Then we had a diabetes in young and type 1 diabetes session with Ram Naik from US and others. And we had oral anti-diabetic drugs by USB, and it was a nice session. And diabetes, hypertension, and cardiometabolic cases were discussed. So today we are coming back to mostly insulin, basal insulin, regular insulin, and GLP-1 RA. Our first session is GLP-1 RA and insulin's clinical update and supported by academic grant from Novo Nordisk. I request Professor Ashok Das to take over and start the proceedings of the day.
Thank you. Thank you very much, Alok. Dear friends, we are in for yet another exciting session. Now, you know today that GLP-1 arrays are hailed as the molecule of the decade. And these GLP-1 arrays comprising of oral, namely semaglutide, which is considered as the first world's only one protein in a pill, oral semaglutide, along with injectable semaglutide, along with CagriSema, and also the other molecules from the other pharmaceuticals like the Manjaro, combination of GLP-1, GIP, and glucagon, and the retatrutide along with glucagon and survodutide. This drug has become very, very important today, held, as I told, molecule of the decade. Dear friends, I must also tell you that in our country today, we are available only oral semaglutide, and the injectable semaglutide, Bigovi, will be available shortly. And the other companies, drugs like Manjaro and others are also going to be approved. They are already approved. They will be available shortly. Dear friends, on this background, I must tell you, the GLP-1 RA holds the promise of a molecule which was never to not seen. Along with it, cardio, renal, hepatoprotection. It has a glycemic efficacy. It has efficacy in many other fields. And today we have amongst us somebody who will talk about this. Before that, I must tell you that we have two stalwarts of the nation who will be addressing this session. The Professor Dr. Sambit Das, Professor Dr. Abhay Shah. Coming, the first speaker is Professor Sambit Das, who will be speaking about a topic regarding the setting the standard of the basal insulin therapy. I always mention that the advances in insulin are mind-boggling. They're relentless advance. They're astounding advance. And one such advance has been the basal insulin. I mean, I will not speak about it. I will not keep the cart before the horse. We have a very eminent speaker, Professor Dr. Sambit Das, who is the professor and head of the Department of Endocrinology as the KIMS, whom I had a chance to visit with a lot of PG DM students in his department. He's going to speak about it. An absolutely fabulous speaker, MD and DM, and an absolutely astute clinician and researcher. He has contributed immensely in the various organizations, in his own college where he did his DM, and then where he did his where he did his first initial practice in the Apollo Hospital. He had the MD from Cuttack, DM endocrinology from Chandigarh, and is a fellow of the American Endocrinology. I will not take time to introduce him. It is my great honor and pleasure to invite him to speak. The setting the standards. What the words? Beautiful title. Setting the standards of basal insulin therapy. Sambit, all is yours.
Hello, dear friends. Very good evening. And at the outset, I must thank the team Nucd and Dr. Alok Kanungo sir for giving this opportunity. And this is the Insulin Symposium, and I'll be speaking something on insulin degludec. And as we all know that degludec is a very important second generation basal insulin, and I'll set the standard in basal insulin. So the basal insulin concept is not new. It has been there from a long period of time, but it has evolved in due course of time from NPH to first generation basal insulin to second generation basal insulin, and now we have degludec and glargine U300. So the next few minutes or 20 minutes, I'll be discussing about degludec. So let us start with a case scenario. So he's Mr. Rajesh, 48-year-old male lecturer. So weight is 78 kg, BMI is 27.2 kg per meter square. Blood pressure is 146 by 84 millimeter of mercury. Medical history: he has been type 2 diagnosed with diabetes for the last 8 years. He has systemic hypertension for last 8 years. Dyslipidemia has been there for 3 years, and there is family history of diabetes also. Alcohol intake is there for more than 2 drinks per week. Smoking is non-smoker, and he does regular exercise. But what is more striking is the HbA1c level. If you can see, the HbA1c is quite high, it's 9.7. You have fasting of 218, and his PP has been 236 milligram per deciliter. Previous history of hypoglycemia is not there, and there is definitely dyslipidemia because the LDL cholesterol is 188 milligram per deciliter. eGFR has been 68 ml per minute per 1.73 meter square, and microalbuminuria is there. It is 200 milligram per 24 hours as the urinary albumin excretion. So, patient has been diagnosed with increased ACVD risk because of the hypertension, dyslipidemia, and also microalbuminuria. He has been advised to adhere to a healthy diet, regular exercise, and physical activity also. The challenges with the previous medication was that the patient is already on good doses of antihypertensive. Patient is on full doses of statin. Cardiac drugs were also prescribed in combination of OADs, and the patient is on metformin 2000 milligram per day, liraglutide 1.2 milligram per day, empagliflozin 25 milligram per day. So if we actually evaluate the drug history, the patient is already on a very good drugs. The patient is on SGLT2 inhibitor, metformin, and GLP-1 array, along with the good dose of statins and ARB therapy. Primary challenges identified were, but despite metformin full doses, liraglutide, and empagliflozin, the glycemic control is poor. Fasting is high, PP is also high, and HbA1c is also high. And subject has hectic work life and fears insulin initiation, and fears of insulin initiation is there because he thinks that probably it will be more stringent for the lifestyle what he is continuing at this present moment. He travels often and unsure about taking insulin on fixed time of the day. So now let us discuss what the guidelines tell about initiation of insulin therapy as per the ADA 2024. If injectable therapy is needed to reduce A1C, the recommendation is that first we should consider giving an injectable GLP-1 or a GLP-GIP array in most individuals prior to insulin therapy. But if patient is already on GLP-1 array or GLP-GIP combination, it's appropriate to start insulin. For example, this patient is already on metformin, empagliflozin, and also GLP-1 array. So definitely the HbA1c is more than 9%. So we intend to start with an insulin therapy. And the best insulin therapy to start at this point is to add a basal insulin. So the other indication of starting insulin therapy, we all know that when insulin is the first injectable, if there is an evidence of catabolism, symptoms of hyperglycemia, A1C is more than 10%, blood glucose is more than 300, or are very high, or diagnosed with type 1 diabetes. So in those scenario, instead of waiting for starting with GLP-1 followed by insulin therapy, you can straight away go for an insulin therapy also. So there has always been a quest for an ideal insulin, and that I have already discussed in my first slide. Transitioning away from first generation basal insulin analog is also important, and delivering into the realm of ultra long acting basal insulin is the current concept. So what is the quest for an ideal basal insulin? I have already told that basal insulin is not a new concept. It has been there from the time of NPH insulin, but we always search for a better, flatter, and longer basal insulin, and so also the basal insulin has evolved. For example, initially it was NPH, then the first generation basal insulin, and then the second generation basal insulin. We want basal insulin to be absolutely peakless and flat. We want minimum glycemic variability, and we want a longer duration of the basal insulin, more than 24 hours, to allow for dosing flexibility. And we know that isolation of the insulin is by Banting and Best way back in 1921-22, followed by there were animal insulin preparation. But the three important landmark in basal insulin were NPH, glargine and detimer, glargine U300 or degludec. So the half-life varies. Accordingly, we call it as NPH or a first generation or a second generation basal insulin. For example, for NPH, the half-life is 5 to 10 hours and the variability is very high. Whereas the first generation basal insulin like glargine U100 and detemer, we have the half-life of 12 to 19 hours and the variability is medium. For longer acting glargine U300 and degludec, we have half-life of 24-5 hours and variability is very low. Insulin degludec PK/PD profile, it's almost flat and has a flat profile across a 24-hour profile. Insulin degludec efficacy, if we see, there is a nice study by Dr. Jyotidev et al. And Dr. L.S. Murthy and Tirthankar Chaudhary et al. That is the TRUST study. TRUST study, what they have done is that patients with type 1 and type 2, around 1,000 patients they have included. They've started on insulin degludec over and above the standard care of practice, and they've tried to see the visit 1, visit 2, visit 3 and visit 4 HbA1c level. What they found was that the HbA1c has declined from baseline of 9.6 to minus 1.8 at the end of 6 months or the end of 12 months, and the fasting blood glucose has also reduced significantly, around 64 milligram per deciliter. There is a significant reduction in HbA1c and FPG in 1 year of degludec treatment. Transitioning away from first generation basal insulin analog, so I'll discuss how you should transition from first generation to the second generation. Then on the subsequent slide, we'll discuss how the difference of two second generation basal insulin are. So transitioning away from first generation basal insulin analogs, we have insulin degludec, onset and duration of action. Onset of action, degludec is around 0.5 to 1.5 hour, whereas for degludec, for the glargine, the onset of action is around 2 to 4 hours. Duration of action for degludec, it is 42 hours, and for glargine, it is 22 to 24 hours. So degludec has a faster onset of action and prolonged action profile compared to glargine U100. Intraday, within day glycemic variability, degludec versus glargine U100. I think there are some slight problem because the graph is not coming properly, but just to highlight that within day variability among the degludec versus glargine, the intraday variability is very high with glargine U300 when compared to the degludec. So lower within day variability and better round the clock coverage is there with the insulin degludec compared to glargine U100. Regarding inter-day glycemic variability, day-to-day glycemic variability, also the results are similar. The degludec has got very lower day-to-day variability with degludec compared to insulin glargine U100. Lower glycemic variability may reduce the risk of hypoglycemia, and it has been shown that with the use of degludec, the fasting plasma glucose drops down significantly and achieves the target range. So that's the concept of probably the fixed fasting first. So whenever we are using the degludec, not only the fasting comes down, the whole postprandial and everything comes down, but it doesn't go to hypoglycemia range. It is well maintained with less intraday and interday variability and less glycemic variability. Coming to time in range study, that is the switch Pro RCT, where degludec versus glargine has been compared in terms of the time in range with the CGM, and it has been shown that the estimated treatment difference is a significant 1.43% or 20.6 minutes per day in favor of degludec compared to glargine U100. That means every day more than 20 minutes with more than 20 minutes one will have time in range when degludec has been used in comparison to glargine. Mean TIR has been 72% for degludec and 70.68% for glargine U100. Insulin degludec safety evidences, degludec versus glargine U100. Evidences we have BEGIN study, we have Swiss 2 study, we have DEVOTE trial, we have U-Treat type 2 diabetes trial, where they have clearly shown that in comparison to glargine U100, degludec has significantly lower overall hypoglycemia, reduction of the nocturnal hypoglycemia, and reduction of the severe hypoglycemia also. So consistently proven hypoglycemic benefit with degludec in comparison to glargine U100. Degludec achieves the target safely. So this is the post-hoc analysis of Swiss 2 trial, where type 2 diabetic patients, 721 patients, has been given either degludec or glargine U100, and then they were crossed over to either degludec or glargine subsequently in the next 32 weeks. One can achieve lower glycemic targets with degludec before incurring an equivalent hypoglycemic risk. Regarding the flexibility of the timing, insulin degludec is highly flexible. It can be given 8 to 40 hours flexibility is there, whereas glargine U100 you do not have flexibility. So if you are giving at a particular time of the day, try to give it during that time of the day in subsequent days. But when administration at the same time of the day is not possible, I think the role of degludec comes, where you can have absolute flexibility in giving any time of the day to achieve the similar fasting and the glycemic profiles. So degludec versus glargine U100, degludec has definitely an edge over glargine U300 because of its faster onset of action, longer duration of action, lesser glycemic variability both interday and intraday. Efficacy wise, it is definitely better in terms of the improvement in time in range, proven safety profile in RCTs and real world evidences. Delving into the realm of ultra long acting basal insulin, now we have discussed the quest for basal insulin, then we have discussed the newer basal insulin, that is the generation 2 basal insulin, specific attention to degludec when it was definitely superior to glargine U100 or the first generation basal insulin. Now let us compare the degludec versus glargine U300, both are second generation basal insulin. Now if we compare head on regarding the pharmacokinetic properties, the onset of action and the duration of action, for degludec it is 0.5 to 1.5 hour the onset of action, whereas for glargine it is 2 to 6 hours is the onset of action. Duration of degludec is more than 42 hours, whereas glargine U300 is 30 to 36 hours. So degludec has definitely a earlier onset of action and the prolonged action compared to glargine U300. Efficacy wise, A1C reduction, degludec versus glargine U300 provided a greater reduction in HbA1c when compared to glargine U300. So end of the treatment dose minus 0.3%. HbA1c change from baseline to 6 months has been statistically better with degludec compared to glargine U300. Fasting plasma glucose reduction also in this particular study, which was published in Diabetes Care in 2018, it has been shown that the degludec has got a better fasting plasma glucose compared to the insulin glargine U300. Within day glycemic variability or the interday glycemic variability, degludec versus glargine U300, degludec had approximately 40% lower within day variability in glucose lowering effect compared with glargine U300. So this is the degludec 0.4 units per kg, whereas glargine U300 0.4 units per kg. The intraday glycemic variability is better with degludec compared to glargine U300. Interday glycemic variability, when degludec has been compared with glargine U300, it is better with degludec compared to glargine U300. Hypoglycemia confirmed study data from the real world evidences, where degludec has been compared with glargine U300. So insulin naive patients who have been given degludec versus glargine U300, and 30% lower rates of hypoglycemia with degludec versus glargine, and significantly lower proportion of patients experience more than one episode of severe hypoglycemia with degludec versus glargine. So degludec has shown a significant lower risk of hypoglycemia versus glargine. So the trials which I am showing, it has clearly shown a better interday, intraday variability and a lower risk of hypoglycemia with insulin degludec. Dose time flexibility, definitely the card tilts towards degludec because the flexibility is up to 8 to 40 hours, whereas for glargine it is plus minus 3 hours. That means within 6 hours you have to give better flexibility with degludec. Degludec is more potent. I think there are studies which shows that the glargine U300 has almost 30% lower potency versus degludec. That's why you require some increased amount of doses with glargine U300. So glargine U300 requires 20% extra doses, and that has been shown in the RSSDI clinical practice recommendations also. Glargine U300 requires 20% extra doses. Better adherence with degludec, the confirmed study versus glargine, likelihood of discontinuation of basal insulin treatment in patients who initiate treatment with degludec or glargine 300. 27% lower risk of treatment discontinuation was demonstrated with degludec versus glargine U300. So if we compare the second generation basal insulin, action wise, it is faster onset degludec and the longer duration. Variability, both the intraday and interday variability is less. Safety wise, hypoglycemia chances are less. It requires lesser doses compared to glargine U300. So summarizing, the ideal insulin, the quest is always there, and we'll get some more longer acting insulin in the near future also. But till this time, we have two important second generation basal insulin. One is the degludec and glargine U300, and degludec has definitely proven its benefit in terms of the efficacy, safety, and hypoglycemia compared to glargine U100 or the first generation basal insulin. And in the second section, I have clearly shown with all the data of confirm and the other real world data that degludec has got definitely edge over glargine U300 in terms of the efficacy, safety, and the potency and the total daily dose. So with that, I'll conclude. Thank you for the patient hearing.
Dr. Ashok, Dr. Alok.
Am I muted? Sorry. So, dear friends, it's my great honor and pleasure to thank Sambit for his great talk, and we'll be coming back to the discussion after the second talk. And it's my now honor and great pleasure to invite Professor Dr. Abhay Shah to give his deliberations on a very important topic, a newer insulin, the case-based discussion on a newer insulin, which I take as for the first time available in the country. Professor Abhay Shah is MD and DM Endocrinology from the AIMS, Delhi. He was the professor and head of the Department of Endocrinology Metabolism at the Apollo Hospital, Bhubaneswar, organizing secretary of huge conferences, successful conference, ESICON 2018. Before that, he had done in 2012, an obesity meeting in 2016, co-organizing secretary for the main ESICON in 14 and 2016. And he is the recipient of the Rajdhani Gaurav Award and many awards. Dear friends, it's my great pleasure to present to you my dear friend Abhay, Professor Dr. Abhay Shah. He had been the professor of endocrine metabolism, head of the department at the famous SOM Hospital. And now I present to you Professor Abhay Shah for his talk on this newer insulin case-based discussion regarding the co-formulation IDEGASP. Abhay, all is yours.
Yeah, thank you, sir. I'm sharing my slides first.
To Stuti, or you are sharing now, or Stuti will share?
No, I'll share, sir.
Perfect. Yeah, it has come. Just make it full screen, Abhay.
Yes, sir, yeah.
Full screen.
So now it is full screen, sir?
No, not yet. Yeah, now full screen. Now full screen, Abhay.
So thank you. At the outset, I'm thankful to Alok sir and also Ashok sir and the whole team for giving me this opportunity to discuss this topic in front of this August gathering. This is navigating diabetes care. This is a case-based insight to on IDEC aspect. So we'll discuss a case. Mrs. Savita, she's a 52-year-old entrepreneur having sedentary lifestyle, comes for consultation with complaint of tingling in the foot, frequent fatigue, and lethargy, and has challenged challenges in adhering to the advised diet, and is just concerned about her busy lifestyle and also treatment regimen impacting his day-to-day activities. Motivated to adhere the physician's advice to bring her diabetes under control, and she actually don't want to continue or don't want to start insulin. And now if you see the medical history, patient is taking moderately adherent to diet and exercise. Dinner is the major meal for her. History of actually GLP-1 receptor agonist use 1 year back, but again stopped due to GI side effects. Now patient is taking sitagliptin 100 mg OD, metformin 1000 twice daily, empagliflozin 25 mg, and both the parents are diabetic and mother is having CKD. And you will see the patient's recent parameters. Then fasting is 142, PP is 168, HbA1c is 9.8, not arterial control, and post lunch is 148. Again, post dinner is 284. That means our dinner is too heavy. And renal parameters showing creatinine is normal, and LDL is high, 126. Her body weight is 62 kg with a BMI of 26.5. Blood pressure is normal, and she was diagnosed type 2 diabetes 12 years back. She's a non-smoker and non-alcoholic. So how do we manage this case scenario? Add another OHA, or we should initiate insulin. That if you see that what clearly, this is a study which has clearly shown that if you are adding multiple OHs, probably the efficacy of treatment gradually comes down. Some from 1 to 2, if you are going, again your HbA1c reduction is less. If you are going 2 to 3, again less, and if you are going 3 to 4, probably that will be further less. So that shows that as the sequential admission or administration of OHA, usually the efficacy of subsequently OHA comes down, and HbA1c lowering property also comes down. So it is always wise, if someone is on multiple drugs, not controlled, instead of starting OHA, if you are going for insulin, probably we are giving the best thing to the patient. So again, our RSSDA 2022 recommendations for insulin initiation after 3 OHA, if you will see, insulin therapy should be considered in all patients who are failing to reach the target after even if 3 OHs. Clinicians must consider limitations of individual oral agents and their combinations in terms of quantum of HbA1c reduction. Again, it providers should avoid using of insulin as a threat or describing as it is a sign of personal failure or punishment should not be done. And therapeutic choice regimens, preparation, and the delivery device should be made through, and shared information decisions should be done with the patient. But the Indian realities which should be considered while choosing insulin therapy for effective diabetes management, if you see, the first Asian phenotype, we know that we develops diabetes early, at least 1 decade earlier. The progression of faster from the stages like pre-diabetes to frank diabetes become faster. Then there is a high level of, we have abdominal truncal obesity. There is increased insulin resistance even at low level of BMI, and the beta cell dysfunction occurs quite early and rapidly. Another important part is there is high carbohydrate is a very common Indian reality. If you see the STAR study, which classically we thought that probably the eastern part of India is actually taking much more carb. It's not true. Throughout India, everywhere the carb intake is high in the range of 68 to 70%. So again, that shows that probably this type of diet actually compels us for particularly increase our postprandial body glucose, and that is one of the important thing for particularly while managing. So the number of here in the 350,000 patients with the mean HbA1c of 8.5, mean fasting of 172 with mean PP of 253. This is how the postprandial contributes to the day. If you will see, probably we remain in a postprandial state for at least more than 12 hours to 14 hours. So if you will see that probably the night time only 6 to 8 hours we are remaining in the fasting state, and majority time we are spending in the postprandial state. So this postprandial increment, that PPG is actually very important. Again, additional overall glucose in the people's diabetes like basal hyperglycemia or postprandial hyperglycemia, that is important, and also this is the normally physiological exposure. So we know that this postprandial state is utmost important, and this postprandial state makes us actually prone for development of different diabetic related complications. So as you know, Indians have a high PPG excursion. It is important to have PP control right from the start of the therapies. Difference in the glycemic response in Asians and non-Asian people in diabetes while initiating basal insulin. We know that among the non-Asian people, this is the pooled analysis of 16 randomized control studies, which has clearly shown that the non-Asian people have actually very good control with basal insulin, whereas Asian people, where actually our carb intake is high, if we are starting insulin, basal insulin, probably the number of people who are getting control or HbA1c coming to the range is around quite less. That is 47% versus 39%. So again, Asian people having HbA1c high, having high carb content food is actually difficult to control with basal insulin alone. So what are the evidences? We have different evidences from the Indian studies like IDCI, DiabCare, A1C achieve, present and improve. All has clearly shown there is a significant postprandial rise in comparison to, along with the fasting and HbA1c. So that shows that probably we Indian as in toto, our prandial rise is very much high, which is probably the basal insulin is not an ideal insulin, which cannot take care this prandial rise of the blood glucose level. So the need for good PPG control is utmost important. Here, along with fasting, we want to control PP so that automatically the HbA1c will come down. So the result from meta-analysis showing increased PPG and fasting drives increase the HbA1c. PPG has a stronger correlation with HbA1c than fasting. That shows that when our baseline HbA1c is very high, at that time the fasting contribution is more and PP contribution is less. But as we are closing towards the normal HbA1c, that is monocetal, going normal, probably our PP contribution is much more higher in comparison to fasting. But here Vishabu should tell that our Asian studies has clearly shown that when even if the higher HbA1c or in lower HbA1c, always the PP contribution is higher in comparison to the fasting contribution. So the ground reality in India, that the impact survey, this is a survey which has taken among the doctors, 9 out of 10 HCPs prefer as a insulin therapy that would control fasting and postprandial both. What type of insulin one should consider for these patients? We usually see what is the postprandial rise. If postprandial rise is above 75 or more than 75, then probably rapid acting insulin is the first choice and second choice is the premix insulin, particularly 50-50. But if prandial rise is between 40 to 75, then premix insulin is the first choice 30-70, the second choice is premix 50-50. But if prandial rise is less than 40, then probably basal insulin is the first choice. The second choice will be the premix insulin. So the value of 74 and 40 why we've taken, so for the particular this postprandial glycemic excursion has actually calculation has been taken that way.
Dr. Niranjan Tripathi.
Moving ahead to the next insulin co-formations, we will see the biphasic insulins, biphasic human insulins, and we will compare.
Away continue.
Yeah.
Away continue.
Yes, sir. The biphasic human insulin, and if we compare biphasic analog insulin, probably there is in biphasic human insulin there is a shoulder effect, and the chance of development of later hyperglycemia is more. So this hypoglycemia can be avoided if you are using this biphasic analog insulin. So the advantage of people see the biphasic human insulin, both controls fasting and PP. It is simple and convenient, titrated based on the pre-meal blood glucose level. It can be given once or twice daily. But the limitation is there is lacks of mealtime flexibility. Also, there is opportunity for better PP control, and there is risk of hypoglycemia is less. People are using the biphasic analog insulin, then it can be given OD, BD, or thrice daily. Risk of hypoglycemia is less, better PP control, and mealtime flexibility is there. And the limitation is the opportunity for better fasting control, and that is lower, and also there is low risk of hypoglycemia is there. And if you are using this insulin degludec, and aspart combination, here the advantage is it can be given once daily or twice daily. better fasting control, low risk of hypoglycemia, lower amount of insulin requirement is there, and weight gain is found to be very less in those group of patients. So let us discuss this Idegas, the world's first only co-formulation insulin, where you have 70% is ultra long-acting degludec and 30% is ultra short-acting or short-acting aspart insulin, rapid-acting and aspart. These two insulin components don't interact in the solution and in the subcutaneous tissue, thereby retaining their individual properties. There are indices for holistic choice of insulin therapy. If we are discussing, then probably it should have low risk of hypoglycemia. There should be mealtime flexibility. The regimen should be simple. It should be convenient. The device should be very much convenient, better quality of life, and should be cost effective. On top of that, it should be efficacious. So if you see the probably IDEC as one of the prudent choice for particularly management of diabetes. What does the evidence says when you have to consider a co-formulation over basal insulin? So first we will discuss the efficacy, we will discuss safety, the quality of life, and what are the flexibilities. So it will compare the efficacy point of view, it will compare. There is a comparison to glargine U100. Fasting reduction, PP reduction is very good, and HbA1c reduction is also very good. That is percentage reduction in glycemic parameters. If you see Iglar U300, the fasting reduction is less in comparison to glargine. PP reduction is same, and HbA1c reduction is also good amount is there, or 8% reduction. But if you see the Idegas, the fasting reduction is better than glargine, PP reduction is better than glargine, and also HbA1c percentage HbA1c reduction is also higher in comparison to glargine U100 and U300. So again, if you compare glargine U100 versus U300 versus Idegas, then probably Idegas is superior in all those aspects, that is for the fasting, PP, and HbA1c control. And again, meta-analysis for the risk of hypoglycemia, you will see. So if you will see the overall confirmed hypoglycemia, there was no significant difference in the overall confirmed hypoglycemia between once daily Idegas to once daily basal insulin. Same thing, if you see the nocturnal hypoglycemia, the nocturnal hypoglycemia was significantly lower in once daily Idegas group in comparison to once daily basal insulin. So if you take overall 24-hour hypoglycemia, probably there is no difference, but nocturnal hypoglycemia point of view, Idegas offers better benefit in comparison to particularly the glargine U100 and glargine U300. Whenever we are switching Idegas from the glargine U100, what happened to quality of life? This is the change in the total DTR QOL score at EOS, that is the quality of life scoring system. At baseline, it was 67.3, which has increased to 70.6 at 26 weeks. So the quality of life improves significantly once someone is taking Idegas in comparison to the basal insulin. Again, the flexibility is dosing. So if you are using glargine U100, you can give any time, but every day you have to give the same time. If you are using glargine U300, there is a flexibility of 3 hours before and after injection. If you are using Idegas, then administration can be done with any of the major meals of the day with a gap of particularly between 8 to 24 hours. And it is Idegas is very simple. You start with 10 units, then administer with the major meal of the day, and or initiate 10 units Idegas with the most carb containing heavy meal of the day. Then you gradually the meal size, if meal size increases, or if you see despite of starting once daily, if you are not controlling the blood glucose, then you can shift to twice daily injection, from once daily to twice daily injection, and split response to dedicated the ratio in 2 doses. It does not have to be 1:1 split. So the switching from Idegas from glargine U100 to U300, the treatment preference, you will see the 78.8%, that is 79% people continue to the Idegas treatment preference, whereas people with diabetes preferred Idegas over previous therapy of glargine by 74%. So you will see that's from those who are already on glargine, when they are shifted to Idegas, probably they feel better, their blood glucose control is better, their HbA1c control is better, and also the risk of hypoglycemia is less. So that is the reason why probably the treatment preference are there with particularly people with diabetes. The practical aspect of co-administration with OADs and switching from basal to premix or basal bolus to Idegas, people see if Patient's profile for IDS as initiation, those who are uncontrolled need for safety and the flexibility of dosing, or those who are uncontrolled on basal insulin, developing unacceptable hypoglycemia, unacceptable weight gain, or need flexibility, or patient needs safety, specifically elderly with frail patients having hepatic impairment, renal impairment, having fasting condition or erratic meal style. Probably all those group of patients fits for particularly this Rhizotec group. So on premix or already on premixed insulin or basal insulin, if still fasting is poor, recurrent hypoglycemia, they need flexibility, you can go this premixed insulin. If someone is on once daily basal insulin, but having unacceptable variability, recurrent hypoglycemia, they need flexibility, they also can be shifted to Idegas. So switching to Idegas from other basal insulin regimen, how we are switching? If anybody is on basal insulin, OD or BD, then this, if you are switching to Idegas, probably this is 1:1 switch will be there, and doses further may be reduced with subsequent titration of the blood glucose level. And if someone is developing hypoglycemia, if someone is developing hypoglycemia, accordingly, you can titrate with subsequent monitoring of the blood glucose level. So once, what type of regimen, if you want to shift, if someone is on premix OD and we're shifting to Idegas, then we same 1:1 in the 1:1 ratio, you can go for Idegas. If someone is premix BD, then same 1:1 dose split over main meal, Idegas twice daily. If someone is on premix thrice daily, then you should go for total same doses and split into two divided doses, split into two divided doses, and give the main meal. So doses reduced by 10 to 20% for those who are experiencing hypoglycemia or HbA1c less than 8%. So twice daily, one basal, one bolus, you give same dose and go to Idegas once OD. Twice daily, one basal, two bolus, then you can go Idegas twice daily. If someone is taking 4 to 5 times, that is basal plus bolus, then Idegas 2 times and once aspart once daily is sufficient for those group of patients. Switching needs to be individualized based on careful consideration of the basal bolus doses, and close blood sugar monitoring is utmost important for those group of patients. So Idegas is a choice of insulin initiation because it has lower risk of hypoglycemia, it has very good mealtime flexibility, very simple regimen, convenient device, better quality of life, it is cost effective and found to be very much efficacious. So it is one of the best choice of insulin for those patients. So now, Savita, coming to our patient, Savita was started with baseline HbA1c started with Idegas 10. Over a period of 3 months, gradually the dose was increased to 18 units, and HbA1c was at baseline 9.8, and over 3 months it has come down to 110, 7.2%, and fasting come down from 140 to 110, and PP came down from 286 to 136. So insulin injection are not to be painful as presumed to be. The therapy has helped with not only a good blood glucose control, but is also very convenient and fits to everybody's lifestyle. So now this is a app. There's a WhatsApp chatbot service, which is actually that makes diabetes care easy because you can scan this. Anybody who want, they can scan this, and also you can send a hi and start chatting. And they can give any sort of things like diabetes insulin-related information, insulin user storage information, diet exercise tips, Indian dietary information, calorie and BMI calculator, medication reminder, or anything you want. They have their own 12 different languages which can give you or help the diabetic patient. So this is one of the initiation by Novo Nordisk for particularly people who are living with diabetes. So thank you. Now we can it's up to Ashok sir and Alok sir for particular.
Thank you. Very, very, very detailed and beautiful exposition of this new molecule, Idegas, in world's first co-formulation, which is poised to be one of the best. Has Dr. Sambit joined?
Good
Sambit?
morning, sir. Yes, I have joined, sir.
Sambit, good. Sambit. So
I'm
now
actually outside, so because of internet
doesn't matter.
instability,
I will ask the
switching
first
off.
question. I'll ask the
Yes.
first question.
No, sir, no problem.
Yeah, I'll start the first question. We have got few minutes for discussion. We'll take up one by one. You know, your talk on the insulin degludec was fabulous, and even new points I learned, which you said very subtly, but it was very, very well taken. I just want to make few things clear because there are large number of audience, almost 3,000 people have joined. Sambit, Dr. Sambit, I would like to know that when you say that insulin degludec is an innovative basal insulin, what are the newer properties that you are seeing in it that you call it an innovation?
Sir, thank you, sir, for that question. So, basically, the insulin degludec has been designed in such a way that it forms a multi-hexamer chain under the once it is injected. So, in the depot, it will form a long multi-hexamer depot, and once the zinc or the Pb ions are released, then one molecule will be released in a phase-wise manner, so that it creates a lot of. Hello.
Yes, we are
Yes,
listening.
sir. So that yes, sir. So that it will create slow release of the insulin into the circulation, and the half life is prolonged.
Absolutely. You see, that is one of the greatest benefits of degludec. It is longest half-life. How much you call it? 43, 42? How many hours now?
Yes, sir. It's 44 almost.
44 hours. 44 hours. Now I just want to ask you that, as you rightly said, it translates into great clinical practice. I'll give an example that we have always encountered, where you are also here. Now we send the patient morning for investigation, very long investigations away. In the hospital, I work in the medical college. In the hospital, you have all of you are in medical college, and by the time patient comes back from the investigation is very late. But you know the beauty of this long-acting insulin degludec that you can give it, whereas other insulin will think twice. So this translates into many clinical practice. I have used it when we send the patient going in the morning for investigation, takes a long time, comes back. We can still give the injection because of this flexibility. The second thing that what has appealed me most is I meet people taking insulin. We have a term called insulin distress. You know, taking insulin same time every day is a great distress. So therefore, this flexibility takes away distress. What do you think, Abhay, about this insulin taking same time, same day? It's a distressful situation.
Yeah,
And
absolutely, sir. Yeah. So actually, people ask me, lot of the people either they discontinue insulin or pursue the doctors are kindly change to the tablets. The reason is what we are telling. This is insulin distress. The insulin distress means the every day you have to take a fixed time. If you are
yeah,
taking the previous like Mixtard or all those, then probably your carb content should be fixed. Your meal portion should be fixed. Again, you cannot change your diet, or it's very difficult to actually shift or changing the dietary pattern. You have to actually calculate everything and fix that. So always it's a distress. So if we are using this newer insulin, probably there is a lot of flexibility, not only from the injection point of view, even if from the carb point of view, if you have taken a little bit, that can be taken care of, because the intraday variability is very, very less, particularly with this insulin, because we are going to the older generation insulins, their intraday variability and interday variability is very much high, which is significantly less with this newer insulins.
I'll give another example, Abhay and Sambit. Sambit, you know, in southern India, there are the daughter-in-law, son, or the some brother of the patient. They come back home, then give the basal insulin in the evening. You know, they cannot come back every time at the particular time to give the injection. So somebody's daughter-in-law, somebody's daughter, somebody's son-in-law, they come and give the injection. It is very difficult. And this flexibility, I have found works out very well. And Sambit, another question to you, that people have said that when they take degludec, I'm talking about doctors, few doctors confided in me, they have a smooth control. Do you agree with that, Sambit?
Yes, sir, absolutely. Because of the long half life, the fluctuation, both intraday and interday fluctuation, has been quite significantly lower, and the TIR is definitely better. So that's why the glycemic variability is less.
Absolutely. Abhay, you know that when we have this IDEC ASP, and it has been given, as you rightly said, it can be given in the second dose, it can be given as a double dose, twice a day, once a day. When you give the combination therapy, how does once a day work out? How does once a day work out? You know, combination therapy by antipotal, what do you give? You give IDEC ASP and the antipotal. you give tablets or what, or you also described giving something like Basal Plus. You give in the morning, you can give insulin aspart. You said that in your talk. You can give one injection of Idegasp. Morning you can give aspart in Basal Plus. So little bit dilate on it.
Yeah, actually, whenever we are starting this Idegas, it is always wise to start Idegas with the major meal. Major meal or high carb content meal, if they are taking, you should start with this and try to titrate and try to make the fasting control normal, and also see what is happening to the postprandial after that carb meal. And after 2 to 3 months, gradually you titrate the dose and fix the dose, try to fix the fasting. Once the fasting is controlled and if your postprandial after this carb meal PP has been controlled, you see what is happening to the HbA1c. If HbA1c has come down, okay. If HbA1c is still high, then probably you have to go for twice daily doses. So you can go morning or evening or 2 major meal, because like in East India, we always have a 2 major meal. So in this case, you can go for with 2 major meal, 2 doses of this Idegas. And if HbA1c has come down, okay. But in the lot of people where actually diabetes duration is very high, they need a short-acting insulin in between. So in that case, you can go 1 short-acting insulin and twice Idegas, which will almost a full-blown basal bolus. Or basically, we get 4 injections, 3 short-acting and 1 long-acting. So if you are giving 2 Idegas and 1 short-acting at lunch, probably it will be a total almost full basal bolus regimen will be there. And in that way, you can control the HbA1c.
How much time we have for the discussion now? How much time we have?
Sir, and 7 minutes.
7 minutes. So I've got 3 more questions to ask, and I'm also inviting questions from the audience. You can put in the chat box. I'll take up your question. The second question, Abhay, is a very pertinent question. You have highlighted it, but still, both as a degludec, that is called Tresiba in the trade name, and Idegasp, that is called the famous
Ryzodec.
Ryzodec in the trade name. There are 2 advantages which has been highlighted. One is freedom from hypoglycemia. So my question to you, how do Idegasp get this freedom from hypoglycemia? Then I'll ask Dr. Shambit, how does degludec get freedom of hypoglycemia? Very small. And
no, actually, sir, it's not freedom of hypoglycemia. The hypoglycemia is very, very less. As I have clearly shown, there is actually study in comparison to glargine U100, and also there is a study in comparison to glargine U300. What they have shown that if you take 24-hour hypoglycemia, then overall 24-hour hypoglycemia, there is no difference between both the groups. But if you see the nocturnal hypoglycemia, with particularly in this Ryzodec group, the nocturnal hypoglycemia has been reduced by almost 68%. So again, that shows probably because nocturnal hypoglycemia is one of the dangerous time. Once someone is developing at night, and that once someone develops some
most important is cardiac problem with the nocturnal hypoglycemia.
Cardiac arrhythmia, and that leads to a sudden cardiac death. So nocturnal hypoglycemia, if you are avoiding significantly, that is one of the biggest advantages of particularly using of this Ryzodec.
Yeah, I think Sambit, you'd like to say anything about the Tresiba?
Yes, sir. So the degludec has also, I'll echo what Dr. Abhay Sahu has told. So degludec has also shown lesser chances of hypoglycemia all throughout the day, and mostly nocturnal if we compare it with the fascination basal insulin like glargine U100. And also there are studies to show that in comparison to glargine U300, the glycemic variability interday and intraday is lesser, and the chances of hypoglycemia is also lesser. So both are correct.
I have got 2 questions more, but in the meantime, I'll request Professor Dr. Alok Kanungo if he has any question to ask. Alok? If not, I'll take over. The 2 questions left for me. You are muted, Alok. Alok, you are muted.
Thank you, Sambit and Abhay, for nice talk.
Very good.
And one thing we have always experienced that Tresiba or Ryzodec are working wonderfully well, and they give a sense of well-being to the patient, and a doctor can sleep in the night because lack of hypoglycemia or early morning hypoglycemia is very minimal or less, as Abhay has told and Sambit has told. So these drugs are the drugs of the future. because this technology it will stay long and long enough until I don't think there will be new molecules in insulin and other things because now the attention has been shifted to GLP-1. So this will stay long and they are very safe molecules to be used.
Thank you. No, I just want to tell you one thing because it's a clinical meeting. So, Sambit and Away, please excuse me for a very raw example. I have found a great clinical benefit.
As
Away.
JJ Boss has actually put a question that Bright study has shown there is no differences. Of course, right? Because some of the studies from the Glargine U300, they have also shown that Glargine U300 and Glargine and this Rhizodec, they both are same from HbA1c control point of view. Both are same from the weight control point of view. But what they found in the Bright, they have shown that probably during the titration phase, the hypoglycemia is less with Glargine U300 in comparison to this Degludec. So what they found, because the initial 3 months is the phase where actually people titrate, and during the titration phase, if you develop hypoglycemia, a lot of the people discontinue insulin. What they found in the that during the titration phase, the hypoglycemia is less in Glargine U300 in comparison to this particularly this Degludec. So Dr. Jejabas has put that. So both the newer insulins are very good, and both has risk of hypoglycemia is very less, and both can be used. But the advantage of Rhizodec over this Glargine U300 is that it works both on fasting and PP, that acts as a basal plus regimen in comparison to Glargine U300. So that is the biggest advantage of Rhizodec. But from the Tresiba and for Glargine U300 point of view, then probably both are same, with some studies supporting Tresiba and some studies supporting actually U300 also.
There is one more comment by him that the Rhizodec should be given preferably before breakfast or with breakfast, with lunch, preferably not by night.
Yes, actually that is also true, because if you are giving once, probably the major meal is the best time where you should give major meal. So this is up to the patient, because normally for our Eastern people, probably breakfast or some people lunch as the major meal. So definitely what Jejabas is telling is absolutely right. You can give in that time.
Correct. There is another clinical benefit which I would like to highlight. Alok, we have time. 1 minute I'll take.
Yes.
This clinical meeting. I have found in the government meetings, we supplied not the high-end insulin. Now we are supplying the high-end, these ones we're discussing today. Rhizodec and Degludec is supplied in the CGHS and government supply. That time it was not supplied. There are very high officials who take alcohol, and they forget to take food. One such officer went to the washroom to take the injection, took the injection. He was little inebriated. He totally forgot to take the meal. And his wife rang me up in the night saying that after reached home, he's sweating. So this flexibility of this insulin that you have described, Sambit, and also you have described away to a certain extent, is a great benefit clinically, practically. Am I correct, Alok? You can give it before, after, in between, and there's a window period of 43, 44 hours. So that gives a greater opportunity to be used. Last but one question to Abhay from my side. Abhay, there is something about conclude, we'll take it up later. I just want to ask you that when you compare it with the other premix, the shoulder effect, the need for taking the food at the same time of the day, are they negated?
Yeah, absolutely. Because if you are using in comparison to the older generation insulins, human insulins, that the shoulder effect is well taken care of if you are using this aspart insulin, because the aspart duration of action is only 4 hours. After that, there will be no action. So that will be taken care of. Again, we have discussed the flexibility point of view. Taken, of course, yes, because the study with particularly Tresiba glutation, if today morning you have taken 8 a.m. and next day you are taking before dinner, the HbA1c reduction is same. There is risk of hypoglycemia is also not increasing. So there is, as you have told, at one dose was given at 8-hour gap and another given after 40 hours. Still, the HbA1c control is similar. There is no difference, and the hypoglycemia is not increased. So that shows the boost of confidence, and of course, there the flexibility. This flexibility is there with particularly this Tresiba or Rhizodec. which is not there with other particularly long-acting insulins.
Fantastic.
Because if you see Glargine U300, there is a flexibility of 3 hours. It's not more than that.
Plus
If you are,
minus 3 hours.
if you are
Plus
going
min-
with
plus
Glargine
minus 3
U100,
hours.
Glargine U100, you have to go for same time of the day plus minus 30 minutes. So looking at that, probably the highest flexibility is particularly this either Tresiba or Rizodex.
Yeah, I think the last question to Sambit. Sambit, there's a question put by JJ. He is asking about the interpretations of conclude. He says that it is not final about the hypo benefit. Sambit, are you there? I think JJ, I'll take, yes, Sambit.
Abhay?
Where you like to highlight on that? JJ has put JJ's question, no? He has put another question on the chat box asking that the conclude vis-a-vis hypo benefit.
Yeah. So as yeah, because actually as I have clearly shown, this is that some of the studies as actually showing that benefits from particularly giving benefits to the Glargine U300. Some of the studies are showing there is benefits from particularly hypo point of view. There is benefits from actually from the Tresiba point of view. But both these two generations, second generations insulin are very good. They can be used safely. The risk of hypoglycemia is less in comparison to particularly this older generation insulin. So they both are safe. So you cannot tell that only Tresiba is good and Glargine U300 is actually that is not that much. Both both are same. That is from the hypoglycemia point of view, because they have their own studies. They have also supported that the hypoglycemia is less in particular Glargine U300 in comparison to Tresiba. But the titration phase hypoglycemia is less with Glargine U300 comparison to particularly the maintenance phase.
Thank you, Abhay. Thank you, Sambit. Thank you, Alok. We'll pass on to the next part of this particular session, and that will be moderated by Dr. Alok Kanungo. And I'm delighted to welcome now the Professor JJ Mukherjee, my very dear, JJ. JJ, welcome. And I must tell you one thing. I must announce it to the world that JJ's daughter has been going to become a very famous dermatologist of the country. Welcome, JJ. With this happy note, I hand over to Alok to take forward this session.
Thank you, sir. Good morning, sir.
Good morning.
Alok, please carry on.
Hello, JJ and Ipsita. Welcome to this second part of...
Ipsita, let me see your face, my daughter. Ipsita, where are you? I'm not able to see your face. Anyway, Ipsita has joined. Ipsita is my juniors, my 1 year junior, very famous Professor Hudan Mishra's daughter.
Namaskar, sir.
That is not an introduction. Ipsita herself. I'm happy to see you. Over to JJ. Yes.
So you are able to see me?
Yes, now I can.
Thank you, sir.
Thank you. Alok, start.
Basically, it mimics the human intelligence and involves in the simulation of human cognitive processes such as learning, listening.
I think something is happening. Tuti,
There's an overlap.
Overlap. So there's some overlap of the voice of Dr. JJ.
Somebody's mic was on. We've muted.
No. Please make all of us will make our mics off. Please mute after 1 second, all of us.
So, dear friends,
Alok on the speaker.
Delegates, dear faculty members, Professor Ashok Das and others, we are now going to the second part of Novo Nordisk's sponsored academic session on GLP-1 receptor agonists. It is a very, very important session. I'll take 4-5 slides to introduce the topic, and then the topic will be dealt by Dr. JJ Mukherjee on exploring GLP-1 receptor agonist beyond glycemic control, the cardio-kidney metabolic benefits. And the second talk will be by Dr. Ipsita Misra, the upcoming new generation endocrinologist from Cuttack. Do GLP-1 receptor agonists hold the promise of becoming the next standard of care in diabetes and cardiovascular management? Stuti, my first slide, please. And as we know, the crucial role of early start interventions for diabetes and weight management is very important. Next. Next. We know the whole world is growing in population and the population of diabetics are also increasing. You can see in the Asia Pacific area, we have Southeast Asia 90 million and Western Pacific 206 million, Europe 61 million, and Middle East and North Eastern Africa is 73 million, and plain Africa is 24 million, and North America 51 million, and Central South America is 32 million. The millions are just numbers, but there is similar numbers waiting to be diabetic. And people with diabetes in the world in 2045 will be 783 million. You just imagine what will be the mammoth proportion of social and health burden for this world. Next, please. Alarming Indian picture with more than 100 million people living with type 2 diabetes. Diabetes with 101 million and number is every day increasing, and pre-diabetes is 136 million and the numbers only diabetes is 101, but if you look at dysglycemia 236 and hypertension 315, they are all corroborators, or abdominal obesity 351 millions, and like that HDL and other things, because diabetes is the primary cause of all these complications, and once diabetes is well controlled, all these things will come down. Next, please. So, overlapping risk factors of diabetes, obesity, and cardiovascular disease is very much known to us. One end is type 2 diabetes, the other end is obesity, and the last is CVD. If you look at smoking, obesity, history of gestational diabetes, race, and ethnicity play an important role, and also physical inactivity, which is now treated as the most important factor for causing all these metabolic disorders, is very important, of paramount importance. High blood pressure, age, genetic factors, high blood lipids, and PCOS add to the problem of obesity, CVD, and type 2 diabetes. And if you look at the sleep patterns, socio-economic status, and medications or other diseases, and mental health, which is seen more frequently nowadays, are all adding up to this problem. Next, please. Sir, if weight reduction improves, diabetes control improves. It has been observed that if weight reduction improves, the HbA1c is also reduced and fasting blood sugar is also reduced. And as you know, 15% of weight loss or 15 kg and more of weight loss is almost going for reversal of diabetes in younger diabetes, 35 or 40 years and below, not for elderly. Next, please. Greater weight loss was associated with greater reduction in HbA1c and fasting blood glucose. Next. So, diabetes remission clinical trial or direct showed some important and very interesting results. Weight management program or intervention versus best practice care by guidelines. It was tested and it was found that remission at 2 years for every kg weight loss, 1.25 chances of odds of diabetes. Greater weight loss led to greater proportion of patients achieving and maintaining remission. We may not have reversal, but remission is a clinical achievement that many of us are achieving now, and that is possible by reducing the weight. And there are drugs which are now controlling diabetes and controlling weight and reducing weight to a greater extent. Next, please. So look ahead tried benefits with 10% weight loss have been studied, and primary and secondary outcomes have been studied, and this favors weight loss to the greater extent. 21% low risk of composite outcome within 1 hour, 1 year. If you reduce weight, you must have marked that you feel much better. Next, please. So these are the things to be discussed. Blood pressure, triglyceride, HDL and LDL. Weight loss imparts reduction in CV events and risk factors, and it has been through the look ahead data, and it has proved that all these things, reduction of blood pressure, triglyceride, HDL and LDL, is helping in reducing cardiovascular events. Next, please. So loss of 5% of body weight in the year following diabetes diagnosis was associated with improvement in risk factors and 48% lower hazard of CVD at 10 years. It's a great achievement for the clinicians now. Next. So weight loss is mandatory, at least 5%, reduce hypertension and hyperglycemia, 5 to 10% prevention of type 2 diabetes, NFLD, PCOS, and dyslipidemia. And if we achieve 10 to 15%, CV diseases, stress incontinence, NAS, OSA, and obstructive sleep apnea, GERD, and knee osteoarthritis is also reduced. And more than 15%, but there is a caveat, it should be younger age, 35 to 40. Type 2 diabetes remission, CV mortality, and heart failure preserved ejection fraction is maintained. So remission, now many people with 60 years, 70 years are coming that I want to go for remission. Please don't try that. It should be younger people where still some beta cells are preserved. Next, please. So there is an upstream approach. Weight loss promotes glycemic control, impacts cardiometabolic risk factors, disrupt underlying pathophysiology, and reverse or slow down disease progression. So it prevents micro and macrovascular complications also. Next. So thank you, dear panelists, and thank you, Professor Das. I will now invite Professor J.J. Mukherjee, who needs no introduction for this audience, august audience, the most academically oriented, astute clinician, and a lot of interest on academics and spreading knowledge. Professor J.J. Mukherjee, please. And your talk is Exploring GLP-1 Receptor Agonist Beyond Glycemic Control, Cardio, Kidney, Metabolic Benefits, CKM, not CKD. So Cardio, Kidney, Metabolic Benefits. Dr. J.J. Mukherjee, please.
Stuti, can you go?
Yes.
Hello, good morning. I'm Dr. Mukherjee from Kolkata. It's such a pleasure to be back again talking in NUCD 2025. And my respect and thanks to Professor Alok Kanungo for inviting me for this meeting. Very nicely organized, very nice topics I saw. What I have been asked to speak on today is exploring GLP-1 receptor agonists beyond glycemic control. A topic you must have heard a few times, but I will try to, discuss it a little bit more detail so that you can carry some new points home. And I'm going to focus on the cardio kidney metabolic benefits. You must have heard the CRM, the cardio renal metabolic benefits, but this is now CKM, cardio kidney metabolic benefits. So at 20 minutes, I'll try to finish in 15 to 18 minutes so that we can have some time for question answer later on. So when we say CKM, what do we mean? What is the cardiovascular kidney metabolic syndrome? It's basically a systemic disorder characterized by pathophysiologic interactions leading to a high rate of adverse cardiovascular outcomes. We all know that majority of the people with type 2 diabetes have a cardiovascular endpoint. So the the purpose of treating diabetes is to prevent complications. The foremost among them is cardiovascular complications. So they develop chronic kidney disease, cardiovascular system is involved, there is diabetes, there's hypertension, there's dyslipidemia. As you can see, it's a very common pathway. They all interact with each other, leading to multi-organ dysfunction. So the CKM syndrome includes those at risk for CVD or CKD due to metabolic factors, or those with already existing cardiovascular diseases. So, like, it's not a new term, CKM syndrome. CKM syndrome is people with metabolic disease having cardiovascular and renal manifestations. Now, of course, burden of CKM is increasing worldwide for many reasons. The prevalence of diabetes, hypertension, dyslipidemia is increasing. People are living longer. Blood pressure is getting more common. Dyslipidemia is getting more common. So naturally, the burden is increasing. And conditions of these CKM systems affect more than 1 billion people worldwide. In fact, hypertension alone is prevalent in more than 1 billion people in the world. Now, 1 in 3 persons with type 2 diabetes have cardiovascular disease. And as I said just now, cardiovascular disease is the leading cause of death in people with type 2 diabetes. Now, diabetes and or hypertension together or independently account for almost 75% of the people who have end-stage kidney disease. So we need to do better in controlling not only diabetes, but also hypertension. And in people with advanced chronic kidney disease, again, not most of them have a renal death. More than 50% of them have a cardiovascular death. So in the end, it's always a cardiovascular event which is happening. And what is the key driver of the CKM syndrome? Of course, there is hypertension, there is dyslipidemia, but at the bottom of metabolic syndrome is obesity. There's lipid and glucose accumulation, which causes glucolipotoxicity, has an adverse effect on the beta cells. There's insulin resistance, which leads to beta cell exhaustion. In the initial part, as you've all seen, onset of diabetes, there is insulin resistance goes up and the beta cell starts to compensate. But comes a time when insulin resistance is same, but beta cell starts failing. So there's beta cell exhaustion, and there's an underlying inflammation in people with obesity, with increased fat, ectopic fat, normal fat. There's increased inflammation, which basically promotes lipolysis, which is increases fatty acid reflux to the liver, which enhances gluconeogenesis and worsens glucolipotoxicity, hyperglycemia, and beta cell dysfunction. So at the root, there is adiposopathy. That's what it's not a new term. We've been using it for quite some time. And this is again in another form of seeing the pathophysiology of cardio-kidney metabolic syndrome. There's excess or dysfunctional adipose tissue. So there is increased adiposines and cytokines, which causes ectopic fat deposition, metabolic fatty liver, non-alcoholic fatty liver disease. It's called MASLD now, which also potentiates. And in the end, the common pathway is inflammation, oxidative stress, insulin resistance, and vascular dysfunction. This in itself can cause, and this is also caused by hypertension, dyslipidemia, metabolic syndrome, and diabetes. And this leads to accelerated atherosclerosis, myocardial remodeling, fibrosis, and cardiac dysfunction. Excess fat tissue causes glomerular hyperfiltration, which ultimately leads to glomerulosclerosis, tubular interstitial fibrosis, progression to chronic kidney disease. So in the end, fatty tissue is at the core of cardio-kidney metabolic syndrome. Are there stages to it? Yes, like every other syndrome, there are some stages. Stage 0, of course, is no risk factors. It's a focus on primordial prevention and preserving CV health. And this is the basic things that what you and I and everybody who's listening to this seminar and webinar should be doing. Adequate sleep. I don't know what is adequate sleep. The definition keeps changing. For age-wise is different as to how many hours you should sleep. Just ask yourself, are you having adequate sleep? I, for one, am not. Healthy diet, we should need to. Exercise. Again, many of us fall short with regards to exercise. We should think about it. We should get annual health checkups done, and if blood glucose, weight, and BP are not in healthy range, we need to do something about it. Get adequate hydration, avoid tobacco, and also excess alcohol. This is followed by stage 1 and stage 2. What is stage 1? Stage 1 is the deposition of excess or dysfunctional adipose tissue. So this is people being overweight, BMI between 23.1 to about 24.9, and of course obesity, BMI more than 25, which leads to abdominal obesity. We all know that amongst the various fats, there is subcutaneous fat, visceral fat, and ectopic fat. Visceral fat is the one which is the key driver with regards to all the pathophysiological events, which I just discussed a couple of slides ago, and that leads to impaired glucose tolerance. Stage 2 is when the metabolic risk factors have established themselves and there is beginning of CKD, chronic kidney disease. So hypertension has now come on board. Hypertriglyceridemia, low HDL cholesterol has come on board. People have developed metabolic syndrome, and some of them may have IGT, IFG, prediabetes or type 2 diabetes, and there's moderate to high risk of chronic kidney disease. Then comes stage 3, which is subclinical CPD or CKM syndrome. There's no clinical event as of now yet, but in stage 3, but they have subclinical atherosclerotic cardiovascular disease, subclinical heart failure, and then the stage 4 is clinical CVD, CKM syndrome, CHD, heart failure, AFib, stroke, and peripheral arterial disease. So targeting weight loss in CKM management is what is important. So we need to decrease BMI, which leads to decrease in blood pressure, blood lipids, blood glucose, insulin-resistant inflammation. And whenever we talk about weight loss, there should be a minimum threshold of more than 5% weight loss is required to have a positive impact on glycemia, BP, and lipids. And if you lose a weight of 15% or more, it may help to mitigate some of the CKD complications. So now that we know what is CKM syndrome, which I said is not a big deal, is basically cardiac, kidney, and metabolic syndrome all coexisting together. And we all know that most of the people with type 2 diabetes do have, majority of them have hypertension, dyslipidemia. So that puts together the higher risk of cardiovascular disease. So now where do we fit in GLP-1 receptor agonists here? Does it mean that if you do not use GLP-1 RAs, you are not going to have any impact on CKD syndrome? No. You should have, as I said, good diet control, good exercise, get good glycemic control, good blood pressure control, get lipids under control, get them off smoking. You're already on a good way down the path of preventing or reducing the burden of CKM syndrome. But then there are medications now which can, on top of this standard of care, can help you in mitigating some of the CKD pathophysiology and clinical events. So what are the various GLP-1 receptor agonists currently licensed in the world as of December 2024? Exenatide LAR, those of you who are interested can look at the years when they were licensed in US and Europe. I can't go through all of them for a short of time. Then liraglutide, dulaglutide, lixisenatide, albiglutide, semaglutide, and semaglutide oral, which is available to us in India. Albiglutide has been withdrawn worldwide, so I've tipixed it out. It was withdrawn in 2017. And amongst all these, the ones which have a green circle are available to us in India. So surprisingly, they're expensive medications. We don't use too much of them. But if you see, so many of them are available to us. And of these, liraglutide, dulaglutide, and oral semaglutide is what most of us who are using these molecules tend to use. And liraglutide is slowly getting phased out. So the most of the competition now is between dulaglutide and semaglutide, and amongst them, semaglutide is unequivocally, I'm not going to share those slides with you, is unequivocally better with regards to glycemic control and weight loss in head-to-head trials with dulaglutide. So GLP-1 receptor agonists, of course, get blood glucose control. I mean, HbA1c comes down to what degree? Now, this might vary from study to study. This is the latest network analysis. If you want, you can take this reference down. There's a DOI. You can get it, you can download and have a read. This is a forest plot of the effect size between GLP-1 RA and placebo for HbA1c measured in percentage. Because if you see various trials separately, if you see the semaglutide trial, dula trial, lira trial, some of them show a little bit more reduction in HbA1c. But when you do a network meta-analysis, you get kind of a overall picture. And if you see exenatide, exenatide is not yet approved for marketing, but it's got a very nice cardiovascular outcome trial, which I'll discuss later. These are not based on the human backbone, the human GLP-1 receptor molecule backbone, and they have generally an HbA1c reduction of about 0.8 to 1%. But then when you come to the ones which, as I said, we commonly use, lira, dula, and sema, you see already that the HbA1c reduction is higher. And I was just telling you in the slide before that sema has got definitely got better HbA1c reduction as compared to dulaglutide. Now, what about the other effects of GLP-1 receptor agonists beyond glycemic control. With regards to obesity, they help in weight loss. Now, I'm going to talk about the doses being used in management of diabetes, because semaglutide in a dose of 2.4 milligrams once weekly, or the dual GLP-1 GIP agonist. I'm not talking on that. I'm just talking about GLP-1 receptor agonists, which we use in our diabetes management. So either 1 milligram once weekly semaglutide, which is not available to us. So what do we use? We use oral semaglutide up 7 milligrams or up to 14 milligrams per day. And there you will get an average ballpark figure of 3.13 kilograms. But in one of the pioneer trials, there was a weight loss of up to 5 kilograms. If you come to liraglutide, not the weight loss dose, but the dose which is used in management of type 2 diabetes, max 1.8 milligrams, you can have a reduction of about 1.3 kilograms in weight. The others, if you see, one of the reasons why albiglutide probably was not marketed by Glaxo was because the weight reduction, and in the previous slide you saw HbA1c reduction was not that effective. Same with lixisenatide, exenatide, and dulaglutide. So apart from glycemic control and weight control, what else do GLP-1 receptor molecules offer? They offer cardiorenal protection, decrease in major adverse cardiovascular events, decrease in heart failure with preserved ejection fraction, decrease in the progression of clinically significant renal endpoints, and decrease in cardiovascular death. And some of the trials have shown that, and let's discuss those. This is a busy slide. You can't take it through in the next 1 minute that I'm going to spend on this slide, but these are the various cardiovascular outcome trials. You can get it from the reference that I've given to you. This is the latest, which has summarized most of the trials. And if you see overall, there's a 14% statistically significant reduction in 3P MACE, which is non-fatal MI, non-fatal stroke, and cardiovascular death. If you see the ones in green, leader liraglutide, rewind dulaglutide, harmony albiglutide, which is not available to us now. Sustain 6 is semaglutide, 1 milligrams once a week. Amplitude O is f-peglinatide. All of these showed statistically significant reduction in the 3P MACE. The others, Elixa, Excel, and Pioneer 6, did not show superiority, but they were non-inferior to placebo with regards to 3P MACE benefit. What about composite renal outcome? The trials have defined composite renal outcomes in a little bit different ways, but in the end, it's basically either doubling of serum creatinine or worsening of eGFR by more than 40 or 50%, progression to end-stage kidney disease, GFR less than 10 or 15 over 3 months, or they're ending up on dialysis or having a kidney transplant, or a renal death or a cardiovascular death. This was generally the composite endpoint of renal outcome. And again, if you see leader liraglutide, rewind dulaglutide, sustain 6 semaglutide once weekly, and amplitude f-peglinatide, they all showed this was not the primary endpoint. These were the secondary renal endpoints, which were carved out from the cardiovascular outcome trials. SELECT is non-diabetic patients. SELECT is there in this paper, so I'm not discussing SELECT because SELECT was semaglutide in obese non-diabetic people. So that was only obesity population. I'm just keeping that out. Overall, if you see, there was a 24% reduction in clinically significant composite renal endpoints. I'm discussing CKM, so I'm just sticking to C and K. I'm not going to the others. So prior to this trial, which is called the FLOW trial, as you can see down below, we only had secondary endpoint data that GLP-1 receptor agonists have a salutary effect on the progression of renal disease in people with type 2 diabetes. Then came the FLOW trial, which was effect of semaglutide 1 milligram once weekly on chronic kidney disease in patients with type 2 diabetes. And this was where the renal endpoints, these were the clinically significant renal endpoints that I just mentioned, persistent more than 50% reduction from baseline in eGFR less than 15, kidney replacement, death from kidney cause, death from cardiovascular cause. All 5 were clubbed together as the primary outcome, which was the major kidney disease events. And you see this unequivocal, statistically significant 24% reduction, relative reduction with a confidence interval not touching unity, which means it's significant. So this was the first evidence where a primary endpoint was the composite renal outcome, and it showed that the GLP-1 receptor agonist semaglutide provides you with renal benefits. We had this information, but as a hypothesis, in a hypothesis form from the various cardiovascular outcome trials, but now you have the evidence. So GLP-1 receptor agonists have reduced HbA1c, cause weight loss, have beneficial effects with regards to MACE, heart failure, DKD, CV death, and established benefit in DKD, MI, heart failure with ejection fraction, and stroke. Now, investigational with regards to metabolic liver disease, Alzheimer's, Parkinson's, and PAD is not yet is still being researched, and we need to wait for some more data. So, what all we have discussed? We have discussed what is CKM syndrome, what are the effects of GLP-1 RH with regards to metabolic, reduction in blood glucose and weight, CV, MACE, did not touch the heart failure data, and renal, where I shared the flow data with you with semaglutide. So where do GLP-1 RAs come in various guidelines with regards to CKM syndrome? So K, that is 2022 KDIGO guidelines for improving outcomes in people with diabetes with CKD. This is the latest guideline. There's another guideline 2024, which is management of CKD, not management of diabetes in CKD. And here, if you see, metformin, if GLP-1 is more than, if GFR is more than 30, SGLT2, if GFR is more than 20, and on top, after that, if you're not getting glycemic control, the next which comes in the algorithm is a GLP-1 RA. Of course, RAS inhibitors has to be on board. Of course, statins has to be on board. If you see the European Society of Cardiology, cardiac, guidelines recommend the use of GLP-1 RA for the management of type 2 diabetes in people with very high risk of CV risk or ASCVD. And here, if you see, if there's cardiovascular disease and type 2 diabetes, what they are saying is to reduce CV risk independent of glucose control. Of course, SGLT2 inhibitors, we have the EMPA-REG outcome trial, the CANVAS trial, and the declarative trial. But also, as I showed you, those 5 molecules which have shown statistically significant superiority with regards to cardiovascular outcomes, those GLP-1 RAs which you can use, all 3, Lira, Dula, and Sema, oral. Sema injectable and oral maybe. We are waiting. The top line results are out, which suggests that it also has statistical superiority with regards to cardiovascular outcomes. The ESC 2024 recommendations for GLP-1 RAs in patients with chronic coronary syndrome clearly puts class 1A evidence for GLP-1 receptor agonists with proven CV benefit are recommended. The ones which are proven, I just mentioned those 5, of which the 3 that we use, we have data. And chronic coronary syndrome patients without type 2 diabetes also GLP-1 RA semaglutide, because you had that select trial. I told you there were obese people without type 2 diabetes, but that was injectable 1 milligram once a week. And of course, the one which we follow day in, day out is the ADA guidelines. This is the latest one, which has just been published. It's almost the same like the 2024 one. On the left-hand side, you have people with diabetes with systemic involvement, ASCVD, high risk for CVD, heart failure, CKD. And on the right-hand side, people who do not have these, but weight management or achieving glycemic goals are necessary. If you zoom in here, then if you see people with ASCVD indicators or high CVD risk, if you see GLP-1 RA comes here, same. Now, for CKD also with flow trial, of course, you will use SGLT2 inhibitor first, but GLP-1 RA comes later. And on the right-hand side, people who have got none of these, but weight reduction is a matter, you will still think of GLP-1 RA. So the last 40 seconds, the summary, there's a close association among cardiovascular, kidney, metabolic diseases, which suggest a common pathophysiological basis. The CKM staging reflects the progressive pathophysiology and increasing absolute cardiovascular risk along the spectrum of CKM, and guidelines recommend a holistic, multifactorial, person-centric approach for the comprehensive management of CKM, which includes good glycemic control, good blood pressure control, good lipid control, and using a GLP-1 receptor agonist along with an SGLT2 inhibitor. With that, I will thank, and I'm happy to take questions. Thank you.
Thank you. A very excellent talk, and we'll go for the panel after 15 minutes. Now I invite Dr. Ipsita Misra, the young energetic endocrinologist from Odisha, to deliver on do GLP-1 receptor agonists hold the promise of becoming the next standard of care in diabetes and cardiovascular management. Ipsita, please.
Thank you, sir. Thank you for giving me this opportunity. I thank Ashok sir also and Jayan sir a lot for giving me this. So, sir, before answering this question, what we need to understand is the first part of the talk, which has been delivered beautifully by JJ sir, where we have looked into the rationale of why probably.
Can you make it full screen? It is not full screen. Just slides.
1 second, sir.
Just
One
put
second.
slide mode. Slideshow mode. Sorry for the interruption. Slideshow. It was coming, but slideshow mode. Can you put? Same thing, just put it slideshow.
Just a second, sir.
Okay, doesn't matter. It is
No,
coming.
no, sir, I'm just doing it. It was there. I just again, hold on.
Ma'am, you should share the screen first and then make it full screen.
You have done correctly, Ipsita. First share what you had
Right.
done last time.
I didn't, but then why it didn't come?
It will go back, ma'am. Can you please share the screen
Yes,
again?
I think now.
Yeah,
Is it
Yes.
in full screen? Right.
Perfect. Perfect.
So, but the first part of the question has already been answered. To understand that what is the rationale of using GLP-1 analogs because of their multiple benefits, and we'll just discuss a bit about that because already major part has been covered by JJ sir. And then what rationale we have from the hard data which is there, what evidence we have found, and why probably GLP-1 analogs in future are going to become probably the standard of care in management of T2DM. So I'll just go to the next slide. Should next I only slide? Yeah. So this has been sponsored by Novo. For the financial disclosure, I would like to talk of that. So the first question is, what are the actions of GLP-1 receptor analogs in T2DM and CVD management? So before going into the hard data. So we have understood from the CKM part that GLP-1 analogs not only bring down the glycemic part, but they have got a pleiotropic effect on the cardiac protection part, on the renal part, and also the metabolic part. Now, what needs to be understood is, apart from that, they have got effects has been explored on the liver related aspects and also on the central nervous system part. So we all know the mechanism how GLP-1 analogs probably work at the level of the CNS, where they have an effect on the satiety control and bring down and they regulate the neurotransmitters and the various factors which regulate the satiety part, having a balance between the oxygenic and the anaerogenic, and also through the GLP-1 receptors per se, which are located at the level of the hypothalamus. So by which they modulate the appetite. And at the level of the liver, now we are finding the GLP-1 receptor analogs are going to be probably the standard of care in the management of MAFALD or MASH. We have some discussions put up later. So here also they regulate the gluconeogenesis, bring down the hepatic steatosis, and have a modulation on the lipid metabolism. Renal part we have already understood, and definitely the data has been evident from what sir told was the flow trial. So in total, they improve the CV outcomes by reducing the appetite through the CNS part, bring down the adiposity, and we know that obese, overweight, they cause us they exaggerate the inflammatory milieu, which leads to a worsening in terms of the renal outcomes and also the cardiovascular outcomes. And this also we have discussed about the lipid parts and how they modulate the cardiac and the renal part along with the liver part. So first is just knowing a bit of data about how GLP-1 receptor analogs have been found to cause an improvement in the cardiac part. So multiple data has already been discussed by JJ sir. So GLP-1 receptor analogs, so this was a meta-analysis which include the landmark CV outcome trials, and these molecules have been found to reduce, especially the 3-point MACE, to a large tune, to the tune varying from around 10 to 17%. So if you compare the GLP-1 receptor analogs with the standard of care drugs which are being routinely used as of present, so definitely the improvement in 3-point MACE stands better if we use the GLP-1 receptor analogs. Now, at the level of the renal part, now if you look, somebody who has got a diabetic nephropathy, apart from the RAS modulation and taking care of that, and SGLT2 inhibitors, MR analogs, GLP-1 receptor analogs are being proven to have a better outcome in preventing the decrement or in the rate of falling of the eGFR. And this has been found from the injectable semaglutide by the flow trial. So some direct effects are there, some indirect effects are there. So direct effects by natriuresis, improving the renal and the systemic inflammatory milieu, which definitely lead to endothelial dysfunction, and indirect effect definitely by the other modulations where they bring down the glycemic parameters, where they take care of the blood pressures and they bring down the adipose content of the body. So this is how they probably will have a good effect on the renal milieu per se. Now, coming to the metabolic part, because now the discussion is, as we have already discussed, it is again the CKM. So it is the metabolism. It is metabolism which probably is found to be regulating at the level of the cardiac part, at the level of the CNS, at the level of the renal part. So the basic mechanism of dysglycemia is, along with insulin resistance and decrease in the beta cell function, the inflammatory milieu which sets in rather leads to worsening of insulin resistance and a poor outcome in the glycemic parameters. So ultimately, the inflammatory milieu, where multiple cytokines, NF beta, TNF alpha, interleukins, all these are released, they cause a harmful effect at the level of endothelium, at the level of the pancreatic functions. So all these things are further aggravated when the fat content in the body is deposited. So when we have explored the GLP-1 receptor analogs in bringing down the fat content in the body, so once the fat mass is decreased, the white adipose tissues, because we know that in the fat, there are multiple type of cells, and the fat tissues are the sites where adiponectins or adipocytokinins are certain things which are being produced, and a balance of them regulates the insulin resistance and the glucose disposal mechanisms. So all these things will ultimately bring down the inflammatory milieu set down by these adverse adipocytokines which are released from the fat mass content. So appetite regulation and weight loss is something which we have already discussed, how GLP-1 receptor analogs, both by its direct effects, because the receptors are situated at the level of the hypothalamus, and the indirect effects, they regulate the appetite and help in satiety control, which definitely plays an important role in bringing down the weight part, because along with your food habits, your exercise, the feeling of control of the satiety is definitely very much important. So this is just a mechanism, because we all know that two important factors regulate the food intake at the level of hypothalamus. It is between the balance between the orexogenic and the anaerogenic peptides. So the orexogenic ones are the ones which will rather want you to eat more, and the anaerogenic ones are the ones that will want you to eat less. So POMC and CART, they belong to the one where you will rather, when they are stimulated, there is a decrease in the hunger and decrease in the energy intake. And the other way around, if somebody, the GLP-1 inhibits the neuropeptide Y and the agouti related peptides, which are the orexogenic ones, that leads to more of rather food intake and the feeling of having food intake more. Now, let us look into the hard evidence what GLP-1 receptor analogs want. So this is where we have explored how the molecule probably works, and now the data about that. So there has been an evolution in GLP-1 analogs right from 1987 until 2024-25, where the molecule has been found to go through various trials and various approvals, right from the CVOTs to finding its benefits in the cardiac part, in the obesity management, in the renal part, now upcoming in management of MASH, and also to certain extent a very few data in where PCOS is also where that has been shown that there is improvement in the polycystic ovarian morphologies and those outcomes. So Pioneer was the trial where oral semaglutide was used, and multiple Pioneer trials have been conducted with the drug in comparison to various other molecules with placebo, with looking into and exploring into various data. So if you look into this is a data where HbA1c reduction and weight reduction with oral semaglutide variation, the varying range has been explored by using a data of 19 clinical pharmacologic trials, one phase 2 trial, 12 phase 3A trials, and one phase 3B trials. So JJ sir has already told in select the weight loss, which was found to be up to the weight 3 to 5 kgs, and that mean weight reduction with oral semaglutide at a dose of 14 milligram, it can be up to 5 kgs or 10 to 13%, and HbA1c reduction can go as high as up to 1.5%. Maximum HbA1c reduction can be as high up to 2.6%, which the meta-analysis data of various other comparing all the data has been done. So higher, this is a slide which shows comparison of various Pioneer trials where other molecules, SGLT2 inhibitor, EMPA, LIRA, the other GLP-1, DPP-4, the weight neutral, sitagliptin was used. And higher proportion of patients achieve HbA1c reduction to a more tune of around 1 to 1.5%, and definitely a mean weight loss of varying from 5 to 10% in comparison to the other drugs, because we know that DPP4 inhibitors are the weight neutral drugs. EMPA SGLT2 inhibitors, though they are been found to have weight reduction, but then it is to a very lesser extent. And liraglutide, in comparison to oral semaglutide, what the trial found was the weight reduction was definitely better with oral. So now this is a data which looks into that oral semaglutide is what it removes the fat content from the body, but it preserves the muscle mass, which is a very important part, and it gives an added benefit, because we all know that if there is sarcopenia, if the muscle content of the body goes down, probably the inflammatory milieu is rather worsened. So the data says that when with use of oral semaglutide, the waist circumference, BMI, and the total fat content of the body, especially the visceral adipose tissues, and now it is the intermuscular adipose tissues are the ones which are rather more bad, because they set a more of an inflammatory milieu. So the oral semaglutide definitely exerts its benefit by altering the body weight and the body composition, because it brings down the fat content and preserves the muscle mass. So this is the data which speaks how probably oral semaglutide benefits. And again, we have looked into the pathophysiology, how probably semaglutide, GLP-1 analogs, by improving the insulin resistance and the insulin release, and by its pleiotropic effects, and bringing down the weight, etc., brings down the inflammatory milieu. And definitely this data shows that the decrement of HSCRP, an inflammatory marker, is more in comparison to SGLT2 inhibitor EMPA. So definitely the inflammatory outcomes are better. This is something which is the same repetition of what we have learned from the previous session, that after the results of the flow trial, semaglutide oral part, the flow was with the injectable, the semaglutide oral part has been also shown to have improvement in the urine ACR and improvement in the GFR in obese patients with CKD and T2DM. So potential mechanisms is now in diabetic nephropathy, if you look into the pathogenesis. So once there is alteration at the tubuloglomerular feedback, alteration in the renal RAS part, there is worsening of albuminuria and there is a rapid fall in the GFR decline occurs. Multiple mechanisms are there. So GLP-1 receptor analogs looks into these pathophysiological mechanisms, and by its anti-albuminuric effects, by altering the renal hemodynamic mechanisms, leads to protection of the renal part, because it decreases the rate of fall of eGFR and probably helps in bringing down the albuminuria content to certain extent. And this data shows that the rate of reduction in the urine ACR, when it was found to be to the tune of around 20% after initiation of the drug therapy. And this is the same. And this is definitely the Pioneer 6 results. All of us sitting out here, we are aware of the data, how oral semaglutide was explored, and it has been found to have established CV safety in T2DM, because it led to 21%, though it was non-significant, but 21% reduction in the MACE, 51% reduction in all causes of CV death, and 49% in all causes of death per se. So CV death was 51 and all causes of death to the tune of 49% versus the placebo. So definitely this trial data showed that oral semaglutide had got a superior outcomes in terms of prevention of death due to CV causes or death due to any causes in the patient. And now SOUL has come up, where oral semaglutide cardiovascular outcome trial in patients with T2DM is probably going to do a paradigm shift in the management of diabetic care by using this molecule, where a huge number of patients varying from 9 to 10,000 long-standing diabetic who have established CVD and renal part have been included. So this is a placebo-controlled one. And this again explored into certain primary endpoints and certain secondary endpoints. Primary one being looking into again the 3-point MACE, and the secondary endpoints are looked into the exploring with the renal outcomes, especially the rate of reduction of GFR, and whether there could be a need of initiation of a renal replacement therapy. And interestingly, this also looked into the aspects of the lower extremity arterial diseases, if they can be improved or not, and certain other exploratory outcomes were also seen. So if you see that here, majority of the patients varying from 70 to 80% have got some other degree of cardiac or the renal endpoints, and most of the patients have got some other form of other comorbidities, and the degree of CKD stages was very high, to the tune of 30 to in around 38% of the patients had got GFR varying between 60 to 90, and 16.9% have got a GFR varying from 45 to 60. So quite a number of patients from this data were having baseline renal diseases or cardiac disease, and most of the patients were also on those drugs which are probably now the standard of care of management in diabetic treatment, who are proven to have cardiac protections, and most of the patients were on these drugs. Some of them are from between the OAD categories, especially the SGLT2 inhibitors. Majority of the patients were on the ACE inhibitors, ARBs, which we know, and of course statins not to be forgotten, which are the included in the standard of care to provide cardiac protection in the long-standing T2DM patients. And without doubt, we know that the top line results of SOUL was a 14% reduction in the risk of MACE, and all the three components of the primary endpoint contributed to MACE reduction was to be found. As part of the standard of care, 49% of patients received SGLT2 inhibitors, but they found that addition with the use of this drug, rather probably it improved in the renal and also in the cardiac outcomes. And oral semaglutide appeared to have a safe and well tolerated profile in line with all other previous trials, that is the pioneer group of trials which the molecule has undergone. So the CV outcome findings, if you look into the other modern glucose lowering drugs which are there, definitely if there is a comparison between the outcomes of EMPA, CANA, and the findings of LIRA, REWIND, and SOUL, definitely if you look, the mean reduction in the MACE is on an average, it is almost at par. But other pleiotropic benefits of GLP-1 analog semaglutide, which we have explored and found from the hard data, supports the use of this drug. And this is definitely a critical piece of evidence, the findings of SOUL, which will probably lead to a paradigm shift, because apart from the renal and the cardiac improvements, outcomes in the peripheral arterial disease have also been explored, and for the upcoming trials occurring with this drug to look into the findings of the lead lower extremity arterial diseases. Oh, so again, this is the same repetition. I would not like to go into that, where we are summarizing how probably oral semaglutide 14 milligram causes clinically relevant improvements in the CKM risk factors, especially hypertension, reduction of the HbA1c, bringing down obesity, improving the diabetic nephropathy, and also leading to improvement in the lipid parameters. So just to summarize, GLP-1 receptor analogs improve the glycemic control, so that is important. But along with that, the cardiac part is being found to have beneficial effects, renal parts, along with that, the metabolic risk factors, especially the obesity, the inflammatory milieu, the metabolic dysfunction associated liver disorders, they are being found to be improved. Evolving evidence definitely supports the use of GLP-1 receptor analogs in the management of T2DM and CVDs. Oral semaglutide, with its pleiotropic benefits, multifaceted, rather from the primordial level, it can cause to a modulation of the risk factors which lead to cardiovascular diseases probably in the later. And 14% risk reduction in MACE has been found in SOUL, which definitely throws light or emphasizes that this molecule would rather lead to being used as a standard of care in the management of T2DM. Along with that, the cardiac renal part will be explored and taken care of. So thank you, sir.
Thank you, Ipsita, for a very elaborate and excellent talk. It has you have touched almost all the clinical points that is needed. In my experience with oral semaglutide, since it has been available, one thing is definitely there, that it is reducing weight. But in some of the few of the patients who do not respond to semaglutide for weight reduction, but if you look at their parameters, they are all normal. The biochemical parameters, other aspects, and that gives a wonderful opportunity for the patient to live a healthy life. And Soul has added to this 14% reduction in MACE, and that is the possibly the molecule of the future. Now we'll have a short panel discussion. I invite Dr. J.J. Mukherjee and Ipsita to the meeting. And J.J., in your
Yes, sir.
discussion, you have introduced a new concept, the cardiovascular kidney and metabolic problem. How does this excess weight contribute to cardiovascular kidney and metabolic pathogenesis, and what are the unmet needs in this population?
The long question will take a long answer. I will give it very short. So it's not a new concept. If you see the SGLT2 talks, it is CRM syndrome, cardiovascular renal metabolic. And now GLP-1 receptor agonists have come up with CKM syndrome, cardiovascular, they change kidney to renal to kidney. That's all. We all know that, sir. People with diabetes, obesity have a high risk of cardiovascular and renal disease, and cardiovascular disease is the reason for their death. Now, excess weight contributes both, Ipsita and I showed those slides that if there is ectopic fat, if there is visceral fat, then it generates a lot of adipocytokines, leads to inflammation, and that inflammation, then of course it increases insulin resistance. So all that, comes in and causes the cardiovascular disease. Unmet needs, I think obesity management is dismal, unfortunately. In my clinic, I tear my hair because it's so painful. Nothing happens. We can talk about this 3.3 kg, 5 kg, and all that. We can talk about remission from the top of the hill. Kuch nahi hota, sir. The reason being, we are fat because 50 years ago we were not fat. We did not have so much food. We did not have a car. We did not have AC. We used to walk. I used to cycle to school. No matter whatever drugs you give, 10,000, 50,000, 80,000, get the people to do lifestyle management. Now, they will not do it, of course, because we can't undo the AC, we can't undo the car, we can't undo the jet plane. So we invent more and more costly drugs. As of now, in India, we only have Orlistat. That doesn't work well. Uh, in people with diabetes, we have SGLT2 and GLP-1, but if they are being sold as a weight loss agent, that's absolutely wrong. SGLT2 inhibitors, the best meta-analysis you see, you get 1.6 kg weight loss. Semaglutide oral, whatever you see. I mean, there are outliers. You also have had people who've got 10 kilos, 12 kilos lost. I've also had them. But if you count all the ones that you've prescribed oral semaglutide and you do a proper average as to what is the weight loss, it's not more than 3 to 3.5 kilos. Of course, there are outliers. I mean, in one of the out of the 8 pioneer trials, only in one pioneer trial they get a weight loss of 5 kg, and every slide says semaglutide causes more than 5 kg weight loss. Not true, sir. There were 8 trials in which not all of them touched more than 3 kilos, 3.5 kilos. So overall, I showed you the latest network meta-analysis, 3.3. Yes, the literature is improving. Once we get SEMA 2.4, I'm told it's going to come. And once we get GLP-1, GIP, tirzepatide, but then cost will be an issue. And of course, the other newer molecules which are being investigated, including the triple agonists, that will probably change the scenario. So yes, obesity is a problem. Yes, we overeat. Yes, we don't exercise enough. Yes, drugs are coming, but they will be very expensive. Over to you, sir.
I think, Alok, I have one question to ask to JJ and also then I'll come to Ipsita. I think what you said is correct. Maybe that when you have the Pioneer 8 trial with Dr. Nitin Kapoor, where they use abnormally high dose, he used 24 milligram, you know that, no? 24 milligram semaglutide. He got a higher weight loss up to 10 kg. It was not blinded. So he knew that the patients were taking the drug and he found that. But as you rightly said, the weight loss is less than 5 in oral trial and the network trial 3.5. My very pointed question to my dear JJ, does it have any preferential effect on the epicardial fat, pericardial fat, epipancreatic fat, and that they say the layer of fat over the kidney? They call the renal fat. Does it have? If it is having an effect, then it is standing head and shoulder above SGLT2.
Okay, to answer your question, sir, the 2 trials that you mentioned were OASIS trials.
Yes.
The Oasis trials, they used 25 and 50 milligrams.
Yes.
Oasis 2 was in diabetics and Oasis 1 were in non-diabetics.
Correct.
Yes, the weight loss there was more than the dose of 7 and 14 milligrams. But there, the weight loss of about more than 10% was seen in a substantial proportion of patients. But you see, because we can't get good weight loss, now we have set our targets only at 5%. We can't get a gold medal, so get a bronze and you will be getting Khel Ratna. So what can we do? So we say 5% and 10%. We need much more weight loss. So leaving that aside, coming to the ectopic fat deposition that your pointed question is, epicardial fat, hepatic fat, perirenal fat. There are small scale trials, sir. We don't have very large trials, but there are small scale trials which show that you lose overall fat, you lose visceral fat, to some degree subcutaneous fat. And yes, there are studies now, these are very sophisticated MRI-based studies, which are suggesting that they do move the epicardial fat. To what degree they move, how much that has an effect on cardio-renal outcomes. So these are studies still, I mean, begging to be done. And I'm sure they will be done because the company will only move forward if if they think that this epicardial fat, perirenal fat reduction is clinically significant enough. That I don't know. We are seeing on some imaging studies, some movement of fat. As to whether it's clinically significant, we need to wait.
Yeah. Second question, Alok, please, 1 minute, is that why do you say differentially you give between SGLT2 and GLP-1 array? One you give for the cardiovascular risk mitigation, other one you give for the heart failure.
So to me, I think both should be used together. If somebody can afford a GLP-1 receptor agonist, he can easily afford an SGLT2. Poor patient who can't afford a GLP-1 receptor agonist, I will use SGLT2. That is practicality. Coming to science, science is you have much more data with SGLT2 with regards to renal benefits. All the trials, if you see, EMPA kidney, DAPA CKD, Credence, it's a much more stronger data with regards to renal. Does it mean that GLP-1 RA does not have renal benefits? Probably no, but we need some more data. You see, I mean, you only had the flow trial now. That's why for kidney, also for heart, if you see GLP-1 RA, GLP-1 RA's main benefit is in retarding the progression of atherosclerosis. The effect of GLP-1 RAs on heart failure, it's kind of a mixed bag. In obese people, select trial, in obese people, you may get benefit in the clinical symptomatology with regards to heart failure with preserved ejection fraction. But in the various other trials, when they've used GLP-1 RAs in the acute phase, there have been some negative data with regards to its worsening heart failure. So that's why when you have this kind of, light and shade, GLP-1 RAs move behind SGLT2, which have unequivocal evidence with regards to benefit in all forms of heart failure, HEF-ref, HEF-pef, HEF-mid-ref. So that's why heart failure and CKD, we should always use SGLT2 inhibitors first. And for CKD prevention, choose SGLT2 or GLP-1. Ask me if somebody can say, yes, मैं GLP-1 ले सकता हूँ, happily prescribe him both.
I think over to Alok. Alok, you had some questions. Please continue.
My question to Ipsita.
Sir.
We know that cardiovascular disease is a major risk factor for diabetes, particularly type 2 diabetes. CKD is also coming forward as a major risk factor, and many people are suffering from that. What are the risk factors for CKD in this population and how to mitigate it?
So if you look into the progression of diabetic kidney disease in long-standing T2DM patients, for T2DM patients, the onset of the renal disease may be much prior to the point of diagnosis. So along with that, definitely we have discussed, we know it from our basics that hypertension, dyslipidemia, presence of diabetic retinopathy, presence of microalbuminuria, which has already set in, where probably you are not getting a higher urine ACR, but other biomarkers are evident in the renal part. Use of excessive smoking, especially in diabetics who are more than 40 years and they are on a long duration of smoking. So these are all the risk factors. But apart from that, there are certain genetic risk factors which are there and which are not routinely identified because genes are something which we cannot study. What we ask is, okay, family history of diabetes. So family mein koi renal disease से किसी का death हुआ है क्या. So that is an indirect practical marker because we do not go for screening of genes, and there are multitude of genes which also rather aggravate the worsening of progression of renal part and worsening of the albuminuria. And now we have a group of patients who are the non-diabetic, non-classical renal diseases they are having in T2DMs. So these are the ones where genes also play a role. So what are the modifiable ones which we can take care of that? And then we, as JJ sir has told, we have got data from these trials where we can have a progression of onset and where the pre-existing thing is already there and where we can just hold on and prevent the rate of progression of fall of GFR. So here molecules where drugs have come up starting from the SGLT2 inhibitors to the GLP-1 analogs where there has been found to be benefits, but then when the certain things are there which are not beyond, so somebody who has got a full-blown part of a diabetic kidney disease, so at that point only we cannot predict how good the outcome will be. But in the case where it can be modifiable, definitely we know the risk factors and how we can take care of that part along with the diabetic management, blood sugar, the lipids, and the drugs which have got pleiotropic effects. If we use them, then definitely we can have a good point. And now the upcoming drug along with RAS, MRAs have been coming up, the non-classic and mineralocorticoid receptor analogs, which are shown to have benefit from the trials of Fideldo and all those Figaro trials, sir.
Thank you, Sita. That means
Alok.
you mean gene means the susceptible genes and protective genes. So
Yes, sir. So there is a balance between both, sir. Are existing, sir.
In some diabetics, we find their nephropathy continues for a longer time,
That's
and
right,
in
sir.
some, it's just sliding down. In 6 months to 1 year, they go to 11, 12 creatinine and need replacement or other aspects. So
Absolutely.
that's very important. JJ, how do
Yes, sir.
you connect this
45 rekhaiba border.
mass and CKM? I think this is one of
Come again, sir. The
a
question.
link between mass and CKM, MASH.
Oh, mass, we mean fatty liver, MASLD?
Yes.
Yeah. Fatty liver.
Fatty liver. Yes, sir. So fatty liver is a new elephant in the room. We are tired of kidney and heart, so now we jump onto the liver. And yes, MASLD is a big deal. It is the commonest cause for chronic liver disease now, commonest cause for progression to cirrhosis. It used to be alcohol when I was training in JIPMER. Professor Das would vouch for that. Now it has become fat. Now, with regards to fatty liver, it's a very big topic. I mean, I will stick only to GLP-1 receptor agonists. Do GLP-1 receptor agonists have a role in it? First and foremost, it's weight loss, lifestyle, 10 times, 20 times. Because that's the only thing which reverses MASLD, to some degree reverses fibrosis. Amongst drugs, very few drugs have got data. Pioglitazone, yes, has got biopsy-proven data. SGLT2 inhibitors have got meta-analysis where they've done all sorts of data where they've looked at liver fat, etc. But hardcore data of reversal of fibrosis is lacking. With regards to GLP-1 RAs, there have been small-scale studies also done by semaglutide. A couple of them are with liver biopsy ones, but I think the jury's out. We don't have enough data to say that GLP-1 RAs per se will cause benefit in MASLD. Certainly, by causing weight reduction, they will have a salutary effect on MASLD. There are a lot of mechanisms. If you see those slides, there are multiple mechanisms by which GLP-1 RAs might reduce. They will reduce liver fat, but as to whether they reduce the inflammation, the hepatocyte ballooning, the inflammation, progression to fibrosis, that is open to question. And more data is going to come very soon, and that's what we are eagerly waiting for.
I think, Alok, just 1 minute, I want to ask this question also. Sita beautifully covered in her summary slide.
Correct.
I think one thing she said about the inflammation. I think
Yes,
compared to SGLT2, GLP-1 array have more anti-inflammatory effect. Am I correct? JJ, correct me.
You're right, sir.
Correct. That's one advantage. The second thing I want to ask you regarding the two things regarding sarcopenia and taking away the hedonic pleasure. You and me are, our life centered around food. So does it take away hedonic pleasure? Is there a difference between SGLT2 and GLP-1 array?
Absolutely, there's no doubt, sir. I mean, GLP-1, as Ipsita very nicely showed all her nice
Yes,
slide
sir.
in one. She
Beautiful,
showed the
beautiful,
various,
Ipsita.
the one which is making you feed, one which is asking you to stop. I think I better let Ipsita answer this question. That was her talk.
Please, yes,
So
Ipsita.
definitely, sir, GLP-1 receptor analogs per se, the receptors are present at the level of the hypothalamus. So they modulate the balance between these hormones. All these peptides, I would rather say hormones or peptides, which we have already told, sir, the arexogenic and the anaerogogenic. So the hedonic pleasure, sir, is uncontrolled satiety where we just want to eat and eat. And that is one of the most important cause of overweight, obesity, especially in the younger generation and in the present context. So GLP-1 receptor analogs have proven mechanism to control that by causing a balance between this POMC CAT, neuropeptide white and ARYs. Along with that, sir, when this is controlled and the fat content comes down, definitely the adipocytokine milieu, which will have a bit, there'll be an improvement in the milieu. And we all know now the focus in on anti-inflammation. So now Vidya Balan also probably lost weight by taking diets which were anti-inflammatory and not pro-inflammatory. So now the focus is on anti-inflammation. So definitely GLP-1 analogs have focused on that.
Over to Alok. Alok, please. Alok, please.
Regarding JJ's answer, there are murmurs in the research corridor that oral semaglutide is helping in reduction of fatty liver. It is to be released, and that is a very big thing that we are going to achieve. Possibly, the company will give a
Waiting for those, data,
I
sir.
think Alok, you were correct. There are studies with oral semaglutide which had shown, and as JJ said, some studies with the biopsy, because now this is a multi-million-dollar trials, as rightly said. And because I had a chance to talk with Shiv Sarin, he's coming to your city on 23rd. I'm also with him. Don't ask me why. We are there for the API. Now, what happens is that, Alok, please give me 1 minute, that many of these GLP-1 RAs, including the oral semaglutide, which is the oral GLP-1 RA, has proven to be useful in the fatty liver disease. There are biopsy-proven data, but as you rightly said, it is going on. The practices, the trials are going on. But till today, pioglitazone stands out as the only drug which has proven benefit on the epicardial fat, pericardial fat also, and also on the anti-inflammatory action. So that's a good thing this drug can back.
So best is to eat less and exercise more, sir. Kaun karta hai?
Yeah. That is true. I personally believe these drugs have come to stay, and the price will come down. Oral semaglutide also going out of patent, you know that. So it is going to come down, and this will be used. Whomever are given oral semaglutide, not many, not like JJ, not in thousands, but maybe 50, 60 people, they are all very happy. Alok, and it is not a very expensive drug. They can afford it, and they're very happy. They're continuing. So I'm very happy about that. But there are some reports of the anterior choroidal. You saw the report, JJ? What is that?
Yes, sir.
What is the
Yes, sir.
report about?
It's a very minuscule side effect. Like for example, if you are using a DPP4, you can get pancreatitis. DPP4 inhibitor, you get pancreatitis. If you use metformin, you can get lactic acidosis. So it is definitely an issue. I think henceforth we need to warn our patients, not warn, just have a mention in the passing that this can cause non-ischemic optic nerve damage. But it's very rare. The latest paper, as you must have seen, the incidence is so. The incidence is so low, but then this is something else we have to worry about now. We used to worry about retinopathy. So we said, chalo, focus trial aa jayega. Next year, we will get an answer to that. Now this thing has come. Now this thing is also not a kind of RCT data. So again, some more information we'll need.
Case study only. Thank you. I think Alok, under your stewardship, this has been a seminal session. Absolutely fabulous. Thanks to JJ and my daughter, Ipsita. I must tell you, it is absolutely fabulous, JJ. Great. Kailash is waiting. Kailash sir, namaskar. Now, Alok, you please conclude the session.
Thank you. It is a great session that which established beyond doubt that GLP-1 receptor agonist, particularly oral semaglutide, is of tremendous clinical value, and price will come down. Even if people do not have objection to this price after COVID, COVID has taught people that life is above everything else. To protect life, people are prepared. Even lower middle class people are asking for oral semaglutide. So this is a good molecule. It has come. It is going to stay, and possibly this will be the mainstay in diabetes management. Thank you, everybody.
Thank you, sir. Thank you for the opportunity
JJ, sir.
and enjoyed the session. Ipshita, enjoyed your talk.
Thank you, sir. Thank
JJ, meet me on 24th.
Jarur, sir. Will be. Thank you, sir.
Thank you.
you, sir.
Bye. Bye.
I will now request Dr. Manoranjan Behra and Dr. Kailas Mahapatra to chair this session. And in this session, there is little change. Vascular and neuropathic aspects of diabetic foot by Dr. Ghanusam Goel. Diabetic peripheral neuropathy by Dr. Sanjeev Kumar Bhui. Interview of infection in diabetic foot by Sambit Das to Dr. Asu Rastogi, and moderation will be by Dr. Manoranjan Behra, and Dr. Kailas Mahapatra will be one of the panelists. Dr. Behra, please.
Am I audible, sir?
Yes.
Good morning, sir. My heartiest pranam and regards to Professor Ashok Das, sir, Kanungo, sir, Jayan Panda, sir, and all the organizing committee of Nucd. So, and all my and distinguished delegates, audience, ladies and gentlemen. So, this is an important session we are going to have on diabetic foot and neuropathy. You know that diabetes mellitus is one of the most common endocrine or metabolic disorder, and is one of the most common non-communicable disease giving rise to multi-organ dysfunction. So the most common complications are the vascular complications. So aptly nowadays we are telling it as a vasculopathy because of most common microvascular as well as macrovascular complication. So our session is dedicated to this diabetic foot and neuropathy. You know that when there is hyperglycemia, there causes activates autoglycation, there are activation of the advanced glycation end product pathway, polyolal pathway, the PKC pathway, in sorbitol pathway, and this pathway ultimately leads to oxidative stress, endothelial dysfunction, and those things causes vasoconstriction, prothrombotic state, and that lead to atherosclerosis and ultimately both microvascular and macrovascular complications. So diabetic neuropathy mostly a microvascular complication, and diabetic foot both microvascular as well as macrovascular complication. So coming to the first session, I would invite Dr. Ghanshyam Goel, who will be speaking on vascular and neuropathic aspect of diabetic foot. Thank you, sir.
You can just introduce Ghanshyam in a minute, Manoranjan.
Okay, sir.
Please put the slide, Stuti, the slide of Ghanshyam Goel.
Let me introduce Ghanshyam.
Yeah.
Namaskar to everyone. Very good morning to all of you. It's a fantastic session. I listened to the entire morning session, which included so many aspects which surgeons usually do not know. But this session is going to be interesting in the sense that we are going to protect another organ, like besides liver, besides kidney, besides heart. The foot is also very important for everyone in day-to-day life. So that's important organ which is always neglected in diabetes. I call it the Cinderella. I have given it the name Cinderella, since that whatever attention the foot should get deserves, it's not given to the foot. So it is always said that prevention is better than cure. So we as doctors who are engaged in management of diabetes and also management of the foot, we must try to prevent this disease right from its inception. So as I said, we have doyens in this field who will be speaking on the various aspects. And I would request that they should stick to the time. And our first speaker is Dr. Ghanshyam Goyal. He is one of a great friend, and he's a senior consultant practicing diabetologist and endocrinologist in Kolkata. He has a lot of organizational activities. He has done, editions. He has written the books. So let's listen to Dr. Ghanshyam. Dr. Ghanshyam.
Panel discussion. Dr. S.K. Sen from Kids Hospital, Chief Consultant Food Specialist, will also join in the panel.
Yes, sir.
Ghanshyam, please.
Good afternoon, friends, colleagues. Today I'm going to discuss vascular and neuropathic aspects of the diabetic foot. So diabetic foot syndrome is a disease which includes several pathologies, mainly diabetic peripheral neuropathy and peripheral arterial disease, which results in diabetic foot ulceration. So according to the ADA, etiology, epidemiology, and disparities in burden of diabetic foot ulcers, DFU prevalence is increasing as persons with diabetes live longer. People with DFU, diabetic foot ulcers, are at high risk of lower extremity amputation, especially young, racial, ethnic minority, and low socioeconomic strata. Better diabetes prevention care is necessary to decrease the incidence of DFU and lower extremity amputation. Cost of diabetic foot ulcer is greater than that of 5 most costly forms of cancer. And lifetime risk of people with diabetes to develop a foot ulcer is 34%. Means every third diabetic is going to develop a foot ulcer in their lifetime. And out of that, more than 50% of the diabetic foot ulcers become infected. This is the paper from Michael Edmonds and his group. The current burden of diabetic foot diseases. There are neuropathy and ischemia are two great pathologies of the diabetic foot, which lead to characteristic features of diabetic foot ulceration. And every 22nd, a lower limb is amputated due to complications of diabetes. And we call it that ulcer is in remission because the recurrence of ulcer is very common after the healing. It's around 40% in the first year, then 60% in the 2 year, and more than 75% in the 3rd year. So how to identify the risk of it? It might be asymptomatic neuropathy. It may be peripheral arterial disease. It's a pre-ulcerative signs or ulcers. So this is a PAD presentation. You can show it that there might be different sort of peripheral arterial disease presentation, which we see in our day-to-day clinical practice, very advanced cases in which you may landed with a below knee or major amputations or the above knee amputation. These are typical neuropathic foot ulceration which are presented in our clinics. You can see a lot of callus around the ulcer. So to callus to grow, you require a good blood supply, and that's why by seeing it you can say it's a neuropathic ulcer. They're the different, and to offload the bilateral foot ulcer is the most difficult task to offload that. So that is, you have to keep the activity level to a minimum. Then who is at the risk of foot ulceration? Patients who are neuropathic, diabetic patients who are neuropathic, peripheral vascular disease, posterior foot ulceration, microvascular complications, poor glycemic control, smokers, foot deformity, and amputation. How this is the pathophysiology of neuropathy? There are motor neuropathy, sensory neuropathy, or autonomic neuropathy. And the sensory neuropathy, there is a decreased proprioception, unawareness of foot position, stress on bones and joints, plantar pressure, and there is a callus formation, ulcer become out. And here on the motor, there is a muscle wasting, there is a postural deviation, then deformities, stress and shear pressures, and ultimately to trauma and ulcer. And about the autonomic neuropathy, there is a reduced sweating, dry skins, fissures and cracks, and bulging of the veins, and that might be infected, and there might be ulcer. Or the peripheral arterial disease, there is atherosclerotic narrowing of, or blocks the arterial lumen, the foot ischemia, foot ulceration, and necrosis of gangrene, and infection and ischemic toy of the atherosclerosis. So peripheral arterial disease, any atherosclerotic arterial occlusive disease below the inguinal ligament, resulting in reduction in blood flow to the lower extremity. What is the reason? Why we say reasons for under recognition of PAD? As when we started diabetic foot around 25 years back,
we used to say 15% are ischemic or neuroischemic, 85% neuropathic. But nowadays we say 1/3 are neuropathic, 1/3 ischemic, and 1/3 neuroischemic. Because now people are more and more into it, and more they recognize this entity. First line method to diagnose PID is the ABI, and is not really available in the most of the clinic. But now the scenario is changing. PID, peripheral arterial disease, is not widely recognized as a disabling condition where stroke is estimated as a leading cause of disability. And very important, some experts think that the specific investigation of peripheral arterial disease is not important because evidence for myocardial infarction stroke can be extrapolated to PID, which is actually not true. So what is the unique feature of PID in India? It presents at younger age. In the Caucasian population, it is more in the elderly age group, more than 65, 70, 75, like this. And increased association of diabetes in presence of typical diabetic peripheral vascular disease. Then strongest correlation with presence of coronary disease and cerebrovascular disease. So what are the risk factors for peripheral arterial disease? Male gender, age, diabetic age per 10 years, diabetes, smoking, hypertension, dyslipidemia, and the Asians are at more risk, increased CRP, and renal insufficiency. All these are the risk factors for peripheral arterial disease. Smokers have twice the risk of peripheral arterial disease, and diabetes is a 1.7 times increase. So those with both conditions, means having smoking plus diabetes, they are at 3 to 4 times more risk of symptomatic PID. So regular monitoring of blood glucose and managing diabetes effectively are important ways to decrease PID risk in these patients. So how to classify PID? There are two classifications we all know, Fontaine classification and Rutherford's classification. You can say asymptomatic, mild claudicators, moderate claudicators, or severe claudicators. Severe claudicators mean patient is in pain when he walks less than 200 meters or sometimes even less than 50 meters. Then rest pain, minor tissue loss or ulceration or gangrene. So neuroischemic fit generally is cold. It's not pink. It's generally black, ulcerous, marginated ulcers, and gangrene. And it's not painful. It's very painful because these patients are injured. So how to assess for peripheral arterial disease? Perform a diagnostic ABI in any patient with symptoms of PID. Not to miss. This is the message which I want to convey. Palpate the both pedal pulses, dorsal pedis and tibialis posterior, and that is the important thing. Then do a ankle brachial index. And for the ankle brachial index, always remember it's an inexpensive, accurate, and can be done in primary care setting. Even at the primary care, you can do it. And ABI is 90% sensitive, 90 and 99% specific for the peripheral arterial disease. And this is, we all know, is a ischemia grade mild, moderate, severe, or you can say less than 0.9, or even this recent guidelines for International Working Group on Diabetic Foot, less than 0.80, normal, 0.6 to 0.79 is the mild, and then 0.4 to 0.59 is moderate, and severe or critical limb ischemia is the ABI less than 0.39. That is there. And the Helder Doppler is one of the gadgets by which you can measure it, and relatively low cost. It's a non-invasive, and you can be performed repeatedly without any problem. What are the other non-invasive invasive tools to assess the peripheral arterial disease? There's a transcutaneous oxygen tension, color Doppler, CT angios, MR angios, and peripheral angios. If you are thinking that patient is going to require an intervention, either a peripheral angioplasty or might be requiring a pedal bypass, in that situation, you have to go for peripheral angiography. So what are the contraindications for ABI? ABI is a very simple tool. You can practice at a primary care level also. If patient is having excruciating pain, patient is having deep vein thrombosis, or patient is having severe pain in the lower wound, lower extremity wounds. In that situation, you should not go for an ABI. So toy pressure and toy brachial index and abnormal TBI. Toy brachial index less than 0.7 is an abnormal thing. It's generally 30 millimeter less than the ABI. And what are the further evaluation? You can go for a duplex Doppler, transcutaneous pressure of oxygen, angiography, CT angio, and MR angio. This is the one of the way why you can say there is a block. You can see in the superficial femoral, or I can say popliteal artery, where there is a block. You can see, and we all know below knee artery blockade is especially anterior tibial, posterior tibial, and peroneal is more common than the above limb, above knee arteries. About the MR angio, It's a non-invasive, no radiation, no iodinated contrast material, 3-dimensional useful for renal patient where the renal functions are compromised. We can opt for MR angio instead of CT angio. And now, with this background, now I'm going to discuss about the diabetic neuropathy. The simplest definition for diabetic neuropathy is have been excluded. We all know it agonizes when painful and damages when it's painless. So neuropathic foot, it's a well-perfused, bounding pulses, high R's, clot, you can say a lot of callus around it. It is in the high pressure areas, great toe, first, third, fifth empty head, first, third, and fifth empty head, plantar callus, plantar ulceration, and legs protective sensation. Even patient walks on these sort of ulcers because they don't have any pain sensation. This is a patient who presented to us, 52 years male, type 2 diabetic, unpoorly controlled diabetes, and present non-healing ulcer on right great toe, non-healing ulcer, and foreign body staplers were found in the X-ray and it has been removed. So that was non-healing because patient was not having any pain. So diabetic peripheral neuropathy occurs in up to half individual with type 1 or type 2. So most common complication of diabetes is diabetic neuropathy. So current clinical management of diabetic peripheral neuropathy focusing on controlling the diabetes, and there is very strong evidence in metabolic control or diabetic control in patients of type 1 diabetes. But even in type 2 diabetes, there is a benefit if you will achieve the glycemic control. Then among diabetic complication, damage to peripheral and autonomic nervous system is the most prevalent, and distal somatic polyneuropathy, which presents a lower limb sensory loss followed by upper limb sensory loss, is the most common type of diabetic nerve damage. So about the LOPS, the person will LOPS, loss of protective sensation, are not aware of minor foot injuries that can become major problem, major injuries, and they might land it with a non-healing ulcer and even ultimately with the amputation. So cause of LOPS is believed to be the related blockage of small artery. This is the painless nature of the diabetic foot disease. You can see patient doesn't have any pain, localized callus at the high pressure areas, at the great toe, first, third, fifth empty head area. These are the commonest area where. So to evaluate neuropathy, you can have neuropad, monofilament, tuning fork, biophysiometer, pinprick, and temperature perception. The most important is the monofilament test. Out of these three sites, great toe, first empty head, and fifth empty head, if a patient is unable to feel at more than two places, then you can say patient is having loss of protective sensation or patient having neuropathy. And by the biophysiometer, if it is more than 25 volts, means patient is having significant neuropathy and having high risk of ulceration. And foot temperature assessment is a very good tool. It is known as thermometer of the foot, by which you have, because we are all aware during the pandemic, we use this thermometer, the infrared thermometer, and difference in temperature of more than 2 degrees is suggestive of then you have to suspect of either a Charcot's foot or other conditions. So it's a very important tool. So light touch test. If a person who is not doing either a monofilament or not doing a tuning fork, in that situation, it can be used. What you will do, the examiner, what will do, by his index finger, he will touch the first, third, and fifth tips of the toys, and patient is unable to feel, means he is having loss of protective sensation. It's validated. So with this background, I'll say International Working of Diabetic Foot 2023 guidelines suggest you can stratify the high risk fit. So very low risk fit, if patient is no LOPS, no loss of protective sensation, no signs of peripheral arterial disease, then you have to go for a comprehensive foot examination once in a year. If it's either of LOPS or PAD, then once every 6 months. If moderate, if patient having LOPS plus PAD, or LOPS plus foot deformity, or PAD plus foot deformity every 3 to 6 months, or high risk means when patient has LOPS, loss of protective sensation, peripheral artery disease, or history of foot ulceration, history of lower extremity amputation, history of CKD stage 5 or 4, or history of Charcot's foot, or history of amputation, then when our patient comes to your clinic, you have to examine the foot. So about the managing the diabetic peripheral neuropathy, as I have already mentioned, is the glucose control, which is important. In type 2, only marginally affect the DPN problem, especially when patients have metabolic syndrome. Early intervention might slow the DPN progression, making timely diagnosis very crucial. So always remember it. And about the stepwise approach for the primary care, all individuals should be assessed for DPN starting at diagnosis of type 2. Suppose a patient who diagnosed to have type 2 diabetes, so from that time you have to do it and then annually. But in case of type 1 diabetes, you have to assess the patient for peripheral neuropathy after 5 years and then year. That is the guidelines suggest. Then assess for DPN symptom. There's a small fiber neuropathy. We all know the unmyelinated C fibers, and there's the 3 millimeter fiber, and they carries the pain sensation for burning, electric shock, stabbing, hyalgia, analgesia, nociceptive and protective sensation. And how you examine? By pinprick sensation or thermal, cold or hot perception. About the large myelinated fibers, and these are absence of ankle reflexes, reduced vibration perception, and reduce or absent 10-gram monofilament. That is it. So small fiber neuropathy, as I already mentioned, burning, lancetating, tingling, shooting, electric-like, soap-like sensation. These will be the symptoms. Then pain may directly or indirectly interfere with daily activities or lead to loss of balance. Disability, psychosocial impairment, sleep disturbance, and reduced health-related quality of life. Thus, there should be a strong suspicion of DPN in individuals presenting with any of these complications. Large fiber DPN, the symptoms generally say numbness, tingling without pain, loss of protective sensation. More advanced is poor balance, weakness, unsteady, that may lead to falls. Some individuals may present with completely insensate numb feet, may state in the claim that their feet feel as they are wrapped in wool or if they are walking on the thick soles. So, about the asymptomatic DPN, periodic flexible assessment for DPN risk, factors and symptoms and trajectories over time should be part of standard care for all people with diabetes. And you test for clinical signs of DPN, as I already discussed, or the pinprick sensation, temperature sensation, tuning fork, or light touch, or 10-gram monofilament. This is a assessment which has been done in a study in 2020 March, diabetic polyneuropathy and pain prevalence and patient character, a cross-sectional questionnaire of more than 5,500 patients. And what they find, female sex, elderly age, longer duration of diabetes, body mass index, and smoking were associated with possible DPN, where only smoking showed a clear association with painful diabetic neuropathy. Role of glycemic control. Early studies suggested that stable glycemic control with few excursion into hyperglycemia or hypoglycemia was associated with reduced pain score as assessed on a visual analog score. Later, with the advent of continuous glucose monitoring, CGMS, a small study confirmed that people with painful DPN have greater fluctuation glucose and poorer overall glycemic control than mass with painless neuropathy. Means if you are having more fluctuation, time in range is more, time in range is less, then you will have more chance of painful neuropathy. This is another study where diabetic peripheral neuropathy, epidemiology, diagnosis, and pharmacotherapy, and what they shown by this study, what is the implication? Clinical recognition of diabetic neuropathy is imperative for allowing timely symptom management to reduce the morbidity associated with this condition and may lead to the major amputation. About the painful diabetic neuropathy, this type of neuropathy was originally called insulin neuritis because after the good control, after starting the insulin, it upon. But a more recent review by Gibson and Freeman suggests that the term treatment-induced neuropathy of diabetes as insulin is not the only cause. So it should be labeled as treatment-induced neuropathy. So now I'm going to show you one case. It's an example. All we see in our day-to-day clinical practice. Gangrene of the great toe, smoker, black right great toe, severe pain for 2 weeks, diabetic since 16 years, hypertension, habitual smoker with 40 cigarettes per day. VPT was mildly impaired, color Doppler, low limit reduced biphasic flow in femoral and popliteal arteries. Evidence of atherosclerosis also seen in these arteries. TCPOT revealed regional perfusion index of 0.31. Pedal pulse is not palpable. ABI unable to perform due to severe pain. As I have mentioned, there's a contraindication we should not do. Poor glycemic control, A1C 10.3, and these were the other parameters. Renal functions were, I can say CKD stage 3, creatinine 1.4, 5, and this is the calcification of the arteries. You can see this is a common phenomena we all see in the patients who are in long-standing diabetes. That It is more common in the below knee arteries, anteriotibial, posterior and peroneal artery. But there was a block in the superficial femoral artery, and patients SFA and popliteal balloon angioplasty was done, and after that ABI come to normal, and pain subsided, and amputation of right great toe was done because already it was gangrenous. So you can see it was already gangrenous. So amputation of the great toe was done, and this is the 8 weeks after amputation, the wound healed. So this is the one of the way how you use. So to conclude, my dear friends, diabetic peripheral neuropathy is one of the commonest complication of diabetes. Peripheral neuropathy agonizes when painful and damages when painless. Painful diabetic neuropathy can be a nightmare for both for the physicians and patients suffering from it, and for the clinician trying to manage it. It have to bear the major brunt of damage done by painless peripheral neuropathy. Regular vascular assessment is important for people with diabetes. This includes, most important, the checking the pedal pulses and to do a ABI, ankle brachial index. Management means lifestyle changes, medication to improve blood flow, and in some cases surgical intervention like angioplasty or bypass surgery. Or you can start in these patients with a high intensity statin therapy, 40 to 80 milligram of atorvastatin or 20 to 40 milligram of rosuvastatin with the rivaroxaban 2.5 milligram twice a day. And periodic examination of food is mandated in all people with diabetes. Identification of early food problems can prevent major events and cost. Identification of high-risk food is possible at primary care setting, and education of physician-patient important for prevention of food complications. Thank you very much for giving a patient sharing. Thank you very much.
Thank you, Dr. Ghanshyam, for such a elaborative and such a very informative deliberation. As you have already remember you, as you say, always say that diabetic food patients, in diabetic patients, there should be an examination called apadamastaka. So we should never neglect the foot in examination in diabetologist chamber or a surgeon engaged in diabetic management, food management, that we never should always examine the food. Prevention is better than cure. We can treat these cases early, we can intervene them early, and we can save the food. This is what the message is. Thank you very much. I will request Manojan to invite and the next speaker and introduce the next speaker. Manojan, please.
Thank you, sir. Thank you, sir. Thank you, Professor Goel, for your extensive talk. Now I invite Dr. Sanjeev Kumar Bhoi, who will be speaking on diabetic peripheral neuropathy. Over to Dr. Sanjeev Kumar Bhoi. And I think Professor Mahapatra should introduce him.
Dr. Sanjeev, let me see. As Dr. Sanjeev is a professor and head of the Department of Neurology at AIIMS Bhubaneswar. He has numerous publications. He has contributed into many lot of index journals. Area of specialization is neurocritical care, CNS infection, clinical neurophysiology. And his achievements and awards are like he is a member of the American Academy of Neurology and IAN, Indian Epilepsy Society. And also Dr. Sanjeev is a reviewer of many journals like Frontiers in Neurology, Frontiers in Medicine, Neurology of India, Annals of Indian Academy, etc., etc. So it's a long list of accolades in favor of Dr. Sanjeev. I would request Dr. Sanjeev to start his deliberation. Dr. Sanjeev, yours.
Thank you, sir. Sir, am I audible, sir?
Yes, yes.
Yes, you are audible. Very much audible.
Can I share my slides?
Yes, sir, you can share your slides.
It's visible?
Yes, yes. Go ahead.
Make it full screen, please.
Yes, sir. Yes, sir. Thank you, sir. So, my respected teachers, thank for giving me the opportunity, especially Das sir, Kanungo sir, Behra sir. So my topic already, my previous speaker, Goel sir, has already simplified. So I have given the topic diabetic peripheral neuropathy. So this is my line of presentation. So when you suspect a case of peripheral neuropathy in diabetes, you suspect in all case. And out of this suspicion, 10% of neuropathy in diabetes patient may be due to other causes, not due to diabetic neuropathy per se. So this 10% high degrees of red flag signs should be taken care of before jumping in its case of diabetic neuropathy only. So what is diabetic neuropathy? It's a generic term defined by the presence of signs, symptoms of peripheral nerve dysfunction. So how to know this dysfunction? By the clinical signs, symptoms of the patient and the examination finding or some ancillary test in a patient of diabetes with exclusion of other causes. So what are the other diseases that are associated with the diabetic, which are highly found in diabetic patients? These are CIDP or chronic inflammatory demyelinating polyneuropathy, that is the elder brother of AIDP or GB syndrome, vitamin B12 neuropathy. They are closely associated because of metformin therapy and other lifestyle, alcoholic neuropathy and other toxic metabolic neuropathy. So peripheral neuropathy can occur before the signs symptoms of diabetes. The IGT trial says that IFG per se does not produce solely diabetic neuropathy before development of diabetes, but IGT, which is more complex glycemic control postprandial, may develop diabetic neuropathy or the IGT neuropathy before full-blown development of diabetes mellitus. So epidemiologists are already said 32% are related to diabetes, and in type 2 diabetes around 50%, and type 1 also 50%. So the prevalence of diabetes increases over the period of time of diabetes duration, that is around 8% to 42%. So almost 50% of patients of diabetes of 10 years duration will develop diabetic neuropathy. So other problem is the cardiovascular autonomic neuropathy, which is the most common cause of death in this patient with who develop the autonomic dysfunction. And these are the frequently undiagnosed, and they are because of a lack of awareness, we miss this area of dysautonomia, leading to many autonomic complications in this patient. Frequently undiagnosed entity are the painful diabetic peripheral neuropathy. They are almost 60%, and the painless also around 80%. So all patients of diabetes assume that they are having neuropathy by default. So these are the risk factors. These are multifactorial. So because once you know the risk factor, you try to control this risk factor so to decrease the incidence or the prevalence of diabetic neuropathy. The primary is the glycemic control, other the macrovascular and the macrovascular complication of diabetes, duration of disease, smoking, obesity, alcohol, and also genetic susceptibility. The ACE gene and the MTHFR are the high prone to develop the diabetic neuropathy. The pathogenesis, same like any other disease, a strong association of neuropathy with microvascular complications, suggesting as a common pathogenic mechanism. What are those? Hyperglycemia, polyol pathway, myoinositol pathway, AGE and products, and other are the reactive oxygen species radical, C-peptide, and NGL. So coming to this graph, so this is the time duration, the onset of the clinical disease and the diabetic neuropathy. So subclinically, you can have in case of IGT, the neuropathy, and once the patient develops the full-blown diabetes, you will get the sign symptoms of the diabetic neuropathy. So these are maybe the positive symptoms or the negative symptoms will come in detail. Then once they are having the large fiber neuropathy, the more myelinated fiber, then we'll get the reflex loss, the ankle reflex loss. Then the pressure sensation may start prior to that, the vibration sensation start prior to that. So once you go from the symptoms, then the vibration sensation, pressure, and ultimately the reflex loss and the motor dysfunction. But in case of electrodiagnosis, what we do, the nerve conduction, it can diagnose this subclinical neuropathy earlier. We'll come to the nuances of the electrodiagnosis later on. So these are the pathogenesis. The mainstay is the inflammatory cascade signaling, the reactant oxygen species signaling, leading to all these multiple mechanisms leading to the mitochondrial dysfunction and apoptosis. So in case of reversibility of the glucose control may not reverse all these parameters because there are many are irreversible. Mitochondrial dysfunction, apoptosis cannot reverse. So leading to the, coming to the biopsy-wise or the pathogenesis-wise or pathophysiology, what we get is the ischemia of the vasa nerve. The nerve, the vessels supplying the major nerves, the vessels are occluded because of the diabetic vascular complication. So once they becomes thrombosed, narrowing, so the glucose supply to the nerves decreases in due course of time, and the nerves are deprived of the glucose in spite of hyperglycemia in the serum, leading to the DRG, the dorsal root ganglion, becomes compromised and unable to fire routinely, and the myelin becomes in due course of time also damaged. The covering or the sheath of the axon or the nerves becomes damaged. So we'll get the sign symptoms. Second is the painful diabetic neuropathy. So why the pain occurs in diabetic neuropathy? Because of the hepatic transmission, because the nerves are not normal, they are leaky nerve and they are more jittery. So anyhow, with small stimulation, they can be discharged more, and there will be a continuous discharge at the DRG level, the root ganglion level, or along the supply. So once they will have the jittery, they will have more painful symptoms, that is more in during the night. That is the classical. Any night symptoms, pain, we think it's a more sinister disease like malignancy or something else. But in diabetic patient, they have nocturnal pains leading to the quality of sleep and the subsequent workplace. So the microvascular damage leads to this is the left side is the normal nerve and the right side the damaged nerve. You can see the well-formatted nerve, the myelin and the axon, but here you can see the vessels is clotted, and the lumina is blocked, whereas the myelin also damaged, leading to the axonopathy. So the major contributing is the peripheral arterial disease in case of this diabetic neuropathy leading to vasa nerve damage. Coming to the third important part is why the patient of diabetic neuropathy develop allodynia. Allodynia is a central mechanism, not a peripheral mechanism. The allodynia means the brain is there. Here the brain takes the upper hand. So the non-painful stimulus become painful. Suppose somebody touches something which is not painful usually, but in case of diabetic peripheral disease, they will have the more perception of that normal sensation become more painful to them. So this is due to the central sensitization mechanism. This occurs in any other disease like the migraine and other diseases we see more commonly. But because of the peripheral nerve hyperexcitability initial part, they will lead to the autonomic changes, sleep disturbance, and there is some reorganization in the brain. So nowadays, people are doing also the cranial stimulation to the brain to decrease the painful symptoms in case of diabetic painful neuropathy or the diabetic peripheral neuropathy with symptoms. So coming to the nerve biopsy, if you do a electron microscopy section of the nerve, you can see that in the control upper panel, you get the well demarcated, the myelin sheath, the thick black color surrounded myelin. But in case of diabetic patient, they are thinned out and the axon loss is there. Normally it should be 50%, but here you can see lower part, you can thinning of the small fiber more as compared to the large fiber. So coming to the whether the hyperglycemia is the only sole factor for diabetic neuropathy, no. In this trial, they said that apart from the hyperglycemia, there are other factors that can contribute to the diabetic neuropathy like BMI, overweight, hypertension, and other microvascular complications in case of type 1 diabetes. But in case of type 2 diabetes, they are more limited. They are more multifactorial. Age is the major contributor, and other overweight, glucose anyhow it is there, hypertension, and the CKD also plays the role here, or the urinary disturbance or the creatinine disturbance may play major role. So coming to the clinical spectrum of diabetic neuropathy, so all we know it's symmetrical symptoms, diffuse neuropathy, diabetic sensory polyneuropathy. They may be small fiber, large fiber, but we most commonly see the mixed neuropathy that contributes the small and large fiber neuropathy. Other are autonomic neuropathy leading to the cardiovascular, gastro, urogenital, pseudomotor dysfunction, hypoglycemic awareness, and abnormal pupil function. The most localized form are the mononeuropathy or mononeuropathy multiplex. More than 2 nerves involved in 2 different anatomical locations. So it's called mononeuropathy multiplex. Isolated is the cranial nerve 3 or the third cranial nerve neuropathy, which is most commonly seen in case of diabetic complication. Other is the radiculopathy. This is more, the patient comes to you because of the wasting of the thigh muscle, the proximal muscle, and because initially they will have pain, then later on they will develop the atrophy of the muscle. This is the diabetic amyotrophy or the diabetic lumbosacral plexopathy. Less common are the pressure palsy, entrapment neuropathy, CIDP already said, and acute painful small fiber neuropathy. So diabetic polyneuropathy most common, 50% seen in both in type 1 and type 2, and they are symptomatic in 15% and asymptomatic in rest of the. So sensory is the most common symptoms. Next comes the autonomic, because sensory I'm telling you is the small fiber first, then the autonomic small fiber. Motor means it's a large fiber, and they are length dependent fashion. The screening and diagnosis is the mainstay of diagnosing this and preventing. So presence of sign symptoms and or signs of peripheral nerve dysfunction in diabetic patient is sufficient to diagnose diabetic neuropathy. And other things to be, the red flags should be excluded. So any patient comes with the sign symptoms of painful positive symptoms, again findings showing some loss of sensation in the distal part of the foot. So you are pretty sure that you are dealing with a diabetic neuropathy. So whether we require any other things? No. Electrodiagnostics are not mandatory for diagnosis of diabetic neuropathy. The ADA says no, it's not required. But to rule out certain factor, we can do electrodiagnostic test. So these are for research setting and the confirm it's a pathologically diabetic neuropathy and to assess the further progression of the disease. So the bedside clinical assessment is the mainstay. The clinical scoring system is there. Small fiber function can be checked by pinprick. The pinprick can be quite good, 80 to 90% they are sensitive. Second is the thermal sensation. You can put a pole, tuning fork is the best, you can do that thing, or we can, as sir said, the laser way we can do. Large fiber sensation, large fiber means myelinated function. You can go with the vibration sense or the monofilament 10 gram monofilament test can be done. And the 3-minute diabetic foot examination is mandatory in all patients because it takes hardly 3 minutes to evaluate the neuropathy and the diabetic foot complication. The recommendation when to screen, yes, in type 2 diabetes at the time of diagnosis, and type 1 after 5 years of diagnosis. Further, every year you have to evaluate this patient with both the small fiber function and the large fiber function, the temperature and the tuning fork methods or the monofilament test you should do. These are the scores for screening. So we have to quantify whether there is a further progression is there or there is a recovery. So these are the 4 points: vibration, temperature, pinprick, ankle jerk. If the score is more than 6 out of 10 total score, then there is high predictive value of development of the diabetic neuropathy. So coming to the once you diagnose, the patient will say, I am confirmed it's a case of diabetic neuropathy. And you have to classify it's a possible, probable, or definitive. Possible, probable, nothing can be done. It's clinically only presence of sign symptoms of neuropathy like pain, paresthesia, dysesthesia, numbness, reduced distal sensation on examination, and absent ankle jerks. So my point is that the clinician should diagnose, they should not refer this patient to a neurologist for the diagnosis of diabetic neuropathy or to an endocrinologist. That means the patient is a diabetic complaining of distal sensory symptoms. Once you examine, there is some loss of sensation, and you have always checked the ankle jerk. If the ankle jerk is diminished or absent, then you are pretty sure you are dealing with a case of diabetic neuropathy. To confirm for research, okay, you can go for a nerve conduction study. So these are briefly the sign symptoms of large fiber and small fiber. Always we say large and small fiber. What is large fiber? These are myelinated fiber or the thick fiber. Small fiber is A delta and C fiber, the thinly myelinated or unmyelinated. So the diabetic patient will have 2 types of presentation, either a positive symptoms like pain, paresthesia, dysesthesia. Numbness is a negative symptoms. Here the patient will not feel that thing. So numbness, these are the part of a large fiber sensation, whereas the nociceptive is the pain, burning, electric shock, stabbing pain. So initially they will have small fiber, then they will become a mixed fiber and large fiber. Once you are getting large fiber symptoms, mean the ankle jerk will be absent, the monofilament and the vibration sense will be lost, which are the pathway for a large fiber. And the thermal and pinprick is the small fiber sensation. So these are the already sign symptoms already described. They will have the distal part, then they will gradually ascend to involve the proximal part. So it's a stocking and globe pattern distally to proximally. So this graph shows how the presentation of diabetic neuropathy. Pain is the cardinal in all these patients. So pain cannot differentiate whether these are large fiber neuropathy, small fiber, motor neuropathy, or the entrapment. But if it is a large fiber, the sensory loss is more marked, tendon reflex is absent, motor deficit is present. But it is a small fiber do not carry the motor fiber. So there may not be any motor deficit. Tendon reflex required a large fiber, it is intact, only the pain will be there. So you can say if the ankle reflex is preserved in this patient clinically, so you are predominantly dealing with a small fiber predominant with a mixed pattern or a mild large fiber neuropathy. Proximal motor atrophy, these are the amyotrophy, atypical variant, less common. Acute mononeuropathy, yes, they can be there. And entrapment neuropathy, like any site there is an entrapment, they can have this, but there will be a focal signs. There may not be a diffuse or a symmetrical signs. So DSPN is a symmetrical disease, distal symmetrical neuropathy. Radiculopathy is a asymmetrical focal disease, either a lumbosacral or a thoracic or a truncal area. Mononeuropathy is a entrapment neuropathy. There are also focal. Autonomic is a organ-wise or the solid organ-wise the development of the sign symptoms. So once you diagnose you have to grade them, whether the severity scale, whether they are mild or no symptoms to severe symptoms. Once they process the stage 1, then you should be alert because there is high chance of developing the complication in the form of diabetic foot, and the autonomic symptoms may be harboring with them, developing a cardiac complication or a GI system dysfunction. So role of electrodiagnosis, you have to rule out other causes of neuropathy, not to rule in unless you are doing some research. Severe pain, a typical form of neuropathy, so you have to go for electrodiagnosis. Suppose a patient comes with predominantly upper limb symptoms, hand. No, it cannot be diabetic because diabetic is a length-dependent neuropathy, starts from the foot. It's a more motor, not a sensory symptoms. So you have to think of more of a atypical or something else than diabetic. Rapidly progressive course, asymmetric signs. So then you have to think of something else. You have to go for a nerve conduction study. because once you do nerve conduction, we usually do the sural peroneal. If sural peroneal and the peroneal, the sensory sural may be absent and the peroneal may be compromised or the amplitude is decreased. The sequence of event whenever you see a nerve conduction report in a patient of diabetic is the sural sensory amplitude should be declined, should be reduced. Second thing, if it is more severe, then the latency of the sensory will be prolonged. The time taking the conduction will be more prolonged, that is the latency prolongation. And last is the conduction velocity slowing. The velocity of the nerve fastness is slow. So the sequence of event is the amplitude reduction, latency prolongation, and the conduction velocity slowing. And once they become sensory affected, then we'll go for the motor, and the motor will be having same category. So this is one patient aware of a diabetic neuropathy. You can see the common peroneal nerve, the amplitude is markedly reduced. It should be more than at least 4 to 5 millivolt. It is one box is 5 millivolt. It is up to half, and the proximal stimulation also it is half of the stimulation. So it is grossly reduced. So it is due to the motor axonal neuropathy of the common peroneal nerve. You will get the report. No, it's a motor axonal sensory neuropathy. So you have to read meticulously whether the sensory is affected or motor. If both are affected, it is a mixed neuropathy, and whether it's axonal or a demyelinating. And it is distal mode or the proximal part is affected. This is tibial motor conduction. This is also reduced the amplitude. In the sural, you can see there is no waveform, that is totally sural is absent. The small fiber neuropathy is difficult to diagnose because there is no test is available. Whatever we are doing NCS is for the large fiber. There is nothing for the small fiber. So the type of symptoms is deep, burning, stinging, spontaneous shooting pain, and allodynia to light touch. And pain and temperature modality are impaired in this group of patients, whereas the vibration, joint position sensation are intact till late, and autonomic neuropathy will be there. The test required is the quantitative sensory testing. These are more of research oriented, and you can go for a skin biopsy, epidermal skin biopsy, or a corneal confocal microscopy. Now, in our lab, we are doing for research purpose. These are the somatosensory skin response SSR in autonomic testing, but not in diabetes, in other diseases. So you can see if you stimulate the median nerve, these are in the palm and sole we record all the 4 area, we record what are the efferent pathways. The sympathetic efferent we record here in the palm and sole. So well-formed graphs are seen if it is an intact autonomic pathway. But in case of dysautonomia, you can see all the recordings are absent. So this will give some clue that there is autonomic dysfunction is there or not. So these are the diabetic complications. Sir has already detailed said about the diabetic foot complication. So you have to categorize this, and depending upon the stage of the disease, you have to refer the patient, or you can try to manage with you. So if the more severe the stage, then it's a multidisciplinary approach requiring a surgeon and other areas. So you have to send the patient for the better management. So for diabetic neuropathy, till date, there is no treatment for reversal of diabetic neuropathy. So only the control of the risk factor that can prevent the further progression of the disease. So other neuropathy, in brief, CIDP already said, it's a chronic inflammatory demyelinating neuropathy, more associated with diabetes mellitus. In a study earlier we have done, diabetic CIDP, they have more reduction in the amplitude as compared to the idiopathic or the non-diabetic CIDP. So other is the carpal tunnel syndrome, entrapment neuropathy, most common neuropathy in the general public, and the diabetes is most commonly associated. Unless you control the diabetes, the control of the painful symptoms of carpal tunnel is difficult to treat. Oculomotor neuropathy, yes, older patient with diabetes and hypertension, diplopia, ptosis, eye deviation, the third nerve involvement. It is due to the partial demyelination of the third nerve, no specific treatment. With control of diabetes, the patient recover around 6 to 8 months time. Here the thing is that these are papillary sparing third nerve pulses. The papillary fibers are spared, so they will not get a papillary abnormality in case of diabetic ocular neuropathy. Lumbosacral plexopathy or diabetic myotrophy, wasting of the proximal part of the thigh muscles, and the patient with type 2 diabetes, usually male, they are early after insulin therapy, severe pain in initial part followed by atrophy of the muscles, and this may be due to localized vasculitis. And you can do the electrodiagnostic test, and you can see the femoral nerve conduction time, the amplitude is reduced, and if you do the EMG, you can get a neurogenic changes. Sometimes short course of steroid is given in the early course of the disease, but once the patient has developed atrophy, there is no role of steroid. Autonomic neuropathy, cardiovascular, sexual dysfunction, GI neuropathy, bladder neuropathy, and pseudomotor neuropathy. So severe dysautonomia is a poor prognosis. Any patient of diabetic, severe autonomic neuropathy, the lifespan is reduced. So always try to tell the patient that should take care, suddenly should not get up because of the vertigo sensation may be there also, and there may be some cardiovascular complication. All we can do for diabetic neuropathy is make the diagnosis and commiserate. You have to feel pity for the patient. You cannot do anything. This is the Lancet editorial in 1994. We have done some study in metabolic syndrome where we have seen in migraine patient also there is insulin resistance and diabetes around 10%, and they have more severe symptoms of migraine. Second study also done in metabolic syndrome in chronic back pain. In this patient, 40% of chronic back pain have metabolic syndrome and insulin resistance. So other investigation of diabetic neuropathy, yes, for corneal confocal microscopy.
Since we are behind time.
Yes, sir.
Yeah.
Last 2 minutes, sir. Yes, sir.
Okay.
The corneal confocal microscopy and MRI of plexus can be done, but they are only for research and rule out the structural lesion. This is the corneal. This is the right time because now people are more focusing on corneal confocal microscopy. This is a mild, moderate, and severe. You can see the area of the nerve fiber in the cornea. MRI imaging only for structural imaging, nothing for the diagnosis of diabetic amyotrophy. And I'm not going to the detail. And how to suspicion for alternative diagnosis: acute or subacute onset, non-length dependent deficit, motor predominant deficit, asymmetry of clinical signs and symptoms, and early neurological deficit in upper limb, so suspect. So these are the long list of different diagnoses. All the disease can be there in case of diabetic neuropathy. So you have to rule out these are the red flags. Management, sir, I already said, nothing more, only the glycemic control. Lastly, only the few drugs I will say. Anticonvulsant can be tried in case of diabetic painful neuropathy or diabetic neuropathy with symptoms. The serotonin norepinephrine reuptake inhibitor and TCA, tricyclic antidepressant. So these are the drugs: pregabalin, gabapentin, duloxetine, venlafaxine, and the amitriptyline, the most common preferred drugs, but they have their inherent side effects. Opioid, try to avoid because they have addictive potency. These are the metabolic molecule changing vitamins. There are no role classical. Some role is alpha lipoic acid, but there is no standard guideline to say that it's alpha lipoic acid revert that thing or control. But 10 to 30% of symptoms can be reduced with alpha lipoic acid. So the learning point is the diabetic peripheral neuropathy inevitably in patients with diabetes. Suspect in all patients of diabetes. History and clinical examination is the mainstay. Food examination is the essential. Pain, paresthesia, numbness. Later on will develop the motor weakness. Ankle reflex is to be tested in all patients of diabetes to look for the large fiber. Isolated third nerve cranial neuropathy may be a cause of diabetic complication. NCS and EDX electrodiagnosis confirms but not required in all patients. Rule out other causes of neuropathy because 10% may harbor other sinister disease. Control of macrovascular and microvascular is the mainstay. In type 1, yes, glycemic control can revert the diabetic neuropathy, but not in case of type 2 diabetes. TCA, pregabalin, gabapentin, ALA, V12. Avoid upwards. Screening and prevention is the best strategy. Point of care devices are under trial, but they are still far away. Thank you, sir.
Thank you, Dr. Sanjeev, for such a nice, wonderful coverage of the entire neuropathy of diabetes. And as you said, it is most important for the diabetic foot disease also. So therefore, it is mandatory that these examinations should be carried out very neatly in all patients with diabetes, whosoever visits the diabetologist. So because of the paucity of time, we'll go to the next speakers and Dr. Asu and Dr. Sambit. As you all know, Dr. Asu doesn't need any introduction. He's the secretary of DFSI, a professor of endocrinology in PGI Chandigarh. He's a great organizer. He's a great loved person amongst all that in the forum of DFSI. And Dr. Sambit also doesn't need any introduction. We have introduced him in the morning session. So both of you now, I request both of you, Sambit and Dr. Asu, for the interview session. Manojan, you want to
No, not
say something?
Because of paucity of time, because we have also symposium after that.
Everybody is in the fasting state now.
Okay, sir. Let's hear from Dr. Sambit and Dr. Asu.
Yeah, Dr. Sambit and Dr. Asu,
So,
please.
hello everyone. I'm Dr. Sambit Das. I am currently professor in Head Department of Endocrinology at Kalinga Institute of Medical Sciences, Bhubaneswar. And at the outset, I must thank Team Nucd and Dr. Alok Kanungo for giving this opportunity. And today we'll be discussing a very important and pertinent topic, that is foot ulcers in diabetes and the role of infections in that. How do we manage infections and how do we treat a diabetic foot ulcer? So all these things we'll be addressing today. And For that, we have a very eminent personality, and very few people actually work in the area of diabetic foot. And fortunately, we have someone, a big personality who is working solely in diabetic foot ulcer for the last few years with good knowledge. So he's Dr. Ashu Rastogi, who is currently the additional professor at Department of Endocrinology at PGIMER Chandigarh. And Dr. Ashu is an alumni from PGI Chandigarh, and currently he is the additional professor at PGI Chandigarh. So before starting on that, I'll just tell that diabetes is associated with many complications. We know it's microvascular and macrovascular, and out of them, foot ulcer is a very important complication. And in fact, data has already shown that patient with foot ulcer have or infected foot ulcer have chances of mortality which is almost equivalent to that of any malignancy. So it's a very important problem. And there is one rule of 15 which we usually tell to our patients and to our colleagues, that rule of 15 is 15% of diabetic patients will develop an ulcer in their lifetime, and 15% of the foot ulcers may turn out to be an osteomyelitis, and 15% of the foot ulcer can actually go for an amputation. So with that, we'll have a discussion with Dr. Ashu Rastogi on different aspects of foot ulcer and mostly related to infection. So Dr. Ashu, going to the first question, how should one assess a diabetic patient presenting with a foot infection?
Yeah, thank you, Dr. Samit. And at the outset, I'll definitely congratulate the NUCD team for bringing such an important topic on the platform, which is very important and people don't discuss. And as Dr. Samit has rightly pointed out, that you can have a patient with foot ulcers who can have an infection or a foot ulcer which is infected. But mind it that almost only 20% of all ulcers in a given patient with diabetes are infected. And we always typically keep in mind the typical sign and symptoms of infection. And we should not believe that any patient who enters into the clinic with ulcer is having an infected ulcer. So when you are planning to examine a patient, you have to assess thoroughly, first, the patient as a whole, because a patient of infected foot ulcer can be in severe sepsis, can have metabolic acidosis, can present even with an acute MI or acute kidney injury, which require more pertinent and emergency treatment rather than the foot ulcer per se. So this is patient as a whole. Patient can be severely anemic, patient can have tachycardia, and patient can have a renal shutdown, and patient can even land in a flash pulmonary edema because of sepsis, because of foot infection. So always see patient as a whole, and ABCD, which are the basics of management, should always be kept in mind: the airway, breathing, and the circulation. Then comes the foot as a whole. Now, foot as a whole, by which I mean that infected foot ulcer can occur in a neuropathic foot, infected foot ulcer can occur in an ischemic foot, and it can be neuroischemic foot also. So we should see the limb as a whole, and then we have to come on the ulcer. That part which is seemingly in. And now we have the laid down guidelines by the International Working Group of Diabetic Foot and IWF guidelines, which came in 2023, which characteristically mentions the recommendations how to assess and manage a patient with plausible diabetic foot infections. And therefore, they have advised to grade any foot infection as mild, moderate, and severe. That is very important in assessment of a ulcer. Mild ulcer is usually said irrespective of the depth. If the erythema around the ulcer area is less than 2 centimeters, but it is more than 0.5 centimeters, it is characterized as mild infection. Remember that if it is the erythema around an ulcer is more than 2 centimeters, irrespective of the depth, if it involves the tendons and ligaments and the bone, but the erythema is expanding more than 2 centimeters, then it suggests that this patient is having moderate infection. And I always sometimes teach my residents that infection need to be seen, and you have to differentiate a commensal from a causal organism. And remember that infection by an organism is said only when there is a host response to it. Because even in a normal skin like me and you, if I just take a swab of my hand like this and I do like this, it will also grow Staph aureus. But that doesn't mean that this is infection. So infection should be able to have a host immune response, which comes in the form of inflammatory response as rubor, edema, tenderness, and warmth. So if it is there, then only it is infected. So mild and moderate is characterized like that, and severe foot infections if is seen whenever a patient is having systemic reaction to that infection in form of leukocytosis, tachycardia, fever, metabolic acidosis, raised TLCs, or presence of band forms, or any manifestation related to systemic inflammatory response syndrome. And it is very important to classify like this, like mild infection, moderate infection, severe infection, because you have to triage a patient of foot infection, as Dr. Sambit rightly mentioned, that they can also lead to mortality. A severe infection need to be immediately shifted to maybe an ICU or an intensive care team. And the mild infection can be very well managed in OPD basis. But yes, moderate may require hospitalization, may not require intensive care. So this is how we assess the patient in 3 tiers: first patient as a whole, then limb as a whole, and then ulcer as a whole.
So thank you, Dr. Ashu. That was a very candid answer. So many times, actually, whenever a patient comes with a diabetic foot ulcer or infection, then people actually, mostly the surgeons take a swab from there, and then the culture is done. So my next question is, when and how should I obtain a specimen for culture for a patient with diabetic foot wound?
Exactly. This is a very and the most burning question, because now we are dealing with lot of superbugs, and they are pan resistant, whether it is Delhi bug or Chennai bug, and we have papers in Lancet that now we have multi-drug resistant organisms. So we have to be very pertinent about treating foot infections, and that is very possible only if we have a proper specimen for that culture and antimicrobial sensitivity. So it is said that if the ulcer is not showing any signs of infection, not have an attempt of taking a culture. Cultures are only taken for clinically infected wound when it is showing signs of purulence or any signs of inflammation, as I mentioned earlier. So in that context, first step will always be debridement and washing of the wound with a cleansing solution. That cleansing solution, people say that I'll cleanse it with betadine, Usol, iron peroxide, and so on and so forth. But none of these agents are recommended for cleaning. The only agent that could be considered is normal saline or distilled water. And after thorough cleansing and debridement, then only the specimen for culture should be taken. And that specimen for culture should be taken from the base of the ulcer and not from the edge of the ulcer. And remember that the correct tissue specimen would be a soft tissue if you are thinking of a soft tissue infection, and it has to be bone if you are thinking of osteomyelitis. And why I say that? Because we have done a large study of more than 300 patients. We took both pus, we took the soft tissue, we took the bone, and we found out that if you are treating a bone infection with a soft tissue specimen and a soft tissue organism, then you are likely to be wrong 30% of the time. That means the organism isolated from soft tissue is different from the organism isolated from the bone in almost 1 in 3 times. So suspecting osteomyelitis is very important. For that, you need to have a bone culture. And swabs, like superficial swabs, as I mentioned, like just taking like this over the wound, is absolutely contraindicated, because this will always lead to the growth of commensals. And you just treat commensals with antibiotic, this will lead to more drug resistant, but the wound will still not heal. So obtaining proper specimen is always required. Now I'll just highlight one more thing, that IWGDF has gone one step further. And what they say is that usually people say that it's very difficult to take cultures, and it's then we have to wait for 3 days when this culture report will come, and then we'll start antibiotics. So what in the first 3 days? So they say that the recent IWGD update is at least do a gram stain of that culture specimen. That report can come just within an hour, and on the basis of that you can decide what kind of antibiotics you can prescribe. Maybe if it is only GPC, that is gram positive cocci, just give simple antibiotics. Or if it is GNB, that is gram negative bacilli, then you have give to give different antibiotics. So culturing is definitely a part of it, but if you don't have facility, at least do a simple gram stain that can guide you in knowing what kind of organisms you are likely to have in the wound.
Thank you, Dr. Ashu. I think the message is very wide and clear that superficial swab should not be taken. It should be from the base and during debridement, and it should be a tissue-based specimen actually, and preferably a bone tissue or a soft tissue according as per the need. And the next question is, when should I consider imaging studies to evaluate a diabetic foot infection?
Exactly. So this is very important because naked eye examination can be sometimes misleading. And that is very true because you can have a ulcer which is on the top is hardly 1 centimeter, but you can have a sinus underlying it, which might be reaching up to the bone. So for the knowing the extent of infection, when you can see the surrounding erythema is more than 2 centimeters, when an ulcer is chronic and it is non-healing for more than 2 weeks, consider that it is likely to be osteomyelitis. In that scenario, when you have a clinical suspicion of osteomyelitis, you have to do the imaging. In another scenario, even when you find that erythema is extending even beyond the ankle and patient is having only a 4-foot ulcer, so what could be the possibilities? The possibility can be the ulcer which is tracking down the different compartments of the foot or tracking in the proximal part through tendons like tenosynovitis or tendinitis. So it cannot be diagnosed just by naked eye examination, and we have to rely on the radiological investigations. So even the simple investigation that you can order is a X-ray of the foot. And for foot infections, you can just get a AP view of the foot with a lateral view if possible. Weight-bearing X-rays may not be required for foot infections, unlike in patient with Charcot, where we require a weight-bearing X-ray. So just order a X-ray foot, AP and lateral. This will give you 4 major things. First, the bone involvement. But remember that it requires almost 30 to 40% of the bone to be dissolved before the changes can be seen on an X-ray, like in osteomyelitis. So if you see a patient of acute osteomyelitis, probe to bone test may be positive and you feel that you should do an X-ray and X-ray is found to be normal. That doesn't rule out osteomyelitis. So X-ray changes usually take 2 to 3 weeks to appear, but still, if it is showing signs of disorganization of the bone, for a fracture or a moth-eaten appearance of the bone or an cortical breach, presence of sequestrum, then it suggests that patient is having osteomyelitis. Second thing that you can see on an X-ray is soft tissue gas. And this is again an emergency condition and that can be easily visible. The third thing that you can see is any foreign body, because these patients will then have a Clostridium infection which can spread very rapidly and patient will require ICU in these cases. So X-ray is very useful, but it may be normal in early scenarios. Therefore, we have to depend sometimes, and we usually order for an MRI scans to know the depth of the infection, to know the extent of infection, and to confirm the diagnosis of osteomyelitis by doing a simple MRI. You don't require a contrast enhanced MRI for all this. A simple diffusion weighted MRI is good enough, because many times when I talk to many physicians, they say my patient is coming in acute kidney injury, his creatinine is shot up to 3. I cannot give contrast to this patient. How could I do an MRI? But simple, just write non-contrast diffusion weighted MRI. That is very useful. And we did a study in BGI and we found out that the diffusion weighted MRI, and if we plot the ADC curves, you can ask your radiology colleague to plot a ADC curve that provides 100% specificity for diagnosing osteomyelitis. And in rare scenarios, sometimes you might have to do some PET scans also. Though it's still in the studying phase, but IWGTF guidelines do recommend one kind of PET scan that may be considered if MRI is contraindicated, patient is having hip transplant, or patient is having claustrophobia, cannot undergo an MRI. You strongly suspect that patient can have osteomyelitis. So this scan is known as FDG labeled WBC PET scans. Now this is why I'm saying this. It might seem fancy to you, but this is recommended by now our WGDF based upon our very novel work that we published in 2016, and this paper is now cited in IWGDF guidelines. and it was found to be again 100% specific for diagnosing of osteomyelitis in patients with complicated diabetic foot ulcers, especially if patient is having already Charcot's, deformity, and rocker bottom. On top of that, he develops an ulcer, and you are confused that this patient can have osteomyelitis. So sometimes PET scans may be required, and if possible, can be considered.
So thank you, Dr. Ashu. So the next question, and which is very important in our clinical practice, is which antibiotic we should start initially. So that's very important.
Yes, sir. So this is a very important question, especially for we physicians. And I always feel sorry that when I am being from a tertiary care institute and I see patients just roaming here and there without being taken proper cultures or antimicrobial sensitivity, given X antibiotics for 10 days, the wound does not improve. The patient goes to another doctor who give Y antibiotic, maybe parenteral now. It doesn't improve for next 10 days. He goes to Z doctor who starts more higher antibiotics, and at the end of the day, patient has lost 6 weeks, has drug resistance, has an acute kidney injury because of the drug-related kidney injury. So that creates a trouble. So we should be wise, and I believe that every center which deals with diabetic foot should have their own culture sensitivity patterns. Because a person sitting in primary healthcare center will definitely have an ulcer duration, will receive patients who have ulcer duration short. And it is said that if the ulcer duration is less than 7 days, you are likely to grow GPCs, that is gram-positive cocci. And the most common GPC is Staph aureus. You can also have strep pyogenes, but Staph aureus is the most common organism. We know that Staph aureus is very sensitive to linezolid. It is very sensitive to clindamycin. So some people say that we can have MRSA, and I'll like to start vancomycin. But we have done studies over diabetic foot infections and Staph aureus in our patients. Mind it, I am from a tertiary care institute, so I might have a different sensitivity pattern. But even the most common organism in our series was Pseudomonas aeruginosa, but second most common was Staph aureus. And out of all Staph aureus that we grew, only 15% were found to be MRSA. That means in that context, we started vancomycin in these cases. Remember a simple rule: if the wound duration is less than 7 days, the wound is mild to moderate in severity, you can safely start linezolid or clindamycin. And if the wound duration is more than 7 days, then it is believed that you are likely to grow polymicrobial cultures. In that, you will have gram-negative rods or bacilli and GPCs also. So now you need to give either amoxiclav, which covers both GPCs and as well as the GNBs. But if the duration is more than 10 days to 14 days and the patient is having moderate infections, the recommendations are you should give, along with clindamycin, a third generation cephalosporin or a uridopenicillin. Uridopenicillin means piperacin tazobactam, and third generation cephalosporin means cefotaxime and other kind of cephalosporins. For severe infections, they say that you may consider that patient is having either Pseudomonas aeruginosa or multi-drug resistant organisms. In these cases, you can give carbapenems along with either clindamycin, or you should also consider anaerobic infection in this case. So clindamycin very well covers anaerobic infection, but metronidazole can also be considered. So along with carbapenems, metronidazole plus minus vancomycin if it is severe grade of infection and the wound duration is more than 14 days, and you get a history that patient had a trauma and some foreign body infection that is causing the foot ulcers. So you should consider this. So it's very important that the choice of antibiotics is recommendations is like that. But as I mentioned that I am from a tertiary care institute, we receive patients who have already been treated for many weeks before coming to us. So I receive patients who are multi-drug resistant. So in one of our landmark papers, we found out that there was almost pan resistance to quinolones for whatever organism we were growing. We were growing Pseudomonas, followed by E. coli and other coliforms like Proteus and Morganella. And almost all of them were resistant to quinolones. So we have stopped using quinolones like ciprofloxacin or levofloxacin in our foot ulcer patients. But maybe in your center, if you are sitting at maybe primary care or secondary care, kindly have at least a prior 6-month data of what you are growing. And on the basis of that, in the first 72 hours, you can start those empirical antibiotics before you receive the culture sensitivity reports. The last thing I just want to say regarding antibiotics is the route. The route is also important, oral or IV. So it is recommended that for mild to moderate infection, you can safely give oral if the patient can have oral antibiotics. And few antibiotics have very good oral bioavailability like linezolid, clindamycin, rifampicin. Rifampicin is also used for some infections now. And if the patient is having severe infections, you have to give parenteral antibiotics for maybe first 6 to 7 days at the time of stabilization, and then you can shift to oral antibiotics. And the last question is about the duration of the antibiotics. So this is the choice of antibiotics, then route of antibiotics, last is duration. And duration is very, very pertinent to prevent multi-drug resistance. For simple soft tissue infection, give for 7 to 10 days. If it is osteomyelitis, it is recommended to give at least for 6 weeks of antibiotics. But yes, if you have removed the infected bone, you can give antibiotics only for next 72 hours after a surgery for the removal of infected bone, and prove that the bone, the part of the limb which is left behind after the surgery, should be sterile with a culture report, and just continue antibiotic for 72 days and everything would be fine. But just don't continue antibiotics with the aim of healing of the wound, because antibiotics is for infection. Wound will heal with debridement, dressing and offloading. Antibiotics only just one part of wound healing. But I have seen patients or a physician just continue antibiotics for 6 weeks, believing that this will lead to the appearance of the granulation tissue. No, it will not. Just give antibiotic for 7 days for soft tissue. That's good.
Absolutely. I think that's a very important component of using a proper antibiotic, because many times it's not used judiciously. So now coming to the next question is about how one should diagnose a case of osteomyelitis and how one should treat that.
So as I mentioned that osteomyelitis, best is clinical suspicion first via your examination. If the wound has a bone which is visible at the base, consider that it is likely to be osteomyelitis, because if you can see the bone, it is believed that organisms can also see the bone, and the infection is always from out to in. It's never the systemic infection that reaches up to the bone, at least in patients of diabetic foot infections. Second is, some people are fond of some serological markers like ESR, ProCal, and CRP for diagnosis. So it has been believed, and there have been papers from David Armstrong's group in University of Texas, and they found out that if somebody is having an ESR of more than 60 millimeters per hour, along with the ProCal, and CRP's value is more than 50, then you should consider that patient is likely to have osteomyelitis. But believe that ESR is very notorious and it can be falsely high in patients of anemia and CKD. But still, if both are increased, ESR more than 60 and the CRP is more than 40, consider osteomyelitis. And the next step would be a simple radiology like X-ray, as I was mentioned, which shows characteristical signs of the osteomyelitis on an X-ray, and even anybody can see in an X-ray and diagnose osteomyelitis on the basis of the focal demineralization of the bone along with a cortical breach and a fracture, which is seen when a patient have osteomyelitis. In few cases, we need to do an MRI, which shows typical T2 weighted hyperintensities or a marrow edema in the diaphyseal part of the bone whenever there is osteomyelitis. And rest is bone cultures which can prove it. So guidelines suggest that in addition to culture, you can also send histopathology, which can tell you the involvement of the bone. But sometimes I have seen that people confuse osteitis with osteomyelitis. And remember that MRI may not be useful for diagnosis of osteitis, because osteitis is just involvement or infection of the cortex of the bone. Only when it reaches up to the marrow part, then it is called osteomyelitis, and then it is more likely to be dangerous. So osteitis might not be considered to be treated with bone-specific antibiotics. Only osteomyelitis need to be treated with bone-specific antibiotics. So if MRI is showing T2 hyperintensities and marrow edema, consider osteomyelitis.
Thank you, Ashu. Now coming to the last question, that when should I consider surgical intervention?
Yeah, so that's triage is very important in ERs, emergency rooms. And whenever patient comes with severe sepsis or SIRS, along with depth of infection and the extent of infection, which is more than 2 centimeters, immediately consider surgery. Surgery should be considered in case of abscesses, which require immediate incision and drainage. Surgery should be considered in necrotizing fasciitis, and it's very important to diagnose and necrotizing fasciitis because it is life-threatening, and almost 60% of patients have mortality in this case. Surgery should also be considered in case of bad gangrene, in case of ischemic ulcers, which is infected, and in patients who have extensive involvement of the limb, surgery should be immediately considered. Surgery should also be considered if you are having a devitalized bone and you are considering osteomyelitis, then it requires the removal of the infected bone. The three things are most important. One is an abscess, second is necrotizing fasciitis, and third is wet gangrene, which immediately requires a surgical consultation.
So thank you, Ashu. So now we are at the end of this interview, and you have very nicely discussed about the classification of foot infection. Then you discussed about the organism spectrum. Then you discussed about which antibiotics are to be given, and the most important is how you should take a specimen for culture. And then we have discussed about osteomyelitis and the radiology and the surgical intervention. So thank you again.
Thank you, sir. Thank you for the opportunity. Thank you, sir.
Thanks a lot.
Thank you, Dr. Sambit and Dr. Asu, for this excellent deliberation. We are running little short of time. I'll request the chairpersons, Dr. Manoranjan, to reduce the session to 20 minutes because we are already 40 minutes late.
Okay,
So,
okay.
and others have told very well. Dr. Sen has not told anything, and you can manage that.
Okay, sir. So let us move to our panel discussion. So the panelists are Dr. Ghanshyam Goyal, Dr. Shivani Kumar Sen, Dr. Ashu Rastogi, and Dr. Sanjeev Kumar Bhai, and Dr. Kailash Chandra Mahapatra. So let me share my slide.
Manojan, I have some work. Can you just excuse me?
Sure.
Yes, you can go.
Okay. Thank you very much.
Thank you so much.
Sir, my slide is visible, sir?
No, sir, not visible.
No.
Achha. Is it visible, sir?
Coming, yes.
Is it full screen?
No. Slideshow.
Again, I'm trying. Sir, is it visible now?
Yes.
Full screen?
Yes.
So I have divided my questions on certain points on basic review, clinical features and diagnosis, screening and prevention, management, and some concluding remarks. I request all my panelists to be restricted to time and answer to be best or be focused towards our primary care physicians. And you know that we have come from a state which is resource constraint, where face is given more importance than the foot. And many people, many organizations, even lawmakers, they are coming for face rather than the foot care. and our aim is to focus on foot care rather than face. So my first question to Dr. Sanjeev, you are an eminent neurologist. So how often you come across with patients of peripheral neuropathy in your OPD, and how do you differentiate between a diabetic peripheral neuropathy versus non-diabetic? You have already told, but your answer should be very much catchy for our general physicians.
Yes, sir. Am I audible, sir?
Yes. Go on.
Sir, we see commonly peripheral neuropathy in our routine OPD in neurology services. But out of this, major chunk is the diabetic neuropathy patient, if there is a background history of diabetes. But apart from diabetic, we are seeing other form of neuropathy like radiculopathy, radiculoneuropathy, and these are the most common. And third is the vasculitic neuropathy due to other causes. But differentiating diabetic versus non-diabetic neuropathy, as I already said, if the symptoms are symmetrical, it's most common diabetic neuropathy, then you have to think of diabetic neuropathy. If they are having a predominantly focal neuropathy, upper limb, motor predominant, non-painful, and if you are getting other sign symptoms of vasculitis, then you are thinking something else. Thirdly is that we are getting more number of leprosy here, painting with neuropathy also. So that things should be taken care before jumping as a case of diabetic neuropathy.
So we are remaining in a country where the alcohols are more common, and vitamin B12 deficiency is also more common, hypothyroid. So there are also accompaniments. You have to keep
yes, sir.
all those things in
yes.
In account. Yes. Well, regarding the burden of diabetic foot in our country, particularly Odisha, if you know, its prevalence, social and economical. Dr. Goel, please. Dr. Goel, please.
Is not there. The question can go to Dr. Sen.
So, my question to Dr. Sen, what are the common risk factors? Particularly, I'm asking about our people. We are hearing the data from the Western people, but from our patient's sake, what are the common factors which are responsible the foot at risk and causes of diabetic foot in our developing countries?
Am I audible, sir? Hello?
Yes, very much audible. Yes, sir, you are audible, sir.
Okay, thank you very much. Good afternoon, everybody. The risk factor, first, I will rate diabetes mellitus and poor glycemic control. Because of this diabetes mellitus and poor glycemic control, there is glycosylation of the tissue. So what happens? Usually there is limited joint mobility, and even the maximum pressure is transferred to anterior foot because of the shortening of the tendo Achilles. Apart from that, in uncontrolled diabetes, there is hemorrhagical disorders also, like the blood become viscid, there is calcification of arteries, and there is also nitric oxide transport and formation is delayed, nerve growth factors are hampered. So because of this thing, so uncontrolled diabetes is the main risk factor. Apart from that, peripheral neuropathy, either the patient is in clinical or in subclinical stage. In both the thing, what happens? Patient do not know. Sometimes they have lost their sensation. That is loss of protective sensation. That is a sensory neuropathy. Patient doesn't know when he got his feet injured. Apart from that, in motor neuropathy, that is deformed foot because of claw foot, hallux valgus, hammer toes, hallux rigidus. These things happen. Apart from that, also there is gait deformities or gait abnormalities because of motor neuropathy. And people also get callus formation, cracked foot, web space infection. These things also happen because of this neuropathy. So apart from neuropathy, there is also vascular problem like ischemia, poor perfusion, poor delivery of oxygen and nutrients, calcification of arteries. These things happen in case of diabetes, and these are the main risk factor. Apart from that, poor awareness about foot care. People always give less importance to foot care, poor hygiene, foot hygiene, ill-fitting shoe, smoking and chewing tobacco, comorbid conditions like renal disease, retinopathy, cardiovascular disease. These are also contribute to risk factor. The main thing in our problem in our state is, rather I will tell, it is very difficult to motivate the patient, those who are having a loss of protective sensation in the foot, to wear footwear inside and outside house. Because of their occupation, because of the social problem, people say that we cannot put on footwear inside the house. When suppose somebody is working in the temple, we cannot force him to use footwear. So these are few risk factors we come across.
Yes, sir. Many people are barefoot already. Many people are barefoot, even they go outside also without any shoe. So, Marco, next question. Yes, yes. Yes, sir. Thank you, sir. Let's move to Dr. Asurastogi. So, sir, you are working in a tertiary care hospital. So, I would like to hear from you the burden of management of diabetic foot and diabetic foot ulcer. How? Because you know that diabetes is increasing proportionately and very rapidly, and so much the cases of diabetic neuropathy and diabetic foot ulcer. So, how do you see the burden of money management? Dr. Ashu, please.
So I think Dr. Ashu is there.
So I think he's not there.
So we'll restrict to Dr. Sen and Dr. Hoi. Others are not there.
Okay, sir. So when I can tell that the burden out of diabetic foot or diabetic foot ulcer is that the people will have a repeated visit to the clinic or hospital, and they have to use off-roading devices most often, and there is most frequent hospitalization, and they require more investigations, lab tests and imaging, and medication change also from oral hypoglycemia to insulin, and higher antibiotics cost, and often they need surgeries and specialized footwears, rehabilitation, and suffer from absent from their workplace. So these are the different burdens out of diabetic foot ulcer. So let us move to clinical features and diagnosis. My question is to Dr. Bhoi that you know that if you give an inch to a diabetes, it will take out a foot. So we need to diagnose this diabetic peripheral neuropathy at the earliest so that you can intervene and prevent the diabetic foot or diabetic foot ulcer. So what is your message how to assess and confirm diabetic peripheral neuropathy or autoimmune neuropathy in a primary care setting at bedside? And is there a role of biothesiometry or nerve conduction test? You have already described the role of nerve conduction test, but just a brief about the confirmation or assessment of diabetic peripheral neuropathy at the bedside. Dr.
Yes,
Bhoi.
thank you, sir. Sir, for bedside assessment is the gold standard, and all the patient himself should also able to assess this thing before coming to any specialist or a patient opinion. So the basic is that if a patient of diabetic is having some symptoms in the lower limb in the form of pain, paresthesia, dysphagia, numbness, then you are very pretty that he may be harboring a diabetic neuropathy. So if the symptoms are there positive like pain or the numbness is the negative symptoms, then go ahead with the evaluation of the examination. Examination showing that the ankle reflex is lost, and specific investigation like the small fiber, like I said, cold, and you can the pinprick if there is absent, or they are diminished as compared to the normal control, then you can pretty well say they are a small fiber neuropathy. For large fiber, you have to go for a monofilament test. And regarding the role of the VPT, the biased asymmetry, the major role is that it can diagnose around 35% of cases. Pretty sure that is a diabetic neuropathy, but that requires some instrumentation. Nerve conduction is not required. But if you do with a tuning fork test, the vibration perception threshold, that is a VPT, if you can simple 128 tuning fork, that it can diagnose around 31%. So with the extra machine, you can do more about 4 or 5%. So the basic is that with simple tuning fork, pretty sure you can diagnose 1/3 of the patient. And if the tuning fork is placed in a cold water, you can do the cold test also. So the basic bedside is that clinical history, examination of the signs symptoms of the lower limb, and third is the autonomic dysfunction. If the autonomic dysfunction, there is loss of hair, sweat is abnormal, not sweating, ulcers are there, craters are there, then you are dealing with a diabetic foot freedom. Thank you.
So a tuning fork, a cotton, a pinprick, it's sufficient enough to diagnose.
Yes,
in
sir.
our yes
In our
in our setup. So nerve conduction can be taken up some if there is some ambiguity in diagnosis, if it's suspecting some other
ambiguity is
cause
there.
like that.
Yes,
Yes.
sir.
Thank you very much. And my question is to Dr. Sen is when to suspect PAD and how to evaluate and establish each case of PAD, and is there any relevance? Because most of the time when you are diagnosing a case, most of them they send for vascular Doppler, CT, angio like that. Whether at what stage we can advise all those things high-end test, angiography like that.
Yes, sir. So first thing is, one as the doctor is to take the history properly, whether there is claudication or not. Patient will come sometimes complaining that previously I was able to walk for miles together, or 1 mile, 2 miles, but now after 200 meters, there is severe calf pain. And gradually the distance, claudication distance will also come down. So he will tell previously I was walking 1 kilometer, now I get pain after walking half a kilometer. Then after some time, he will tell still my condition is worse. So history is very important. Then local examination has to be done, like change of color of the skin, foot and toes. And also we have to record the temperature of the foot with a laser thermometer. So by that we can know that probably if the skin is cold or there is difference of temperature in both the limbs, definitely there is a chance of peripheral vascular disease. Then comes to palpation. So mainly two arteries are very easy to palpate. One is dorsalis pedis and another is posterior tibial. Of course, it is difficult to palpate when there is severe edema of the leg. But otherwise, dorsalis pedis and posterior tibial should be always palpated. And about already Dr. Goel has told about ankle brachial index. The simple method is you take one blood pressure cuff, measure the systolic blood pressure of the leg as well as of the brachium, that is brachial artery, and divide the ankle blood pressure by the brachial blood pressure. If it is 0.9 to 1.3, that means there is no chance of peripheral vascular disease. These are possible in any clinic anywhere. So apart from that, the valuable equipment which is not also very costly, that one handheld Doppler, that is probably 12,000 to 14,000 rupees. With that, we can know popliteal artery flow, dorsalis pedis, posterior tibial, anterior tibial. These we can see. If you want to go for further investigation, either you go for ultrasound Doppler scan or duplex ultrasound or CT angio. So these are the methods by which we can evaluate the peripheral vascular diseases.
Okay, thank you, sir. So Dr. Rastogi also already have described how to discriminate between uninfected ulcer from an infected one. We need not to go to that, but I would like to hear from Dr. Bhoi regarding how to discriminate between neurogenic food from ischemic or neuroischemic. You have already told that one-third peripheral artery disease and one-third purely neurogenic and one-third mixed. So people want to know whether it is a neurogenic food or a neuroischemic food, because the investigations and treatment also a little bit differ. Dr. Bhoi, please. Unmute. Dr. Bhoi.
Yes, sir. So all this differentiation is for the grossly one-third, but both the pathophysiologists start simultaneously. But in case of purely neurogenic, they may be dry, but in case of vasculopathy is also there, they will have other symptoms of claudication also, but both may be neurogenic claudication or a vascular claudication. But we say that only pure neurogenic claudication is the distance is affected during walking, but in case of rest also the vascular claudication effect. So it's very difficult to differentiate either purely neurogenic or it's the combination of neurogenic plus vascular. So unless you do the test and assess the artery in the distal part, whether they are pretty good in the artery pulsation or not, or you can do with the other modality of test like a Doppler test.
And
Dr. Alok Kanungo.
Okay, sir. How will
I think we have 5 minutes to go, Manranjan.
Okay, sir. Okay, sir.
We will close
Okay,
in 5 minutes.
Okay, sir. So let us move to few questions regarding management. One thing we want to know from Dr. Sen, what is your experience regarding the MRSA and ESBL organisms in diabetic foot ulcer? Because most of the time you know that it is polymicrobial, and as Dr. Asu also told, it may be monomicrobial and it may pan drug resistant. And how often you come across with such organisms, ESBL, MRSA, and pan resistance organisms in diabetic foot ulcer?
Sir, quite often patient come to a surgeon in late hours. So after treated by so many people, they come to me. So when people come to me, usually the infection is polymicrobial. And as Dr. Rastogi already told, MRSA infection is also only 10 to 15%, not more. But previously it was said that mostly diabetic foot infection was Staphylococcus aureus. But nowadays I get with E. coli, Klebsiella and Pseudomonas also. So ideally, what I feel or what I rather practice, if the wound is non-limb threatening, I always give oral antibiotics. And if it's limb threatening, I always give parenteral antibiotic and I advise for admission of the patient. So because Pseudomonas, E. coli, Klebsiella are dangerous organisms, along with antibiotic, I always go for wound debridement. Without wound debridement, I never start. I don't rely only on antibiotics. Along with the after wound treatment, wound debridement, I prefer also or I use negative pressure wound therapy. By that, what happens? The biofilm, which is the most notorious thing in diabetic foot infection, we have to remove that by wound debridement as well as by negative pressure wound therapy. So the antibiotic works better. So I definitely give meropenem. Preferred antibiotics is piperacillin tazobactam and amoxicillin clavulanic acid. These are my preferred antibiotics. But at the same time, one has to see which antibiotic I should give, which will be kidney friendly, because almost 30 of my diabetic foot patients are also CKD patients. So I have to see that one should not give quinolone group or vancomycin or tazobactam should be given in lower doses. These drug adjustment to be done. And about MRSI, I can tell
Manoranjan,
one.
we will stop here because the people have joined for the next session, and in virtual, unless you stick to time, they
Okay,
will not be
okay,
able
okay.
to run it.
So my last question, sir, to my esteemed teacher, Professor Ashok Das also. Sir, you are a great diabetician. What is your vision or plan or suggestion for enhancing diabetic food care in India?
I think the most important thing to be done here, we need podiatrists. We must have a program. Even a nurse podiatrist is good enough. Now, number two, I must tell you, there must be dedicated foot care center, dedicated foot care centers like Alok has in every big hospital, in every medical college, in every district hospital. And final thing, we must make one person in the team interested in diabetic foot. That's what they have done in Ashu. That's what done in Sanjeev. That's what they have done in you, done in Alok's centers and Sen. And it has to be done. Great session. I must tell you that it has been a great session. I liked all the talks. I liked the talks by Ghanshyam. I liked the talk Sanjeev. Where is Sanjeev? Dr. Bhoi, are you there? It was a seminal talk, Dr. Sir. You be in touch with me and just send me your email ID. I'll take it. It's a fantastic talk. One of my interests is diabetic neuropathy, and you covered everything so lucidly, Sanjeev. It is great. And the talk by Dr. The interview between Sambit and Ashu was superb. No, what do you think, Manoranjan? Great.
Yes, sir. Great session.
And everything they covered. And Manoranjan, your interest in diabetic food is great, but you are a chupa Rustam. I mean, you are not showing you have drafted all the questions very well. And Dr. Sen, I know you from eternity, and I'm very happy that you give so good answers. Sanjeev.
Thank you, sir. Thank you.
Yeah. We have to stop it now, and we have
Thank
to
you,
go
sir.
to the session. And what happens that we have to finish by 8 o'clock. So unless we
Okay.
start now, we'll not be able to finish because they have joined their waiting and they will go away. So that's the reason why I'm requesting Manoranjan Babu to kindly stop it now. And I thank profusely on behalf of Dr. Alok Anandgo for your great. It has been a great session, and I'm going to contact Sanjeev. We can publish it because I
Thank you,
read
sir.
in journal. Sanjeev, your talk was good, and I want to publish it. And also the interview. Of course, Alok and me are discussing about it, how to do it. Thank you very much.
Thank you,
Bye-bye.
thank you, sir.
Thank you,
Thank you all the
Dear
panelists.
friends, we will now pass on to one of the very important session, and that is the session on the strong basal. You see the wording. The strong basal means really strong basal, and it's a session which has got great speakers and discuss about the molecule of the decade, the long acting basal insulin of the decade, and I will just send the context. And then I'll ask Security Jana to kindly take over. Security, are you there? Security, are you there?
Not there. I'll take her place.
Okay, you'll take her place. So now this is the session which is called Strong Foundation of Insulin. That is called basal insulin strong foundation. Now, why it is called strong foundation? It's called strong foundation because this has been the basal molecule of the decade, and it has stood the test of time. It has become an insulin, basal insulin, which is affordable, which is appropriate, which is accessible and available. I will not take long time. I will now start the session, and maybe Alok.
In our clinical practice, possibly 80 to 90% people do not agree to take insulin even if it is required. In those situations, by introducing a low dose of basal insulin, particularly glargine and that to lantus, people accept it because for two reasons: single daily dose and there is no hypoglycemia. By giving lantus or Tugio or glargine 100 and 300, a doctor can sleep comfortably without the fear of hypoglycemia. To discuss on this, we have a academic support from Sanofi India Limited. And we have three speakers, Dr. S.S. Mangaraj, who will be speaking on patient-centric approach to glycemic control with basal insulin. Dr. Madhusmita Sahu will be talking on precision insulin management, maximizing generation to basal insulin across patient population. And Dr. Arundhati Dasgupta from Siliguri addressing unmet needs in diabetes treatment paradigm with innovative combination and injectable. The session will be moderated by none other than Dr. Ashok Das and Dr. Devarchan Jena, HOD Endocrinology, SCB Medical College, will also join us as a panelist. Dr. Mangaraj, please.
Actually, yeah, I'll request Dr. Mangaraj is MD, DM Endo, and he's Associate Professor Endocrinology at the IMS and SOM Hospital. He is the National Runners-up for the ESI TISA 2016, 43 publications, and has been fabulous. It will be great to listen to Dr. Mangaraj on this particular topic, the molecule of the decade, the glargine.
Thank you, sir, for your kind words. At the outset, I would like to thank both the stalwarts, Ashok sir and Kanungo sir, for having me over here. And I'd like to congratulate both of you for working so tirelessly for last so many years for bringing NUCD to the forefront of science. So at the outset, I would like to also thank Team Sanofi for giving me the opportunity. And as already Alok sir has told, I will be and Ashok sir has told, I will be speaking on basal insulin with regards to a patient-centric approach, how optimal glycemic control could be achieved with addition of a single agent when we fail to achieve that with multiple number of OAD in the current clinical practice. So to start with, let's go through and delve into the data which we have, how glycemic control is currently in our country. So this is the data from landmark trial, which has been taken into account for almost more than 6,000 Indian patients, and longitudinally these have been followed up for up to 3 years. And I think Ashok sir has been one of the principal investigator in this trial. So what they have shown is roughly around 1 in 5 patients have a so-called good glycemic control as endorsed by the A1C target by ADA, and that number is not very significantly different even in the Western population. A lot of studies have shown roughly 70% of the patient do not have a good glycemic control despite the availability of a plethora of molecules including insulins. Second is, if you look at what kind of patient we have in India who are diabetic, majority of these are either obese or overweight, and we do know that obesity itself adds a lot of other problems, compounds the complications what we are going to face from diabetes from per se. If you look at the complication status, this may be an underestimate, but you can think that roughly around 18 to 20% have evidence of these complications right away in the initial part of the disease. And once your patient has obesity, just look at the number, the risk is almost 5 times higher for any diabetic complications vis-a-vis those who are having a normal BMI. So optimal glycemic control and weight control. So the pandemic of diabetes has to be taken into account while prescribing any pharmacotherapy for diabetes. Now let's move on to the state of pharmacotherapy. How well our patients are doing. We do know that even if you add, we have now 12 class of different agents which we can use for treatment of diabetes mellitus. But if you go on escalating the number of oral anti-diabetic drugs, it is well known by multiple studies that beyond the number 3 or 4, the glycemic benefit is not going to be so great. Rather, once we switch from fourth to fifth agent, the paradoxically A1C may rise. That is what also has been shown by the landmark trial. Roughly 1 in 4 Indians take insulin for the management of diabetes, and there are a lot of factors that contribute to it, starting from the clinical inertia that we see from the physicians and the fear of taking an injection from the patient. Remember, a good amount of 6 years is lost eventually before a patient is put on insulin, because we continue to give them multiple OADs due to a lot of factors, and the insulinization is considerably delayed. This delay perhaps culminates in enhanced risk of both microvascular and macrovascular outcomes in the foreseeable future. Look at the A1C. The A1C is almost more than 9% by the time a patient is put on insulin, and even if it is more than 9, many patients continue to remain on OADs despite suboptimal glucose control. So we now go on to a real world clinical case based approach. So this is Mr. Alok, who is currently 52 years old. His BMI is around 27.8. He has been diabetic for 7 years, works as a grocery shop owner. Now, if you look at the glycemic control, it is poor. A1C is around 9.2, fasting of 194, postprandial of around 256 milligram per deciliter. He is having hypertension. If you look at the molecules on which the patient is currently on, the patient currently takes a secretagogue in form of glimepiride 4 milligram once a day, metformin 2 gram, and a gliflozin once a day. The pressing issues apart, if you look at focus on the glycemic parameter, the patient is poorly controlled. There is no doubt regarding that. Patient is overweight and the patient also has hypertension. Now, how do you approach this case? Remember, due to the availability of different class of agents, the choice of drug may differ for every physician in this scenario. But what I would like to suggest is, if you focus on insulin, how do you like to optimize the therapy? So if you look at the endorsement by the guidelines, you pick up any global guideline, be it ADA, ACE, ESD, or even our national RSSDI. One of the easiest way to initiate insulin is just starting an basal insulin, because it, with the virtue of only a single prick, you are going to deliver an agent which is going to take care of your glycemic excursion. And roughly, if you ask 100 patients in your OPD that you need insulin, you have to take insulin, majority of them, including medicos, would ask you to defer that agent, because they do not understand that insulin is a form of therapy, not because that they are unable to manage their diabetes, they have managed it badly, or they are non-compliant, we are putting them on insulin. Hence, the subject of initiating a discussion that perhaps diabetes mellitus is a chronic progressive disease and insulin would be required in your journey of the disease. The only thing which you are not sure of is how early or how late the molecule might be required. So if you put a basal insulin, because of the elevated fasting goes out, your PPG spikes can still be maintained with the baseline OADs that you currently take. If you talk about glargine U100, almost more than 2 decades the molecule has been with us. It can be safely injected at a particular point of time of the day, repeated again during the same time. It gives you a good control over the disease and offers you also flexibility. Now coming to another agent, insulin, especially premix insulin, which are quite common in our country, especially during the initiation phase once the patient fails OAD. So what this landmark trial has shown is, if you compare from the baseline to 3 years, what authors have shown here, that the control is almost kind of similar if you initiate a patient on OAD plus basal versus a patient who is given premix twice daily. So despite giving one extra dose of injection, the glycemic benefit may not be remarkably different. Both the agents could continue to give you benefit even from the follow-up up to 36 months, because it is a real world clinical scenario that we currently see and published by reputed authors from our country. This is what you are going to see in your practice as well. Hence, initiating an basal insulin is the bare minimum when you think the patient is insulinopenic, classically has signs of insulin deficiency. Do not delay just by adding other oral anti-diabetic agents when the actual need is for an basal insulin. Now, this is the pooled data from the Fine Asia and Gold registries. So what they have shown is that once you initiate a patient on glargine U100, the baseline A1C was around 9.5%. You look at the A1C at around 3 months, it has dropped by 1.3%, and at the end of 6 months, it has come down to around 2%. So roughly, by addition of a single prick, the target A1C of less than 7 is achieved by around 31% of the patient. And if you look at a more relaxed A1C target of 7.5, that's also not very bad in our country. It is around 62% would achieve that even with a single agent like an glargine. The problem with insulin is two. One is, while you intensify, you face two demons. One is hypoglycemia. The second is weight gain. Hypoglycemia, because intensification of insulin is a double-edged sword because of the risk of hypoglycemia. The fear is instilled both in the minds of physicians and the patients alike. Now coming to the tackling the concept of hypoglycemia by different agents. So if you compare premix twice a day versus glargine, the glargine plus OAD group scores over because multiple studies have shown even if the glycemic control might be bit better with premix twice a day, the overall and nocturnal hypoglycemic risk is significantly higher in them. Not only premix, if you compare analog premix like bias 30, even in those, this they have shown that glargine group had significantly lesser risk of confirmed hypoglycemic events versus bias 30. Newer generation insulin top up class like IDEC ASP. So comparative study have shown that IDEC ASP might be superior with regards to glycemic control versus glargine U100. But you look at the hypoglycemic episodes because of intensification in phase where you try to bring down the blood glucose, the risk of hypos may be high with IDEC ASP. Coming to the second problem, weight gain. So here also, because the units requirement by a glargine U100 are considerably lesser, around 33% lesser than bias 30 and 11% lesser than IDEC ASP. For that virtue, the weight gain component is bit less with glargine U100. And because many times we put patients on metformin, SGLT2 inhibitors, these are also weight neutral or weight reducing property that may also help to offset the weight that is gained by the use of a glargine U100. Now coming to compliance. So this study was published couple of years back, way back in 2013, in which authors have shown that if you look at persistence with a particular agent, glargine persistence was significantly higher in cumulative follow-up versus patients who are put on premix and intensified. Hence, not only the molecule gives you good glycemic control with less risk of hypo, less weight gain, but it is durable in its action and also the patient compliance is much, much better. Now coming, because the molecule is off patent, we have a market which is flooded with biosimilars and glargine has been brought under the essential medicine list. So the price benefit, which was earlier the price war which was there with innovator versus generic, is not there. If you compare innovator versus any biosimilar, the kind of 3 ml cartridge costs the same amount of bucks your patient is going to spend because healthcare expenditure in India is out of the pocket. So if you are going to give an innovator molecule at the price of biosimilar, I think there is no doubt or debate regarding the efficacy and safety. Coming back to our patient, Mr. Alok. So when the next choice would be starting an basal insulin in this particular segment of a glargine U100. You can start right away. Like let's say 10 units, also a reasonable option if you don't want to escalate right away. But 0.2 unit to 0.3 unit per body kg weight is an appropriate choice. So currently in around 80 kgs, 16 units what you can safely start with. Then you can intensify or de-escalate based on the fasting plasma glucose. That can be done as frequently as a week or twice weekly with a SMBG pattern or in a lab pattern. So with that you can follow up your patient and the further titration can be done. Now coming to the durability of the drug. Just look at the study. When the insulin was initiated, the mean A1C is around 8.7%. With 3 months, it dropped down to 7.2, and by end of 9 months, it was around 7. Just look at the years spent in control. The A1C of less than 7 was maintained for more than 2.5 years despite patient on OADs and just one basal insulin. The dose increased from 14 to around 10 units within 2.5 years. Not much escalation, but the control continues to remain good. So the thing is, if you are choosing your patient well, giving them optimal doses of OADs, you can still control with a single shot of basal insulin. Now coming to efficacy, when your patient is failing because diabetes mellitus, especially type 2, is a chronic progressive metabolic disorder, beta cell dysfunction will ensue eventually. So you might require the help of a rescue medication like a prandial insulin. So here what I have shown is a basal plus. That means you are added a prandial in form of glulysin and glargine versus premix. So what they have shown is that efficacy, it is non-inferior versus premix twice a day when you give glargine once and one glulysin in the principal meal of the day. Safety, the hypoglycemic endpoints in the all to target trial and the Galapagos trial were both in favor of a basal plus regimen versus premix. So it is safe and the hypoglycemic endpoints are much lesser. Talking about flexibility, so you can personalize because giving a prandial at the major meal of the day when the glycemic surge may be high can be titrated. Remember, premix is a fixed component. The basal target may not be achieved with a premix twice a day. You may need the help of a basal. Hence, the overuse of IDEC ASP in current scenario because of the good basal by Digludec. Similarly, basal plus with glargine once and glulysin is sufficient enough. And I have shown you data. The compliance is much better in these patients and continued to be driven well versus premix twice a day. Now, as I told you, we can progress from a state of insulin resistance to more of an insulinopenia with resistance as the metabolic disorder progresses over decades. So once your beta cell dysfunction ensues, you might need the support of an prandial intensification. That can be done with a basal plus approach, giving an basal insulin and addition of a prandial component in the major meal of the day or a meal of the day when the glycemic surge is anticipated to be the maximum. Second, the risk of hypoglycemic episodes and weight gain is lesser versus premix twice a day. The dose titration, this is very, very essential for us as clinicians because the basal is going to give you a fantastic fasting plasma glucose control, which may not be that great when you initiate premix. I do understand that premix would also do the job in many patients, but there are subset of patients who definitely require a basal insulin, and hence in those kind of patients, basal plus with a basal insulin and a prandial shot would be better than putting them on premix twice a day. So this stepwise escalation is what is needed. Eventually, the patient might require a basal bolus, but the proportion of patients who require that is much lesser in contrast to patients of type 1, because eventually all of them would require that therapy to achieve good glycemic control. We are fortunate enough in this era because we have many other agents which have CV benefit, renal benefit, can be added with insulin to mitigate the risk. So adding those kind of agents like GLPs, metformin, DP4 inhibitors, SGLT2 inhibitors can definitely help us in bringing down the insulin requirement and giving a superior glycemic control. This concept of basal plus has been studied widely, including Opal, Eleanor, and START trial, in which various group of authors across ethnicities have shown that basal plus is a very good thing to start with in the early part of the disease when initially OAD failure ensues, and good glycemic control can be achieved with one prandial plus a basal agent. So as already told, basal plus has its own merits and demerits, and there is data to suggest that the efficacy might be kind of similar from premix twice a day, but the risk of hypoglycemia is significantly lesser with the basal plus. The weight gain component is bit less with the basal plus. And remember, when you are trying to target a deranged fasting plasma glucose, control may be much superior with a basal plus regimen or a co-formulation like IDEC ASP versus going for premix twice a day, because there is a fixed component and intensification, both escalation and de-escalation are bit trickier with premix twice a day. So I would like to summarize here that once your patient fails a baseline oral anti-diabetic therapy, please do not waste the time. Data have shown that a good amount of 6 years is lost. Eventually, a patient is put on insulin. We should, as clinicians, it is our job by learning science, we should cut down that time period so the complication burdens can be reduced. So put them on a basal insulin, fix the fasting first. It will take care of the glycemic burden up to 2 to 3 years with that same set of oral anti-diabetic drugs and a basal insulin. Once you fail that, you need a prandial support, go for a basal plus regimen in which a basal insulin and addition of a prandial component, preferably short acting component, can be added to the principal meal of the day to control the glycemic spikes and that also can take care of your glycemic control for a couple of more years, and that may be better suited in patients who have recurrent hypo, more weight gain, and they might be better in that regard when you are comparing premix twice a day with a basal plus regimen. And with that, I think I will end my presentation here. Thank you all for your patient listening, and we can have some questions if there are any.
Professor
Thank you, sir.
Mangaras, this has been a great presentation. I think you started with where it is indicated, more than three orals. You quoted our very famous landmark study. I'm so thankful to you. You also quoted regarding the issue that in India, we start late. And even if we start late, we don't escalate. And you said at the beginning itself, we lose 6 years. And how many years to lose by not escalating is not been calculated. You talked about the fixing first thing first. You said about starting, escalating appropriately, and also spoke about the beautiful way of you ended your talk with a basal plus. And it has been great talk, very simple, and I'm sure that we may have some questions at the end. Thank you very, very much. At this point, I'll pass on to Dr. Madhusmita Sahu. Can I have the credentials, Madhusmita Sahu, please? Madhusmita Sahu is MD and DM Endocrinology. She has been faculty speaker, faculty chairperson in the state and national meeting. She has 4 publications, and her article received the Best Original Article Award in the Indian Journal of Endocrine Metabolism in 2022. Presently, he is the consultant endocrinologist at the Utkal Hospital, Bhubaneswar. Over to Madhumita Sahu to speak on a very important topic, precision insulin management. Precision insulin management, maximizing Gen 2.0 basal insulin across patient population. Madhusmita.
Hello, everyone. Thank you, chairpersons, and thank you, organizers, for giving me a platform to speak. I'm Dr. Madhusmita Sahu, and I'll be talking today about Generation 2 basal insulin 2GO and its use across patient populations. So, whatever the strategy of treatment is, diabetes is progressive because of the progressive loss of beta cell functions. And in such cases, the control of glycemic status is very much required for preventing macro and macrovascular complications. But various prospective longitudinal studies observed all over the world shows that the control is suboptimal in many cases. Coming to this landmark trial, which is one of a kind, which happened in over 369 sites across India, with eligible 6,000 patients, they found that 4 out of 5 people with type 2 diabetes are uncontrolled in India, and less than 1 in 4 Indians with diabetes take insulin. And average HbA1c at which insulin is initiated is around as high as 9.2%. And this is the Indian reality of diabetes control. That means when the patient has conventional stepwise treatment approach, that is monotherapy followed by dual combination, then triple and then insulin, the people experience prolonged periods of poor glycemic control, which is detrimental to long-term outcomes. Patients, they lost 7 valuable precious years before intensification of treatment with insulin. And when the patient are started earlier and more aggressive treatment intervention approach is applied in such patients, the glycemia may improve patients' chance of reaching to the goal. Now, the simple question, why generation 2 basal insulin over the first generation? For the simple fact that second generation basal insulin helped to find the right balance between A1C reduction and hypoglycemia. It has n number of benefits, like it has safer titration, it has minimal weight gain, it has flexible dosing of 4 to 6 hours. They have stable and prolonged action because of known pharmacokinetics and dynamics. There is less glycemic variability, effective and sustained glycemic control, and less overall nocturnal hypoglycemia. So the strong evidence for Glargine 300 has been found from n number of studies over years together, where time and again they have been compared with Glargine 100 and Degludec. So what happens in this vulnerable population is that hypoglycemia is a risk in this population. So recurrent hypoglycemia, if they occur in these patients, they will not stick to the treatment plan, and there will no titration possible in these patients, and there will be less glycemic control, and the patients will be facing all sorts of complications of diabetes. And with that thought, the U300 glargine has been studied in elderly renal impairment patients and all the vulnerable group of patients, be it Edison trials, be it ATOS, BRIGHT, and DELIVER. All data are in favor of glargine 300 use in such populations. So we'll go one by one. First is the BRIGHT study, where the glargine 300 was compared with degludec 100 across all EGFR groups, and they found that with a comparable risk of hypoglycemia between the two groups, there is greater HbA1c reduction with glargine 300 to the tune of 0.7%, which was consistent across all groups of EGFR. Now, coming to the ATOS renal trial, in line with the previous study, it is also showing that there is a gradual but substantial decrease in HbA1c over 1 year from the baseline. And you can see the numbers, almost 28% of renal impairment group, they achieved the target HbA1c over 6 months. And in the no renal impairment group, almost 25%, they have achieved the target HbA1c in 6 months. And the overall incidence of hypoglycemia was very low, that is 0.5% in renal impaired and 0.05% in no renal impaired, for obvious reasons. Now, coming to the real world data, this is very different than the RCTs, because this is the real world data. So such real world data is this, where data from 1712 patients with available EGFR at baseline were pulled from 24 weeks prospective studies, and after 24 weeks of glargine 300 therapy, there was a HbA1c decrease from baseline, and the proportion of patients achieving HbA1c less than 7.5% were comparable across the subgroups of the EGFR. And the incidence of hypoglycemia was overall low across all the subgroups of CKD patients. And so this U300 provided glycemic improvement with an overall favorable safety profile, regardless of the baseline EGFR. Now, this is the other real-world data, DELIVER, where they found that people with type 2 diabetes and mild to moderate renal impairment switching from one basal insulin to either glargine 300, they result in similar HbA1c reduction and significantly lower all hypoglycemic incidence than a switch to a first-generation basal insulin. Now, coming to the elderly population, this is ATOS elderly, and all the results of beneficial effect of U300 was also seen in elderly subgroups of patients. That is, the HbA1c reduced from baseline to almost 1.5 at month 6 and almost 1.8 at month 12, and overall incidence of hypoglycemic events were low at all point of the time. Now, this is DELIVER 3 study. It is also showing to have lesser hypoglycemic effect after switching to glargine 300 versus other basal insulins in older patients with type 2 diabetes mellitus. So the conclusion of DELIVER 3 was that potential implications of this real world study are that improved glycemic control and lower hypoglycemic risk could lead to better treatment persistence, improved patient satisfaction, and lower costs. And these results have potential significance for basal insulin therapy in older adults with type 2 diabetes mellitus, since such patients carry a disproportionate risk of hypoglycemia and its adverse clinical consequences. This is another senior study. This was an open label study where glargine 300s were effective in older people more than 65 years with lower rates of any documented symptomatic hypoglycemia, and the reduction of HbA1c was comparable in both the groups, glargine 300 and glargine 100 groups. Now coming to the other vulnerable populations, that is type 1 diabetes mellitus, where there is absolute insulin deficiency, and patients who are fasting due to religious purposes. Coming to the first type 1 diabetes mellitus, in this subjects, these subjects were naive to either glargine 300 or degludec 100, but they were treated with 3 months of optimal titration phase. It was seen that there is a 20% greater insulin peak with degludec versus glargine 300. You can see the flat profile of glargine 300 than the peak of degludec. Similarly, there is 23% lesser within day variability was seen in glargine 300 versus degludec 100. The other study is one case study in the adult type 1 diabetes patients, where adults with type 1 diabetes were on first generation of basal insulin more than 3 months, and they were switched to either glargine 300 or icodec 100, and it was seen that all the parameters were comparable between the two groups, and the U300 group had a better nighttime glycemic status. This was also seen. They were also compared with glargine 300 to glargine 100, and in this 16-week randomized crossover study, it was seen that glargine 300 improved glycemic variability irrespective in injection timing, and there was a smoother glucose profile and lower nocturnal hypoglycemia, and there was similar HbA1c reduction between glargine 300 and glargine 100. Now coming to the Orion study, where it was seen in Ramadan, doing people with fasting, it was seen that in those patients, they did not have any severe hypoglycemia during Ramadan or post-Ramadan, and there was consistent decrease in HbA1c. Not only that, there was also decrease in fasting plasma glucose to the tune of 13 milligram per deciliter. So in a real-life clinical practice setting, glargine 300 was associated with positive outcomes in adults with type 2 diabetes mellitus who choose to fast during Ramadan, and the results support the use of glargine 300 as basal insulin for people with type 2 diabetes mellitus who intend to fast during Ramadan. Now, what about the people who are hospitalized? So to compare that, the efficacy of safety of glargine 300 and degludec on glycemic control using CGM in hospitalized patient with type 2 diabetes mellitus. It was a randomized crossover study, and the primary endpoint was mean percentage of time within the target glucose range of 70 to 180 milligram per deciliter. And as we can see, there is comparable time in range for glargine 300 versus degludec in this study, and there is decrease any time of hypoglycemia, nocturnal hypoglycemia, and severe hypoglycemia, which was seen in glargine 300 versus degludec. Now, can we use glargine 300 in pregnancy? Yes, we can use if clinically needed, though it is not approved. It is from this data, the safety of glargine 300 use during pregnancy was using post-marketing pharmacovigilance data. Cases were recruited from 44 countries, and 246 exposures of glargine 300 was during pregnancy, and it was shown that use of glargine 300 during pregnancy was not associated with severe specific adverse events for congenital abnormalities, and the results suggest no safety issues with use of glargine 300 during pregnancy. Now, the device makes all the difference, because there is less volume of U300 needs to be injected than U100 for similar insulin dose. There is a dedicated cartridge, there is a clear dose display and flexible dose selection, and the simple dose delivery is there. There is a short dial extension, low injection force, no rotating dose button while injecting, and 5-second hold time. Now, I may conclude that with this all wall of evidence for Gladgen 300 studies done in all vulnerable populations, including type 1, type 2, and CKD and elderly populations, and with its all n number of benefits like this less hypoglycemic effect, there is more flexibility of injection, there is same unit to unit cost. For this these benefits, I think Gladgen 300 is one of the most shorted generation 2 insulin to be used nowadays. Thank you.
Thank you very much, Dr. Madhumita Sahu, for the very, very clear exposition of what you wanted to say, and it has been great. I have no audacity to summarize, but I must tell you that you have really complemented what Dr. Mangaraj had spoken and taken us through the various trials, starting with the Bright, the Real 1, the Deliver 2, Deliver 3, and also all the trials. And you have shown that how this drug and I beautifully like that the wall of evidence you presented at the end, and that summarizes all the studies. Be staying back with us for if there is a question at the end. We're having about 10 minutes only for panel discussion. Kindly stay with us. Dear friends, it's my great pleasure now to invite Dr. Professor Arundhati Dasgupta. I must tell you that Arundhati Dasgupta has been one of the most promising and one of the most favored speakers across the country because of her real life achievements, her clear diction, delivery, mastery over the subject. I have much to say about her, and but in the interest of time, I will just tell you that she is MD Medicine, DM Endocrinology, and he has a she has got a FAC, the director and consultant endocrinologist at the subspecialty hospital in the Siliguri, and Evi Gandhi award winner, Diabetes Awareness Initiative award winner, and many award winners. And she's a national faculty in almost all the meetings. She's going to speak to us on a very important topic, addressing the unmet needs in diabetes treatment. And therefore, there's a paradigm with innovative combination injectables. How do we address these unmet needs by innovative paradigm combinative innovative injectables? Over to Arundhati. We can start Arundhati's talk now. Yes.
The organizers of Nucd for inviting me over. It's always a pleasure to be a part of this wonderful program. So today I've been assigned with the talk of talking about the unmet needs in diabetes treatment paradigm and how can we solve it with the use of an innovative combination injectable. So when we talk about unmet needs, we are aware that there are so many unmet needs in type 2 diabetes management. With the best of our efforts, we still do not reach there so many times. We have so many glucose-lowering therapies at our disposal today, and yet when you look at the numbers which remain controlled in the target, they are abysmally low. So why so? Because firstly, when you're talking about even the insulin regimens, when you at last convince the patients to take up insulin with the failure of the OADs, there are still so many issues to be taken care of, like the multiple injections which need to be fitted into the frame of the lifestyle of the patient, which brings about a reduced flexibility in the day-to-day working. Of course, there's this risk of hypoglycemia, and you're concerned about weight gain, and also the potential treatment burden of these complex treatment regimens because of the lifestyle adjustments and the injections and the dietary changes and the physical activity that needs to be looked into. For us, it's very easy to write down a regimen, but when it comes to implementing that and continuing that implementation across your work, your family, your programs, your festivals, at times it does become a little difficult. We have to admit that, and that is one of the major reasons why we are not achieving our goal, even with so many available options. So today we will be talking about the combination injectable. We are talking about two titrable drugs. One is basal insulin, the other one is GLP-1 receptor agonist, and when both of them have been combined in one single injection, it's known as combination injectable. So we're talking about Iglar-Lixi here, which is a combination of glargine U100 and lixisenatide, a combination which has been approved in India. Firstly, when you look at the science behind this, when you're looking at the pathophysiology, the octet, and you're looking at this combination with the GLP-1 RA, we know we are kind of attacking a lot of these areas where you're talking about the glucose-dependent insulin release, the glucagon release, which is, again, glucose-dependent, the satiety, the gastric emptying. And when you're putting in insulin with that, you're taking care of the hepatic glucose production, the gluconeogenesis, the uptake in the muscles, and also the lipolysis. So basically, 8 out of 7 areas are being taken care of, with just leaving the kidney behind. All the other areas are being taken care of by this combination. Also importantly, whenever we are putting in a combination, it is important to understand, are they complementing each other? So here, when we're looking at glargine U100 and the GLP-1 RA lixisenatide, you can see that in a way they're complementing each other's deficits and adding on to the benefits. So once you have a once-a-day dosing, you have weight neutrality. Rather than, had you been putting the patient only on insulin, or maybe up-titrating the dose of insulin or adding a basal bolus, there would have been, concerns about weight benefits, I would say, or weight neutrality, which is not there. There is no additional risk of hypoglycemia, again, versus an intensified insulin regimen, and the GI tolerability versus the mono components, and which will thereby result in more people achieving targets, because you're addressing the major pathophysiological deficits. Both fasting and PP are being brought into control here. Remember, with the glargine taking care of one and the GLP-1 taking care of the other, thereby bringing about effective HbA1c reduction. So today we have the recommendations in terms of the global guidelines, ADA 2024, saying that the combination has a potent glucose-lowering action and less weight gain. ACE 2023 says that if you have a failure of OADs or a failure of monotherapy with GLP-1 RAs, then you can add a basal insulin to it alone or as a combination, thereby bringing in the benefits that we have discussed in the previous slide, which is also in sync with what ADA ESD 2022 guidelines says, that in terms of the combination usage of GLP-1 RA and basal insulin, there is greater glycemic lowering efficacy, lesser weight gain, and lower rates of hypoglycemia. Now let's look at the evidence that we have in our hands as of now. This is the wall of evidence. We've had phase 3B trials, phase 3 trials, the real world evidence trials, and of course, putting it all together in the review and the meta-analysis. Looking at the first trial in discussion here about, where you're talking about Iglar-Lixi versus the IDEC-ASP. Now, in a patient who is suboptimally controlled on OADs. So this is it. The study, it was a 24-week open-label phase 3 study. You are comparing the efficacy of Iglar-Lixi with the premix insulin IDEC-ASP, but this was done in a Chinese population. As you can see, the BMI was less than 40. HbA1c was between 7.5 to 11 if previously on metformin plus minus SGLT2, or 7 to 10 if previously on metformin plus a second non-SGLT2 OAD. So we were putting the patients on once daily Iglar-Lixi and IDEC-ASP once daily, carried across 24 weeks with a follow-up of 3 days, and then looking at the primary endpoint of non-inferiority in HbA1c change from baseline to week 24. The key secondary endpoints, as you can see, was the superiority in the change in HbA1c from baseline to 24, change in body weight, proportion of patients reaching target, without weight gain, and no hypoglycemia. That is the best situation, less than 7, no weight gain, no hypoglycemia. Also looking at other secondary endpoints, like change in fasting, SMBG, the proportion of patients again achieving with no hypoglycemia. And as you can see, that also looking at the safety endpoints. Now, when we look at the results, you can see that the group that was studied was comparable in almost all ways: age, female, BMI, duration of diabetes around 8.5 to 9, HbA1c 8.5 and above, and 51% in both groups using an SGLT2 plus metformin. So what do we have in terms of a reduction in HbA1c? You can see that if you're comparing these two results, there was a slightly better reduction in HbA1c from the baseline with the use of the IGLAR-LIXI. You can see there as compared to the IDEC-ASP, 6.83 versus 6.58. So the results there with being clinically significant for non-inferiority. In terms of body weight reduction, also you can see results better with the group, with the IGLAR-LIXI group as compared to the IDEC-ASP. And when you're looking at the key secondary endpoints, you can see in each of these areas, particularly if you're looking at the third point where it's less than 7, no weight gain, no hypoglycemia, the results are significantly better with the IGLAR-LIXI group as compared to the IDEC-ASP group. And when you're looking at the SMBG profile, this is the SOLID-D study we're talking about. So SMBG profile across from baseline to week 24, and you can see there have been very minimal differences with the mean difference being minus 7.93. Also, the change in PPG being looked at from baseline to week 24, you can see post-breakfast, post-lunch, and post-dinner, all of them favoring IGLAR-LIXI as compared to IDEC-ASP. Also, if you're looking at the total amount of insulin requirement, again, the requirement was slightly lesser at 28.2 as compared to slightly higher levels with IDEC-ASP at 34.1. Important area of discussion, the hypoglycemia. Incidence of hypoglycemia, again, the incidence being across the levels, you can see lesser with the IGLAR-LIXI group, and particularly nocturnal hypoglycemia was lower with IGLAR-LIXI, 2.8% versus the IDEC-ASP, which had an incidence of 5.8%. All in all, if you're talking about any hypoglycemia, there was a decreased incidence of hypoglycemia to the tune of minus 29%. So in summary, the SOLID-D study said that when you're comparing IGLAR-LIXI head-to-head with IDEC-ASP, there was non-inferiority in terms of HbA1c, better weight gain benefits. Better weight benefits, I would say, not weight gain benefits. More patients had composite endpoints, low risk of hypoglycemia, and no unexpected safety findings. Now, when we're looking at IGLAR-LIXI versus individual monocomponents, and we take a look at this LIXI-LAN-O study, which is basically a phase 3 study looking at the superiority of IGLAR-LIXI over lixisenatide and non-inferiority over IGLAR. So you're comparing each of it separately, and you're looking across it over a period of 30 weeks. 7 to 9% is the baseline HbA1c, or if receiving 2 OADs. And the primary endpoint, as you saw, again, was a reduction in HbA1c. So as you can see, with this combination, had you been using only IGLAR or had you been using only lixisenatide, this combination, is it giving benefit? Yes, it is. In terms of HbA1c reduction, which is significant, fasting plasma glucose, a 2-hour PPG, a 7-hour SMBG profile, or ultimately the individuals at target. So in all these components, when you're comparing this combination therapy with the individual therapy, the results were better with the combination therapy. Now looking at that population who are suboptimally controlled on basal insulin. So you have started your patient on basal insulin and you're still not reaching them. So what are you going to do? Are you going to add, here they've compared with BiASP. So are you going to add a premix? Are you going to add a combination therapy? Are you going to go for a basal plus? So here they're looking at a combination, the therapy versus twice daily BiASP. Now, generally, when you're not reaching there, you would switch over to one of these components. So, okay, now we're comparing IGLAR-LIXI and BiASP 30 twice daily, and this is a period of 26 weeks. And here, this study actually included patients from our country as well, around 182 patients from our country. And what it did demonstrate was that in comparison to the BiASP 30, over a period of 26 weeks, the IGLAR-LIXI was shown to be superior. This is the SOLI mixed study. And also in terms of the change in body weight from baseline, the results were better. So practically speaking, when you're in that group, which was after OAD, we saw the benefits. And then we're talking about what after only basal insulin has failed, we're also again seeing the benefits with the use of IGLAR-LIXI. So the total composite target achievement was clearly better with IGLAR-LIXI and the group basically requiring a lower insulin versus the biased 30 group. This is the secondary endpoint in looking at the total daily dose. That was 10.6 versus 22.6 in the biased group. Incidence of hypoglycemia, are we concerned majorly? No. The incidence was lesser with the iGLARIC C as expected again. And incidence of nocturnal hypoglycemia also significantly different in the group using iGLARIC C as compared to the group using biased 30 twice daily. So when you're comparing these two, in this study, we saw better glycemic control, we saw lesser hypoglycemia, we saw lesser injections, and similar proportion of adverse effects in both the treatment groups. So thereby placing iGLARIC as an efficacious, simpler, and well-tolerated alternative. Now, when we are using, when you're writing a prescription, at times we tend to forget about the very important thing that is there for the patient, the pen, the ease of use, the dose, the titration. That is something that we really need to look into. So we need to understand that this is a combination therapy. So when you're putting in 10 units of glargine, you're giving 5 mcg of lixisenatide. So it's in the ratio of 2:1. The pre-filled pen having basically 300 units of glargine and 150 micrograms of lixisenatide. So you would basically go up to, from the 10 dose steps to gradually go up. So in an insulin naive patients, you would probably start off with 10 units, which would mean 10 units of glargine and 5 mcg of lixisenatide. And then you would gradually up titrate based on the SMBG from the next 3 days. If the patient has already been on glargine and you're now, adding on this combination therapy, then you would start off at 20 units per day because, the patient needs to get the benefit that was already there and something more. So thereby you would start off with 20 units there. How would you titrate? Remember, this has to be injected once a day, 1 hour prior to a meal, and same meal every day. When the most convenient meal has been chosen, in case somebody misses it, then it should be injected within the hour prior to the next meal. Okay, now what about the special populations? Elderly patients, yes, it can be used safely. No dose adjustment is required for the age. Renal impairment, it can be used in mild and moderate renal impairment. However, it is not recommended for those with a GFR of less than 30. Hepatic impairment, it can be used without any dose adjustment. And in pregnancy, however, we do not have any data, and so it should not be used during pregnancy. And also you should, tell your patients who are planning on pregnancy that it needs to be discontinued and then the pregnancy needs to be planned across. So basically, this is a 1 injection once daily and 1 hour prior to meal, the rule of 1 that has to be remembered. So in conclusion, when we are talking about this combination therapy, it is a synergistic once daily combination of glargine and lixisenatide. Here we're talking about both fasting and PP glycemic control. The trials till now have shown that it's simple, it's well tolerated, good glycemic control, added body benefits, and lower risk of hypoglycemia. And so all in all, if you're looking at this molecule from the standpoint of, what do we need to, what we have in our hands in addition to what we already have had. So this is definitely, it's efficacious. We have seen, in comparison with individual, in comparison with premix, in comparison with, bias. So it's efficacious. It is simple because it's once daily. It's well tolerated. Till now, no major issues. Good glycemic control, weight benefit, and less hypoglycemia. So on that note, I'll thank you. And if you have any questions, I'll be happy to take them. Thank you so much.
Arundhati, thank you very much for a very clear exposition of this new molecule, how simple the rule of the 1 and where it is to be used and what are the benefits that it has addressed in the unmet need. And you have also addressed every issue where the special population where you have to not to use in a EGFR of less than 30, no problem in hepatic dysfunction. So we'll have a very short panel discussion. So maybe we'll be having. Yeah. Can we have Dr. Mangaraj? Are you there?
Yes, I'm here.
Mangaraj is here. Madhusmita, are you there?
No. Professor Das.
Tell me.
We have 30 minutes extra time now.
We have extra time, 30 minutes?
Yes, we can continue.
Okay. So may I invite the other panelists for this session? I'm sure, Arundhati, are you there?
No, sir,
Arundhati,
she won't be able to
for the
join.
question answer? Has Arundhati joined?
No, sir, she won't be able to join.
She'll be joining now?
No.
Has she joined? She has not joined. Debarchan?
Coming. He's joining.
Is coming. Okay, good. So we'll start the discussion. As we said in the very beginning, that that the glargine, I think it was a very good introduction by Dr. Alok Kanungo, who introduced this, that it is the simplest insulin to initiate therapy in the Debarchan, welcome. Debarchan, welcome to the meeting. So it is because that it is like prescribe and forget. And we have seen with the indication of 0.2 or 0.3, and depending on the obesity, increasing by 1 or 1.5 further per kilogram body weight, this drug is absolutely safe. It does not produce hypoglycemia and does not produce weight gain. I can also declare that. As Dr. Mangaras beautifully showed, that this drug has stood the test of time. This has been called the molecule of the decade, and if you will believe the Government of India statistics, this is the largest selling insulin in our country. And it is the original molecule, Lantus, is by the Sanofi, who are the organizers and the academic sponsor for this program. We have also many people since gone out of use. Many people also have brought in copy molecules, which are also available in the market. I would start this discussion by just asking the first question to Dr. Mangaras. Now, you did show that this drug has been one of the wonderful drug to add, initiate, if not initiate there, to add after the 3 oral hypoglycemic fail. There's no using adding 4th and 5th. You beautifully said, if you add a 5th one, it'll be degrowing. You'll be reducing the H1, it will be increasing H1C, then reducing it. Now, when do you give? If at all you give, it's given once daily. Am I correct? Do you give sometimes when the requirement is more than 20 or 24 or more than 30? Have you used it twice daily?
Actually, as you already told, sir, the molecule is preferably given once a day. But again, I would like to say one thing. There is no point in adding in basal insulin when the unit requirement goes beyond 0.5 unit per body kg weight, because that is a clear sign of over basalization, and that happens in clinical practice. Despite everyone is well aware of that, but it happens. So the people have tried to divide the dose if the cumulative dose exceeds, let's say, more than 30 units to into 2, but that may not be a very good idea. Looking at the PKPD profile of the molecule, you may not be giving many meaningful benefit to your patient in terms of glycemic control, because we have other agents which can be taken over. If you are having some problem with the control of glycemic status with glargine, I think we can go with a co-formulation that can take care of a prandial surge or a basal plus, which may also be much more beneficial rather than just incrementing the basal insulin to a very high degree.
I think that's a correct answer. We have to avoid over visualization, and we have many other things to do. I mean, apart from this co-formulation, we can also go for a basal plus. We can go for a basal plus, or if necessary, we can go for the basal bolus. So I think we have other ways to do it than increasing the basal. Now, I would to ask you a question, Professor Mangaras sir, what is the status today in pregnancy? I know off-level it is used extensively in pregnancy. They have not cared, I'm sorry to say, they have not cared to apply for the approval of the CGI. But what is the current status, quote unquote status? May not be government status, but status in pregnancy?
Absolutely, sir. In pregnancy, the only molecule which has been proved by virtue of a dedicated RCT is injection detamir. Unfortunately, levemir is currently unavailable in the market and is not going to any time be available in the near future, also because of the discontinuation in the by the manufacturing end only. Glargine, by the publication of landmark trials like Origin or other comparative trials, it has conclusively shown that it is not going to have any adverse feto-maternal outcome effect. But because they do not have a per se RCT, by that indication, they have not got an approval per se from any endorsing authorities that it is safe to use. But you ask any seasoned clinician, especially stalwarts like you, people have been using that molecules for decades together, because that molecule everybody is well aware of. It is safe, efficacious, It is not going to do any adverse outcome with regards to fetal maternal outcome. We do not have an endorsement per se if because of the lack of RCT, but off label everybody uses glargine when they face the need to use an basal insulin. Now, with the availability of degludec and publication of trial, especially in type 1, approval has also been granted to individuals who are currently on degludec can transition to degludec in pregnancy also. But having said that, proportion if you compare women, they require basal insulin very less per se if they have GDM. But many type 2 diabetic women who become pregnant, the diabetes control is brittle, might require the help of basal support. And in those, I think giving them the benefit of glargine is way beyond any doubt. It is the best of choice that they should be offered that.
I
And
think you're
once also,
talking.
we have also heard that U300 is also not approved per se. We have data from the pooled analysis of the exposure patients who got pregnant and delivered a healthy baby boy or baby girl, but approved indication to use a basal insulin is also not there for glargine U300. But for glargine U100,
That's why I
everybody
was
has used
little,
it, and I think
yeah.
there is no doubt that it can be used.
Yes, I was a little surprised if I heard correctly, Dr. Madhumita Sahu, when she said that this Glargine 300, you remember she said that it has been
Yeah.
used in pregnancy. I did not know what is the off-label use or the level use. Now you're
I think what she told, sir, is patients who were on that agent became
300.
pregnant, so they retrospectively accumulated the data that exposure to glargine U300, what happened to the fetal maternal outcome. But per se, I think you should counsel that if you are on this agent, it is better that it is not yet approved to be used in pregnancy.
Yeah,
You
I think
should
it is
be
always
aware
deferred.
of that.
Yes, absolutely. In fact, we have discussed this in the DCGI meetings, and we might be getting approval for the molecule you discussed. But we have not discussed about the Glargine 300 because that is not the country's need, because country has highest prevalence of Glargine user, the highest number of Glargine users in the country. The thing I want to ask you, Madhusmita is not here, that if you look at the advantages of Glargine 300, the definite advantage, people who require high volume. The volume cuts down by third. I also believe it is less hypoglycemic. I also believe that it is also given flexibility plus minus 3 hours, and also it is possibly less weight increase. And the only thing that has been discussed about it is possibly the little bit of pain that occurs when you give Glargine 300 compared to others. I'm not sure why this is already there in the literature. There will be minimal amount of pain. But if you look at the head-to-head comparison of Glargine 300 with the molecule you mentioned now, the degludec, I don't find the various trials are really giving us a very correct, homogeneous take-home answer. Like, let us start from the most controversial. Conclude. How will you rate Glargine 300 vis-a-vis degludec from the conclude trial?
Yeah, absolutely, sir. If you see, everybody was of the hope that because the molecule gives you an glycemic control of 40 hours, if you talk of degludec, it might be much superior with regards to the outcomes. But what was surprising in the conclude trial, what you told, is that if you compare insulin degludec versus insulin glargine U300, the primary efficacy, if you look at the glycemic endpoints, these are non-inferior. You are not going to give any additional benefit to your patient if you compare these two separate arms with regards to glycemic control. Now comes when you intensify the therapy. In the intensification phase, only point which was slightly different is the hypoglycemic endpoints, which was nominally lesser in degludec arm, which was not statistically even significant. So frankly speaking, sir, if given a choice that these two molecules are definitely Gen 2 basal insulins, good molecules, superior. But if you ask me regarding glycemic efficacy, I don't think a patient would perform better with degludec and versus a patient on glargine U300. We have to choose our patients wisely so that the molecule will give you kind of similar glycemic response, but hypoglycemic endpoints might be. And there are trials like Bright, Edition, and other in which people have shown in some trials U300 is having less hypoglycemic endpoints. The same set of subjects have shown U-degludec has lesser hypoglycemic response in some trials. But primary
That's
endpoints, if you
confused.
compare across the board, control is kind of similar, non-inferior.
Correct. I think that's what I wanted the take-home message, that Glargine 300 is no way inferior in the glycemic efficacy to degludec. Devarshan, can you come in now? Devarshan, I want to ask you a few things.
Okay, sir. Namaskar, sir.
Namaskar, Devarshan. Thank you very much. And I just wanted to ask you a very simple question, that how do you see the future of Glargine 300 in the presence of Rhizodec and Tresiba?
Basal insulin definitely will stay in the
market
armamentarium of management of type 2 diabetes mellitus. So it is a established fact. And when we compare all these molecules, so you told about, sir, U300.
Yes.
In comparison to newer insulin, newer basal insulin. So though Tresiba has shown a longer duration of action of 42 hours, and as Swayam has discussed, it has some in respect to glycemic control, though basal insulin has a better glycemic control. But still, both molecules are not so different. So it will stay in the long run.
Okay. I mean, in the Gen 2, that is the Glargine 300.
Sir, you are muted.
I'm muted? No, I'm not muted. In the especially in the Gen 2, that is Glargine 300, we have
you are not audible.
I'm not audible now. Am I audible, Alok?
Yeah, it's not audible, sir. I think there's some problem with Dr. Debatan's.
I'm audible. I'm audible because this one I'm using since morning. I'll be speaking a little louder now. We know that the advantages of Gen 3, Gen 2 is giving lesser volume, lesser hypo, and also it has got possibly good control, better control by the virtue of the insulin that you use, and especially for the high dose basal insulin requiring patients, this turns out as the insulin of the choice. Now, this particular statement that we need to give about 12 to 16% extra weight by weight, unit by unit insulin in Glargine 300, what it arises from, Dr. Mangaraj? Why it arises that we have to give more 12 units more? Because of the wastage? Because, I have a feeling, we have been asking by the government to introduce U100 and U300, U500, that there's a lot of demand from you, and we are examining that. One of the things is that the wastage, it will be a little more when you have a very high concentration insulin. It is because of that we have to give 12 unit to 6 unit extra, or any other cause?
I think, sir, that has also been incorporated. If you look at the product monograph also,
yes,
they have also demonstrated and written it there. The requirement is higher in patients who take U300 unit versus unit wise versus Glargine U100. And that perhaps arose from even if you study the PKPD, the difference should not have been there. It's a concentrated insulin, the requirement should have been less, but in their phase 2 and 3 studies, they have shown that the volume unit plus unit requirement is higher in U300. Wastage might be one of the contributing factors, but there are things, I think, beyond that also.
And
they are not very clear regarding what the requirement is higher, even if you look at the product monograph.
Absolutely. And the final thing about the Glargine 100 and 300, Devarshan, can I ask you, for a common physician for which this conference is meant, where will you prefer Glargine 100, where you will have to change over to Glargine 300?
Those who have
not controlled with the 2 or 3 OADs, and duration of diabetes is less. And when the dose of basal insulin is less, we can simply start with the U100 basal insulin, sir, in them. And gradually, if the dose of basal insulin goes up, then we can think of U300, those who are
those
having
requiring higher
higher
quantity
doses of basal
that's number
insulin.
one. Correct.
And in those groups, those having higher higher requirement of insulin amount,
Yes.
in them U300 will be convenient for using.
I also believe this plus minus 3 hours, which is 6 hours of flexibility, is also a good thing. We always don't need 42 hours or 44 hours of flexibility. So I believe that in our setting, when person forgets to take the injection, plus minus 3 hours is also something to fall back upon. Am I correct, Devarshan?
Yes, sir.
Yeah.
Definitely, the basal insulin has a flexibility.
Flexibility, especially this one, there's a flexibility of 3 hours. So that provides a little window, greater window of convenience in our country, where the insulin is given by the people who come back from work and give it and etc., or people forget and take it. So that is the beautiful thing. Now we come to the last part of the discussion about the Eigler Lixie. Now,
Alok sir has one point to make, sir.
Yes, Alok, please.
In our society, people go for dinner outside.
Yeah.
For marriage, is that, and they rarely take their insulin pen. In the studio or lantus, that benefit is there. They can come back and within 3 hours they can take the insulin, same dose.
Yes. Yes, I think that's a good thing. I mean, that is a very important thing you have said, that this flexibility and that is built in any analog insulin. But here in Glargine 300, it is more pronounced. You are correct. It is any analog insulin will have that flexibility of before, in, within, or after. But when it is Glargine 300, it is at least for 3 hours, or you can make 3 plus 3, 6 hours. Whereas for the other one, we're not comparing, but that is little more. But this is good enough. I think good point we have made. I also made in the morning a point of about if person goes to the morning for an investigation, by the time he comes back, 3 hours plus 1 hour or more, or 1.5 hour more, may be a good thing to again give the injection, because the flexibility it gives. Now coming to Eigler Lixie, is Arundhati there, or she has not joined? If she has not joined, I just like to mention that Eigler Lixie is a wonderful molecule, and also the sale of the Eigler Lixie is gradually going higher and higher. Now I'll request either Dr. Devarshan or Dr. Mangaras to highlight the clear-cut benefits of this Eigler Lixie.
Sir,
Yes.
in Indian patients, those who take a lot of carb diets, and obesity is rampant in our diabetic patients.
80%.
So this combination will take care of the basal insulin, take care of the fasting, and the lixinatide part. This will take care of the postprandial. So simultaneous dose. Also, with loss of weight, the patient will get some benefit in insulin dose reduction, PP control, and also by weight reduction, he may get some benefit in respect to cardiovascular risk also in the future. So a combination of this insulin, basal insulin, as well as lixinatide GLP-1 receptor agonist will be definitely a beautiful molecule in management of obese diabetes, particularly.
That's a great point. If you take along with the basal insulin, it will definitely provide you the benefit. If there is any weight gain, it will offset that. And if, of course, there is very minimal weight gain, so I think Jayant has joined. Now, even if there is no increase in the weight, it can provide weight reduction in the patients who take this drug. And I found that the Eigler Lixie, one of the advantages, they got approval only 1 year back. And within 1 year, they have got a huge market. You know what is the secret behind the market? The secret behind market is its pricing. Number two, promoting it. As you rightly said, as Sarun rightly said, the single pen, and daily one injection. That's what people like, daily one injection. And number two, they say that 1 hour prior to meal. And 1 hour prior to meal is very, very easy to give in the house. We give 45 minutes, so 1 hour prior to meal. So that's why this drug has proven of much benefit. You'll be surprised to know that when they did the trial, there was some mix-up, and they had mixed up the values of the fasting and postprandial, but ultimately that was correct. That was corrected. Any other advantage, Devarchan, you like to ascribe to the Iglar Lixi?
So insulin has its own benefits. It controls the glucose, and glycemic control is the pillar of management of diabetes. And this GLP-1 again, this is cardiovascular safety. They reduce the cardiovascular as well as renal complication in future. And weight reduction also itself causes some beneficial effect to the diabetes patient. So definitely both when combined in a daily dose will be beneficial with respect to cardiorenal complications also.
Absolutely. CKM benefit, definitely there. This also has glycemic benefit. So I think that is a wonderful drug, and it is more and more being used in our country. Now,
I would like to add something like GLP analogs remain one of the most potent agents which have now picked up in pace in current clinical practice, and perhaps the only thing which is hindering the widespread adoption of the molecule combination is lack of awareness, because Iglar Lixi and Ideglira, these are the only two drugs approved as of now to be used. One we don't have, and Iglar Lixi, as already discussed by you and Dr. Debarchan, there are a lot of benefits which beyond the glycemic control which the patient is likely to get, and the agents are potent. Weight loss would be attributed, and I think Solimix, Solid-D, and the Lixil and O trial, they have conclusively shown that this molecule is superior versus IDEC ASP in terms of weight reduction, glucose control. Versus premix also, the molecule is going to give you benefit even with regards to glycemic control, because GLP as a class is much potent than DP4 inhibitors, we know. And I think it is a beautiful molecule to be available in a single pen. Similarly, what we had like IDEC ASP, the first time we had a co-formulation, so everybody was very excited. With a single shot, you are delivering two agents. Similar with the story of Iglar Lixi also, I think.
Absolutely. And one more thing, Dr. Mangaraj, I would like to point out the beauty that even if, there are sometimes hypoglycemia with Ryzodec, but this drug doesn't have any hypoglycemia. That's one of the greatest thing, because GLP-1 arrays are immune from hypoglycemia. So I think that maybe, of course, I don't have any study to quote, but I always think that may be one of the advantages. There is a very basic question, which is a little odd question. Why Ideglira did not sustain, and why they wanted to do it. Deepak is here. Deepak, welcome. Hearty welcome, Deepak.
Thank you, sir. Thank you very much.
Deepak, thank you. So you are in the car, I can make out. So we are finishing this. Now the whole issue is that why Ideglira did not sustain. Number two, why did they make the calculation of the dose? It is a one pen calculation, very simple. Am I correct, Mangaras? But for the Ideglira calculation is the version is pretty complicated. So I don't know why they made it. I've never asked that to any of the company person, but I think Ideglira they did not promote. They wanted to promote to some people in the country. They did not sustain. And also the complications of calculating the units were a little difficult for many people in the country.
Cumbersome, yes, sir, absolutely.
Cumbersome. So that's why they dropped. I think that's one good thing they have done to do it. Dear friends, I think Alok, we have discussed in detail about this. Yes, you can take over now. Yes.
Regarding this,
hotel मध्ये park करेल का गाडी?
so when solid was introduced, people were apprehensive that how it will work. But in two conditions, it is working very well. One is where you want a basalization and you want to give glargine, you give an additional dose of GLP-1 receptor agonist, which is the frontline recommendation of ADA and other things. So that is reducing resistant hyperglycemia to a very maximum level. I have seen in cases where insulin, OHA, everything was not responding, by adding this Soliqua, it has really responded well and patients. So I think this has a very bright future in the present scenario.
I think that we have finished the panel discussion. I think I'm very thankful for being in this session. Mangaras, thank you very, very much. I wish you all the very best. You are on a rising curve. Devarchan has a lot of responsibility. He is the head of the department of the Devarchan was the presiding officer of the of the status of Professor K.C. Samal. Prashant did not become head, or he became head. There was some controversy in that batch, and then of course Baliar Singh sir and you, and there's a great opportunity and great burden on you, and I'm sure you will rise to the occasion. You are simple, and the way I met you last 1 month back in that meeting, and I saw your talk was fantastic and fabulous as usual. I congratulate you. I thank you. I thank, of course, Dr. Mangaraj again. I thank Arundhati, a very forceful speaker, and did it very well. And thank Alok for giving this opportunity. And I think with a big round of applause, we round up this session and go to the next session. Thank you.
Thank you, sir. Thank you, sir. Namaste.
Thank you. Thank you.
Thank you. Thank you. Alok, next session, Dr. Dhar has arrived.
Hello.
Alok, has Dr. Dhar there? Yeah.
Yes, sir, I'm here. Sir,
Yeah.
namaskar.
Srikant, very
Sir,
happy to meet you. Very happy to
sir.
meet you.
Happy New Year, sir.
To this higher concentration.
Surjit has come.
Surjit is there? Surjit? Surjit, are you there? I already have Siva Prakash, the head of the Department of Psychiatry at the SBB University, and the already Siva Prakash is already here. Siva Prakash here. So let me start introducing. I think they will be introduced by Dr. Srikant and Dr. Surjit. So my job is to introduce Dr. Surjit. Siva Prakash things are here. We'll come back again. Stuti, we'll put it next. First, put the chairpersons one. Chairpersons, put it first. Stuti, first put Dr. Srikant there. I think Alok, you are the right person to introduce Srikant.
We have two stalwarts, young, dynamic, and astute clinicians. They are really serving the state of Odisha in a very big way. Both of them, Surajit and Srikant, have a one common quality. They make a perfect diagnosis and perfect prescription. Patients are happy with them. They're academic, they talk, they participate in scientific spirit, and they are research oriented. So Dr. Srikant Dhar, Senior Consultant, Head of Department of Medicine, some ultimate, the chair is, now the mic is yours. You can take forward. Surajit, we are waiting for you.
Thank you, sir, for the nice word. Blessed to have stalwarts like Das sir and Dr. Alok Kanungo with us to chair this session. And without much delay, we should academics to start because this is a very interesting session. Depression and sleep disorder. I think it is almost known that these two diseases are most commonly found in most of the diabetic patients. As the study says, around 10 to 15% patient, most of the diabetes has some and other type of depression and sleep disorder. So it becomes very essential for all the clinicians to know how to manage them and what is the warning sign or when has to send to a psychiatrist or how to manage best both sugar with a target of HbA1c and as well as the mental stressor. So I'll be inviting
I just one minute. I'll just take to also, before you take over the full session, I would like to also tell you that in this session we have Dr. Siva Prakash. Siva, can I see you? Can I have Siva's biodata? Siva is the professor, and can I have Siva Prakash biodata, please? He is the professor and head of the Department of Psychiatry from the Mahatma Gandhi Medical College and Research Institute in Pondicherry. He is the adjunct faculty for the School of Music Therapy, Salutogenesis Institute, which means Wellbeing Institute and Complementary Medicine. And he had his MBBS in 1993 from JIPMER and Psychiatry in 1997. He has published about 40 scientific papers in very high impactful journals and 9 research papers. And his field of interest, psychosomatic medicine, medical education, communication skill, mental health, literacy, and music therapy. I must tell you one thing, Srikant. He has done the institute's theme song has been composed by him. Not a small achievement for the professor of psychiatry. His theme song is in our college, and the application of IT for the clinical and academic governance. In this session, we also have somebody who is very eminent and very famous. He's Dr. Deepak Jumani. Can I have Deepak's thing also? It will come again while we are introducing him. So people should know who are in this session. Deepak, can I have the Deepak here? Deepak Jumani is the senior sexual health physician and counselor, and he's a prolific speaker on many aspects, include the erectile dysfunction in male and also the sexual dysfunction in female. And he's honorary assistant professor at the JJ Group of Hospitals, fellow of the Regenerative Clinical Medicine, Vishroy Awadi from the IMA headquarters, a diplomat, an American Board of Certified Clinical Sexologists, fellow of the American College of Sexology, asset certified sex therapist, course director, mentor, fellowship in clinical sexology from the Maharashtra University, co-chairman of the IMA's Initiative for Sexual Health, and cyber crime intervention officer. Look at this, Srikant. Cyber crime intervention officer, Government of India, and author of the bestseller, Sex Has No Expiry. I like it. Very good. And I just introduced because, people should know that they are here so that, we have over 2,600 people still logged in. So I just wanted to tell them it's a very interesting session. I just took it. And also we have a wonderful interview with, I have an interview with Shiva Prakash, and Dr. Alok Kanu will be interviewing Dr. B.N. Das, who is a very famous retinologist from our country, now settled in UK. We have this in store for you. With this, Srikant, I will not be interfering. All yours.
Thank you, sir, again for introducing two stalwarts, and we will be fast going to your topic because no introduction needed for you because you are chairing whole of the session since last 2 days and managing very well. And I think no introduction for you, and we have already introduced Dr. Siva, again a stalwart in psychiatry. So it will be better to go to a session
interview
this directly so that we can have more knowledge about how to manage and what are the these two pandemics which are you can say double-edged swords, difficult to treat.
Yeah, I think we can have the interview with Dr. Shiva, please. Professor Shiva Prakash interview. Friends who have joined in large number this program of NUCD, National Update on Clinical Diabetes. And I really appreciate on behalf of all of us here, you are joining in above 3,000 number, 3,634 to be exact. And I'm delighted to be here with you with one of the most eminent professor of psychiatry of the country, Professor Shiva Prakash B. Dear friends, I must tell you that we are having today someone who is very young in age, but his achievements are great and touches the sky. Shiva Prakash is the professor and head of the psychiatry at the very famous Sri Balaji Vidyapith University at the Mahatma Gandhi Medical College and Research Institute. He has also the adjunct professorship in the School of Wellbeing, School of Musicology, School of Complementary Medicine. He had his entire education from the Institute of National Eminence, that's the JIPMA, with his MBBS in 1993, with his MD in psychiatry in 1997. He has 40 solid publications with a high impact factor. He has also contributed 9 chapters to various textbooks. Dear friends, the topic we're discussing today is very contemporary and very challenging. We're going to discuss 2 things today, mostly on the diabetes and depression. And second, the sleep disorders and diabetes, because they're closely correlated. Now, dear friends, and Dr. Shiva Prakash, it's my great pleasure and honor to be with you today. Can I start this by asking you, how common is depression diabetes? And as I told you, this is meant for the CPs, consultant physicians, general practitioners, and few endos and few diabetes. So can you just tell us what is the quantum, the burden of the disease of depression in diabetes?
Good afternoon to all. At the outset, I wish to thank sir for that very nice introduction and I'm also honored to be a part of this webinar as a resource person. At the outset, I would like to, congratulate the organizers on selecting this very, very important topic. And I would like to first start off with this interesting word called syndemic, which I came across in some articles. So when there is diabetes and depression occurring together, there are some articles that have used the word syndemic, two or more disorders or diseases coexisting.
During the COVID time, Shiv, when we had this pandemic of diabetes and various types of other disorders. Yes, correct.
Yes.
Please continue.
So, in the context of diabetes and depression, also the same word syndemic is being used now. So now there is a established bidirectionally, that's what a lot of research has shown now. Diabetes increases the risk for depression and vice versa too, which means depression also increases the risk of diabetes. Now, if you look at the recent Indian publications, the prevalence of depression and diabetes, it ranges from around 20 to 40. Now, to be a little more specific, 1 in 4 people with type 1 diabetes can have depression, and 1 in 5 people with diabetes who are not on insulin can develop depression, and 1 in 3 people with insulin treated type 2 diabetes can have depression. So, depression, the risk is sort of like double in people with diabetes and depression as opposed to the general population. So that is quite an alarming number, something which cannot be ignored by us healthcare professionals.
Yeah, I think very, very important, Professor Sib. We have shown in the ICMR INDIAB data, we have close to 102 million diabetics. And we said 20 to 40%. And that's only type 2. And including type 1, it will surpass the number. And it shows a great deal of burden of the depression in diabetes.
Absolutely. Absolutely.
Oh, now, in as a physicians at the level of primary care or the consultant physician, little secondary care level or tertiary care level as endos and diabetos, what are the subtle signs? What are the clinical presentations? And what makes you suspect and then diagnose this subtle or even over depression in the clinical practice?
Sure, sir. Now, before we actually talk about depression per se, I wanted to bring in the concept of diabetes distress at this point of time because it is far more common. And the other issue is that people can confuse one for the other. There is some overlap. And unfortunately, sometimes both can coexist in the same patient. There can be diabetes distress and there can be a depressive disorder also. So now, obviously, we all know that patients sometimes struggle to deal with diabetes, the stress of getting their lab tests done, medications, injections, appointments, tracking the lab reports. So all that leads to a lot of distress and it can be quite overwhelming for the patient. And so that is why we use the term diabetes distress. It is a well recognized entity which cannot be ignored also because it has an adverse impact on diabetes. There can be higher HbA1c levels if diabetes distress is high. So now moving on to depression per se, now the criteria as laid down by the International Classification of Diseases, WHO, is fairly straightforward. We require a diagnosis, a period of 2 weeks or more, where there is persistent, pervasive sadness, a low mood, not just a transient kind of sadness that all of us might experience at some point of time or the other. This is persistent, pervasive, means it doesn't go away very easily. It's there most of the time. And there is also a loss of interest in pleasurable activities. Let's say the patient has some kind of hobbies, playing a game, listening to music, watching TV. They don't enjoy those activities anymore. The technical term for that in psychiatry is actually anhedonia. So low mood, anhedonia, very, very important symptoms. Apart from that, there can be low energy, impairments in sleep and appetite, reduced sleep, increased sleep. Same way, appetite can go down, it can go up also. And apart from that, they can have feelings of guilt, worthlessness, hopelessness, difficulties in concentration. There can be cognitive symptoms, and most alarming, there can be suicidal thoughts also, and even psychotic symptoms. And so this is in a nutshell how a depressive episode might present. Again, the important thing is a depressive episode is a psychiatric illness. It's a mental disorder. Diabetes distress is not a mental disorder. It's not a diagnosis. It is an understandable reaction. And in this context, I must also point out that all these things, whatever psychological distress we feel, the substrate is the brain. There are basically neurochemical abnormalities accompanying these feelings of psychological distress. So the brain is the substrate.
I think great, Sib. I think the way you have explained it, I mean, to be honestly, I have no motive. I have never heard. You have given a very simple definition. I will not repeat it for interest of time, but it has been complete and it has been distinguishing between distress and the depression, and fabulous, fabulous. I like to ask you the second question taken from your talking just now. How does this depression impact the diabetes practice as a whole for the patient care? You told about the HbA1c going up. How does it affect the self-care and adherence? Very briefly, Sib.
Yes, yes. There is a very profound impact. But before we talk about the specific impact, one must also remember that diabetes per se has a lot of abnormalities in human physiology. There is HPA axis dysregulation, there is hypercortisolemia in depression. And among patients with depression, it has also been noticed that there are high levels of pro-inflammatory cytokines. In fact, there is a lot of inflammation in depression. And in fact, people don't know, is it the inflammation which is causing the depression or the depression that is causing the inflammation? But inflammation is very much there. So given that background, a lot of research is now showing that when both coexist, there is an increased diabetes symptom burden. And also functional impairment is much more when both disorders coexist. And diabetes self-management can be impaired when a person with diabetes also has depression. And depression can also lead to an unhealthy lifestyle, which can further complicate diabetes management. Treatment adherence can definitely be affected. People who are depressed do not feel like following the doctor's prescription. They do not feel like going for a walk. They don't feel like going to the gym. And it has been established across the literature that people with both diabetes and depression have a higher HbA1c level. And unfortunately, the complications are more. Diabetes-related complications are much more when there is both diabetes and depression. There is also an increased risk of dementia, unfortunately. Quality of life comes down further. And last but not the least, the cost of care definitely goes up when you superimpose depression on top of diabetes, and mortality, unfortunately, is higher also, which means when there is depression along with diabetes, the mortality rates are unfortunately much higher.
Yeah. I think it's a great insight. I think very simply you have highlighted the entire spectrum of how depression affects diabetes and given us very important learning. Thank you very much, Sip. Just wanted to ask you, nowadays it is routine even for the postgraduates to use mini mental scale. I do understand mini mental scale will not be applicable here to diagnose depression. But if somebody wants to do a small study or even wants to document, is there any simple scale that you can refer to us that we can use it in practice? Very briefly, Sib.
Absolutely, sir. Actually, MMS, mini mental state examination, still has a role, but in the context of screening patients with diabetes for cognitive impairment, because cognitive impairment is one of the known symptoms. So for that purpose, MMSE can be effective. But coming back to diabetes distress, there are very good standardized published scales. One of them is the PAID scale. It's called Problem Areas in Diabetes. That's the abbreviation. And the other popular scale is Diabetes Distress Scale. And these are all available on the website of the American Diabetes Association also. They're very popular scales. And more specifically, for the purpose of screening for depression, we have the PHQ-9, expanded as the Patient Health Questionnaire. And it's, as the name reflects, it has 9 questions, and it is one of the most popular screening tools for depression. And it's widely used in the research literature. In fact, it is particularly used in the context of medical patients, not people primarily presenting with mental disorders. And it has a clear cutoff also. When you use PHQ-9, you'll know whether there is any depression, and is it mild, moderate, or severe, based on which you can decide, do I need to refer to a psychiatrist or not?
I think great learning. I think, Sib, I am taking your permission after the NUCD is over on the 11th. We would like to put it in the YouTube without any motive, without any financial, without any sponsorship, for the people to access this. I think it's been fabulous. The tips you are giving is very fabulous. Now I'll come to the most important issue now. Now, how do we treat depression? And I do realize, I have seen that there are a lot of non-pharmacological advances, and you preside over them. You have been one of the ardent promoter, supporter, practitioner of this non-drug therapy of the diabetes depression. Can you highlight to my audience, please?
Absolutely, sir. Now, what the guidelines say is that when there is diabetes distress, there is a lot of counseling needed. There's a lot of engagement. The diabetes care team needs to spend time, and they need to be educated a lot more. And that itself can handle their diabetes distress. So diabetes distress per se doesn't need a mental health professional as such. But once the screening determines that a particular patient has features of a depressive disorder, then referral is recommended. And of course, we have one of the most popular forms of non-pharmacological management, that is CBT, cognitive behavior therapy. So we have CBT, and there's a lot of research that shows that CBT in depression, it can actually improve outcomes, not just for the depression, for the diabetes also. Quality of life improves. Diabetes management goes up. And CBT is often given by trained clinical psychologists. And in fact, most guidelines say that for mild depression, and sometimes even moderate depression, CBT alone might suffice. And of course, moderate and above moderate severe, definitely we need to prescribe. And we have a wide range of medications available to handle depression. But in the presence of diabetes, we need to be very careful. For a patient with diabetes who has depression also, SSRIs, serotonin specific reuptake inhibitors, are the first line agents. They are very well tolerated. And the best examples that come to my mind are sertraline and escitalopram. Fluoxetine was the earliest drug to be introduced, but now it has been, now there are newer SSRIs available. So escitalopram and sertraline both are very well tolerated. In fact, and the good thing is they don't have any adverse effect on HbA1c. In fact, there's some research that says that with these drugs, diabetes control can improve as the months go by. So HbA1c can actually improve. And a word of caution, some drugs, specifically the tricyclic antidepressants, should be avoided when there is diabetes along with depression, because those drugs have a whole lot of side effects and they can contribute to metabolic syndrome, and the tricyclic antidepressants can complicate diabetes management. So SSRIs remain the first line of choice. So combined with counseling, cognitive behavior therapy.
Fantastic. I think we have given a great piece of knowledge, because amitriptyline used to be one of the commonest therapy for the neuropathy, and they adapted it to diabetic depression. Now we are very clear that the SSRIs are the main seat anchor, when the CPT fails or the non-pharmacological treatment fails, and it can be used. Any caution you have to give regarding its use, and any drug which should not be used? One you said about the amitriptyline and the this group of drugs. Anything else?
So the other category which we try to avoid also is the benzodiazepine category, because there are, of course, insomnia and sleep issues. That's another issue. But often we need to prescribe something for sleep also in patients who have depression. So if there's diabetes also, we try to avoid benzodiazepine, because they can also complicate the management a little bit with a lot of side effects.
Yeah, I think that brings to the second part of the discussion, very small part, Shiv, is some people have described sleep as a risk factor for diabetes. They say eat less, walk more, keep smiling, the distressing, and sleep well for 7 to 8 hours. Do you believe in that sleeplessness, which is a common malady of the modern civilization? Do you think that can be a risk factor?
Definitely, sir. It is actually quite well established now. There is a very strong correlation between all three entities: sleep on one side, and depression and diabetes. Now, specifically between sleep and diabetes, there's a lot of research that shows a bidirectional connection, which means sleep impairment over a very long time can actually predispose one to develop diabetes. And diabetes itself can cause sleep impairment. So it is sort of like bidirectional. And to complicate matters, depression also can present with sleep impairment. And particularly, articles have mentioned that there is a U-shaped curve, which means at the midpoint you have 7 hours of sleep. So 7 hours is considered ideal. So what they say, that for every 1 hour, either up or down, more than 7 hours or less than 7 hours, there's an increase in the risk for diabetes, which is around 9 to 14% for every 1 hour change. So that has more or less been established very well. And sleep deprivation definitely leads to increased levels of inflammation in the body. Pro-inflammatory cytokines are higher when there is chronic sleep deprivation. That is something we have to remember also.
I think it's great that you mentioned this, because now today in the modern life, sleep has become almost a luxury and not available. And we talked about sleep hygiene. In fact, this year's ADA SOP, Standard Operating Procedure, has given a lot of emphasis, what you rightly said, 7 hours of sleep. That's mandatory to prevent diabetes, not to allow diabetes to occur. Now, the other thing I'd like to ask you, apart from this duration of 7 hours, is there any effect of diabetes on the quality of sleep? Quality of sleep.
Absolutely, sir. Now, actually, when we talk about sleep, it is the quantity, quality, and there's also something called chronotype, which recently researchers started talking about chronotype also. Of course, quantity we've already discussed. Now, quality also matters. Like, does the patient sleep well throughout the night, or is the sleep fragmented? And there is again a lot of research that connects poor quality of sleep also to metabolic impairments and an increased risk of not just diabetes, but cardiovascular disease and other physical disorders too. And very interestingly, this concept of chronotype, there are people who go to bed early and wake up early, and there are people who stay up till late and wake up late. Now, I think the old saying still holds very good, because there's a lot of research that is now proving that the risk of diabetes is higher among those who go to bed late and wake up late. So there are publications that do talk about this particular chronotype, the late chronotype. All three parameters are important: quality, quantity, and chronotype.
I think, the messages you have given today are absolutely simple. And these simple statements can make a highest impact on our physicians, and also when translated to practice. This is the practice essentials that you have spoken us today. The next question that I'd like to ask you, I mean, is there any way from the history or any way you can evaluate the sleep of a particular patient, a person with diabetes?
Yes, sir. Normally, in routine clinical practice, as a part of history taking, we must ask about sleep quantity and quality. But if we wish to go a little deeper, there are sleep questionnaires also. One of the most popular questionnaires is the Pittsburgh Sleep Quality Index, PSQI. That is very popular. There are many more, of course. And yes, polysomnogram is considered like a gold standard. And there is something called artigraphy also, but it's very obvious that the patient discomfort is a lot more, in polysomnography. So we don't routinely use it unless there's a very specific indication, like for example, obstructive sleep apnea or something like that. But for routine evaluation of sleep, we actually don't need a PSG. And these days, there's also a lot of literature on these wearable devices. People are wearing smart watches and stuff like that. Of course, researchers are warning us that these are all like being used by the lay public, but we still don't know if they can be used for clinical research. But the options are many. They are called wearable sleep trackers. So these are the various options available.
Good. I think that's a great thing you have said today. And the last were two questions. Does sleep affect the quality of life? We strongly believe so. Number two, does it affect after work, or we call it work reactions next morning and work output next morning? And how do you see that it can be treated?
Absolutely, sir. There is definitely a very strong connection between both sleep quantity, quality, and our cognitive functioning the next day. And especially when there is chronic sleep deprivation, researchers have shown that our performance definitely comes down, especially if it's a chronic affair. And another word of caution is, of course, many of us are driving to work by ourselves. It can affect our reaction time when we are driving a vehicle on the road. It can lead to an increase in the rate of accidents. So there's a widespread effect, both at the cognitive level, at the psychomotor level, and definitely quality of life comes down as a result of chronic sleep deprivation.
Good. I think great. I'm coming to the last question. How do we manage the sleep in this PWD, persons with diabetes, that we see day in and day out? Can you outline just 1, 2, 3, which are the drugs that you can use safely? And you rightly said, what's your opinion about the benzodiazepines? And also, can you just cite out the common drugs which can be used by CPs, GPs, endos, diabetos, and as a stopgap therapy before we refer it to you?
Absolutely, sir. Now, medications definitely are a short-term management thing. So I would like to touch upon something else that we can do, some non-pharmacological strategies also, which we would always like to start off with first. So if once we have established that the patient with diabetes definitely has a sleep issue, definitely they need sleep education. And the American Academy of Sleep Medicine has actually listed a few healthy sleep habits. Actually, there are quite a few. There are around 14 points, so I won't have time to read through them, but it's there on the website of the AASM. Simple tips like keeping a consistent sleep schedule, avoiding caffeine, and having a relaxing routine from late in the evening onwards. There are 14 tips. So we must make it a point to educate our patients about these sleep hygiene measures or healthy sleep habits. In fact, we even have one particular type of cognitive behavior therapy for insomnia. That is also there. And we can also help patients by teaching them relaxation training. So there are all these non-pharmacological measures that can be tried. And of course, if depression seems to be contributing to the insomnia, we must treat the depression. that itself can lead to improvement in the sleep. And if we have to prescribe, then of course there are a few options. Melatonin is coming up as an popular option these days. And though it is not strictly regulated by the authorities, and it can even be bought as an over-the-counter medication, and the dose range is also not very clearly mentioned, the range of like 1 to 10 mg. We have 3 mg tablets available in the Indian market, melatonin. And it also comes in the form of a syrup where there is 3 mg per 5 ml. Of course, we can titrate the dose. And melatonin is relatively safe. There can be a little bit of daytime somnolence. And again, there is some research which interestingly shows that in the long run, melatonin might have a positive effect on glycemic control also, but there is a little bit of controversy also, so I won't go much into that. Then the other alternative we have is zolpidem. The dose range is 5 to 10 mg, but usually we feel that 5 mg is enough. It is definitely safer than the benzodiazepines. It's short acting, and cognitive effects are not that many. Daytime somnolence is minimal, and even withdrawal is very, very mild. And from the literature that I have come across, zolpidem doesn't seem to have any adverse effect on glycemic control. So zolpidem is all right, but again, zolpidem should not be used for longer than 2 to 4 weeks. It's temporary. And benzodiazepines, I would like to avoid, whether it's lorazepam or alprazolam. People very quickly get addicted to benzodiazepines, and they lead to problems and complications, and it's very difficult to wean them off benzodiazepines.
I think, see, I must tell you without any much exaggeration that this has been one of the outstanding recording. The practice essentials that have come out so well. I mean, I have no audacity of summarizing them, but each sentence you said was laced with practice essentials and take homes. It is a very clear exposition of what is very essential for the CPs, GPs, endos, and diabetes. And it has been absolutely fabulous, educating, clinical, practical, and is loaded with the tips that were given today. Your message has been simple, as the greatest truths are the simplest. Thank you very much, Sip. We'll again meet, and I have your permission to put it in the YouTube from the 12th onwards with your name, photograph, and all that. Thank you very, very much, Sip. We are obliged and to say that we are. I will not say grateful, because it is education. You are so close to me. I must tell you that we appreciate, we love, and we pray for your constant progression, development in the chosen field of psychiatry. I know you have collaboration with University Saclay in the Paris. You have collaboration with many other areas, and it will take you to the highest heights. Thank you, Sim. Thank you very much on behalf of all of us.
Very much.
Love and greetings. Thank you. Thank you, Sim.
Thanks a lot.
Over.
Thank you, sir, for the nice presentation and interview. Like typical journalist, you have taken a very good interview. But not to say the new speaker we will be introducing, I have already introduced by my co-chair or sir. Already sir has introduced Dr. Jumani. Our next session is again another important topic: erectile dysfunction in diabetes and its solution. By none other than Dr. Jumani is a well-known sexual educationist in India. He is a part of all national and international forum where this question is asked. So this is, it is very important. As already said, depression is very common in diabetes. The erectile dysfunction is also common, as common as up to 85%, some studies say. And we will know whether this, how to manage it, and whether this is irreversible or it is reversible. Again, because reversibility is a question in diabetes, it is coming up again. So without much delay, we'll hand over the session to Dr. Jumani for his deliberation. Over to you, sir.
Thank you very much, sir, for that wonderful and sexy introduction. Thank you, Professor Das. He's been always generous in his words for complimenting everybody, Dr. Kanugo, and everybody from NUCD. I'm really excited to talk to you guys. In fact, I am just on my way back from a conference going to the airport, but still I said I'll halt here and I'll make my talk. Uh, well, very rightly said by the chairperson that in diabetes, 82% of men who have erectile dysfunction and they remain in silence. They don't talk about it. And even diabetologists, every diabetologist is my friend. And I've really asked them, do you really ask? They say, I see 100 patients a day. I don't have time to ask. So this is the barrier. The time is the biggest barrier in them. So with pranams to God and thanks to my teachers, Dr. O.P. Kapoor, Dr. Prakash Kothari, and Dr. Sashank Joshi, I beseech them to bless me always. There is no death reported as of now in patients who have had sex. During coital activity, there has been no death at all, no sudden death. All the deaths which have always happened post-coital in patients who have had sex with illegitimate partners after heavy alcohol or heavy meals. So this is what one should remember, that sex is God made. We are all born out of it, and there is no death related to doing the activity. Diabetes, we all know, is a fast growing, lifelong challenging for rich and poor globally. 40% of diabetics have been proven to have some issues in the bedroom, and 62% of women admitted that they were not satisfied with their sex life. They have issues, their partners have issues, and there's definitely a dent in the relationships. There is definitely a link between diabetes and sexual dysfunctions. Obesity, hypertension, sleep apnea, depression are all common occurring alongside with diabetes. The time and energy spent managing diabetes is interest in sex. Changes in testosterone or estrogen because of diabetes, menopause, co-occurring conditions can impact the drive, the lubrication, and the ability to become sexually aroused. Diabetes, what actually does, it impacts the blood flow. They have enough blood, but the flow is impacted, which could affect blood reaching the penis or vagina. For a man to achieve and sustain erection, he needs blood to flow to the penis. In women, decreased blood flow can lead to vaginal dryness and painful and atrophy. So having high levels of glucose can also damage nerves. The tip of the glans and clitoris are loaded with nerves. If these nerves become damaged, the result might be decreased sexual sensation or even painful intercourse. Both type 1 and type 2 have increased risk of erectile dysfunction, which is reported in more than 50% of men with diabetes worldwide. Now, what actually happens? A beautiful study recently done, published in Nature, that the traditional culture affects the patient's sexual concepts, and they think that sex is very private topic. Hence, when they experience the problem, they avoid talking about it, which aggravates the sexual, physiological, and psychological issues. These in turn affect the sexual experiences of the patients. Therefore, to improve patients' sexual experience, intervention must be from multiple perspectives. All the teachers, all the doctors, all the parents should definitely ask, clarify, discuss freely without fear, guilt, and shame about these issues in the bedroom. India and China are the diabetes capital of the world. And erectile, I call India or China and India the erectile dysfunction capital of the world. When we look at the male sexual response, it begins with the desire, leading to arousal or erection, then ejaculation and resolutions. So today, what diabetologists and other physicians focus only on erection. They are aware of only erectogenic drugs like Viagra, Tadalafil, Sildenafil, Vardenafil, Avanafil. They only focus on that, but they forget that desire is the main foundation of male sexual response. And in diabetics, desire gets affected. Of course, the arousal also get affected. But if we keep on treating arousals or the erections, we are losing the track and we are losing the boat by not clearing their desire. So they have to take medications again and again. And at times, 40 to 50% patients don't respond to it. So if you look at diabetes and sexuality, there is also a decrease in testosterone levels. In fact, every diabetic is hypogonad. So erectile dysfunction, though it's a first problem, but there is also decrease in testosterone level. So diabetes has detrimental effect on the sexual function. So diabetologists who primarily care for the patient should not only focus on glycemic control of the patient, but also address the sexual complaints. So diabetes, the current perspective is that though it's a risk factor for erectile dysfunction, we need to address it holistically. It is not just the hormones or the PD5 inhibitors. There are many other things which are related to it, which can really make diabetics have enjoy a good quality of sex. All diabetics are testosterone deficient. Justifies a 3-month trial of testosterone therapy before combining a PD5 inhibitor if testosterone therapy fails. So it is not just only testosterone which is going to help him give a good sex life. So if at all he is testosterone deficient, which he is, he needs to correct his testosterone, because testosterone is very important for maintaining the integrity of the penis, the health of the tunica albuginea, everything, the architecture, the smooth muscle, the blood flow, all depends upon that. So if that becomes normal and then you add PD5 inhibitors, it works very well. My teacher, Dr. Paresh Dandona, he treated testosterone patients for more than 2 years with testosterone and found beautiful results in this sexual thing. Diminished androgen levels and estrogen are all due to aromatase level which become high in hypogonadal diabetic men. And if that is corrected with giving testosterone replacement in patients with hypogonadism, patients see very good response. So oral testosterone undecorated reverses erectile dysfunction associated with diabetes mellitus in patients on sildenafil alone. Who fail on sildenafil, you need to give testosterone also. Research suggests that testosterone is very important for endothelial health. It stimulates the production of endothelial cell mediators also. So when you look at the smooth muscle, it is the nitric oxide which is formed from the normal endothelium because of endothelial nitric oxide synthetase, converting GTP into cyclic GMP. This cyclic GMP relaxes the smooth muscle and allows the blood to flow in the penis. This is again, called phosphodiesterase 5. Today, what we are focusing on, we are focusing only on PDE5 inhibitors to increase the erection. Whereas to reach at this stage, you need enough nitric oxide. You need a normal endothelium. Okay. And when you look at hyperglycemia, increased advanced glycated end products, oxidative stress, alter the molecular functions, alter the cavernosal endothelial functions, and also there is architectural change in the penile vasculature leading to erectile dysfunction. So erectile and endothelial dysfunction in type 2 diabetes, there is definitely a strong link. But what you really need is nitric oxide. If you really want to live longer, live better, you need nitric oxide. We get 50% of nitric oxide from the endothelium. That is true. But what about the rest? We know nitric oxide reduces as we age. At the age of 60, we'll have only 15% nitric oxide left. So we need to supplement nitric oxide as we age. And diabetes is an inflammaging disease. So we are all going to age. We will need nitric oxide. What about the remaining nitric oxide? We can get it from nitrate-rich foods like beetroot, green leafy vegetables, nuts, pomegranate, watermelon, citrus fruit seeds. All these foods are nitrate-rich foods. These nitrate-rich foods get converted into nitrite when you chew them in the salivary microbiome. And these nitrite converted food, when you swallow it or when it goes into your stomach, gets converted into nitric oxide. So this is another way which you can have a nitric oxide in our body by consuming these foods. So this is a beautiful and increases perforation, neuroendocrine regulation, neurotransmission, improves immune functions, neuroplasticity, neurogenesis, lymphatic, beautiful functions of nitric oxide which are there. So let me give you a deeper perspective. It is not only the endothelium. In diabetics, it's also the mitochondria that gets affected. At the islet beta cell level, acute insulin release is regulated by mitochondrial ATP production, and mitochondrial ROS may contribute to the long-term deterioration of insulin secretory capacity in type 2 diabetes. In persons with type 2 diabetes, high nutrient influx and consequent ROS production appear to mediate loss of beta cell in insulin sensitive tissue like liver, muscle, and heart. And heart high fatty acid influx leads to oxidative damage. At the same time, Non-insulin sensitive tissues, which include eye, kidney, nervous system, and penile vasculature, also are exposed and get damaged. So we need to understand it is not just the endothelium, also the mitochondria which gets affected in diabetes. Now, mitochondria is a powerhouse. These patients always tell us, doctor, I'm feeling weak. It's not just you should not conclude that, oh, because he is not able to do sex, he is telling weakness. He really feels weak because his ATP levels are very less. His mitochondrial dysfunctions are not proper. So lots of mechanisms to prove that diabetes leads to mitochondrial dysfunctions and leads to erectile dysfunctions. We have a beautiful drug called imeglimin, which can be given to these patients, which improve mitochondrial dysfunctions. Actions amongst them, tadalafil has a longer duration of action. They all have side effects of headache, nasal congestion, visual disturbances, and we shouldn't give it to patients who are on nitrates or who have hypotension or have anatomical defects or have various anemias. The new drug which we have today is avanafil, which can be beautifully, the action is only 15 minutes onset and the duration is, and the half-life is just 5 hours. This is the drug which you can give it to patients who are on nitrates. Ask them to skip nitrates on the day when they want to take avanafil and have good sex. Once they take avanafil, after not taking nitrates on that day, they can have good sex. This drug gets washed out from his body in 5 hours, and next day again they can start nitrates again. Chronic therapy with PD5 inhibitors like tadalafil, very low dose, 2.5 or 5 mg, over a period of 12 to 14 weeks have fantastic results in these patients because tadalafil remains in the cell up to 80%. So if you give them 20 milligram, which is the adult dose, they may get side effects. But with 2.5 or 5, they don't get side effects. And this gets accumulated in the cells up to 80%. So after 5 to 6 days, they have enough PD5, enough tadalafil in them, and they can have very good erections. Why chronic therapy? We know the prolonged half-life of tadalafil, 80% availability, and steady reaches after 5 days. This is what I just explained to you. And avanafil can be given to nitrates. There are some patients whose HbA1c is more than 10, and still they say we are having very good sex. This is because they have an isomer of endothelial nitron 4 and T786. They all are having, these patients who have these genes have a risk of erectile dysfunctions. But what we have seen, this intron 4, all these other two genes, only intron 4 is not associated with erectile dysfunction. So enos gene, endothelial nitric oxide gene, if they have intron 4, they, even if they have high hyperglycemia, even if their HbA1c is more, they will not have this symptom of erectile dysfunctions. We have films available of sildenafil and tadalafil, which you can keep it on the tongue, dissolves in 10 to 15 minutes, fantastic results. All these diabetic patients who have erectile dysfunctions also have low melatonin. So if you give them 3 milligrams of melatonin every day, they will not only get good sleep, they will maintain their circadian rhythm, it is not addicting, and also they will have benefit of getting good erections. Eroxon, a new thermal gel, which is now US FDA available in US. Fantastic result. Just take this gel and apply it on the shaft of the penis. Within 20 to 30 minutes, these patients get good erections and there are no side effects of it. We tried glyceryl trinitrate in more than 258 patients. Glyceryl trinitrate 2%, 0.2% has a property to vasodilate the blood vessels. Those patients who do not take PD5 or cannot take PD5 inhibitors, do not want surgery, this is the ideal option for them. Just apply glyceryl trinitrate on the shaft of the penis. Because of its properties, they will have very good results. Bariatric surgery has proven to reverse diabetes, reverse metabolic syndrome, and so the blood flow and all, everything improves. My friend Dr. Jyoti Dev put his diabetic patients on insulin pump and found improved sexual functions to the tune of 83 to 85%. There are other therapies like extracorporeal shockwave therapy, PRP, stem cell, gene therapy, nanotechnology. We have been treating patients of ED for last donkey's years, but none of these reverse the pathophysiology of erection, which is endothelial dysfunction and mitochondrial dysfunctions. So we have herbs which are now available in the form of L-arginine. L-arginine produces nitric oxide. Nitric oxide is a signaling molecule for erectile functions. And then we have fenugreek, which has got a chemical composition exactly like testosterone. It displaces the globulin bound and makes the free testosterone more available. So it produces a testosterone-like effect. So the desire and the erections are taken care of by drugs. My last perspective, friends, you may be Hindu, Muslim, Sikh, whatever, but make lifestyle as your first religion, because lifestyle is the only modification, is the only way where you can reverse your wrong things in your body and increase your health span and lifespan. We all are in a pro-inflammatory state. We all have oxidative stress. If you improve your health lifestyle and make it healthy, you reduce the pro-inflammatory milieu, improve the insulin resistance, reduce the oxidative stress, and also improve the endothelial functions, which lead to improved well-being and reduced burden of sexual functions. Beautiful diet, red-colored fruits, red-colored vegetables, greens, beans, berries, avocados, mushrooms, all seeds, flax seeds, chia, pumpkin, saffron, garlic, vanilla, white of the boiled egg and fish. But ask your patients to avoid excess of salt, oil, and sugars. Ask them to fast for 12 to 16 hours a day and walk for 30 minutes per day and sleep for at least 6 to 8 hours per day. We all are going to age, but if you restrict calories, this is a beautiful thing. If you restrict calories, you activate serotonins in our body. Now, serotonins are anti-aging genes, amino acids which are present, and these gets activated. When these gets activated, there is increased NAT, mitochondrial functions improve, reactive oxygen production reduces, and you have a lifespan which increases. So to improve your health span and lifespan, you need to activate serotonin. And the only way you can activate your serotonin is by caloric restriction. There have been studies to prove that aging and cardiovascular disease risk factors on the expression of serotonin in human corpora cavernosa. They found that there are 6, 7, 8 types of serotonin which are present in the corpora cavernosa, which can improve by only caloric fasting. Lots of studies to prove that. Another mechanism is autophagy. We have in our body an innate mechanism to clean up the kachra of our cells, the clutter, whatever is the dead material can be washed out by autophagy. Now, autophagy can be activated only with fasting and caloric restriction. So this is another way without taking any medicines, just starving yourself can also improve your health span and lifespan. The discoverer of autophagy got a Nobel Prize, Yoshinori Oshimi. Third effect is stress your body to a certain extent. Don't think that I can't walk because of arthritis. Don't think that I can't climb. No, stress your body to a certain extent and see the results. Because repeatedly challenging the body with mild stress of choice can stimulate compensatory, adaptive, and reparative process with help. This is hormesis. If you're taking a cold water bath, try taking little warm water bath. Then you see, you may feel good. So increase the warm water bath, increase the briskness in your walk. So try and do something which you're not able to do now, or you don't want to do it for silly reasons. But if you do that, you set in hormesis in your body, activate hormesis, and beneficial results with. Exercise is a hormetic of body. Even novelty in having sex, because if you have novelty in sexual stimulus, see, people do the same thing. Sex is only penis going into the vagina, but initiation and novelty is to be there, because hormesis operates with sexual realm. Innovative sexual stimulation leads to health improvements in later life. Hormetic effects can be invoked via sex hormetins. Inventive erotic activities may result in cognitive effects. It not only improves your general health, brain health, and also sexual health. So eroticism is again a hormetic stimulus to health. Friends, what is an ideal prescription for a diabetic with ED? All the drugs I have mentioned you. You can start with SGLT2 inhibitors, metformin, acarbose, imeglimin. These are the 4 drugs you should give to your diabetes. You can add basal insulin, and every patient of your diabetes will have a good control of hyperglycemia, plus lifestyle modification, plus definitely counseling. So counseling and lifestyle measures should be adopted. Put your patients on metformin, SGLT2 inhibitors, imeglimin, acargose, all improve endothelial functions and mitochondrial dysfunction. Statins, if he has got dyslipidemia, don't worry about the cholesterol damaging the or reducing the testosterone. No, it's not there. It's only 20% of it gets affected. Antihypertensive, start them on ACE inhibitors or ARB. If you want to give beta blockers, give them only nebivolol. If you want to give them diuretic, give them indapamide. So these two are very good antihypertensive which do not affect the sex life. Low dose PD5 inhibitors, if there are no contraindications, like if they are not on nitrates or if they don't have any hypotensions. low dose short course of testosterone, definitely you can give, because unless and until you give them testosterone, if the level comes to around 400, 500, then only the PD5 inhibitors will act. So give them, and also monitor PSA. L-arginine supplement with fenugreek zinc is a must for every diabetic patient. These are metabolically potent compounds or nutraceuticals having no side effects, no death, no anaphylaxis, nothing. And both the partners can take it. Nutritional intervention counseling, you should guide them as to what they should not eat and what they should eat. And of course, mental health checkup. Friends, diabetes is an inflammatory disease. We all are in a pro-inflammatory status. Hence, we need to avoid inflammatory processes in our body. Muscle is anti-inflammatory. Fat is inflammatory. So to rekindle the sparkle of your life, build muscle and burn fat. This is my book, Sex Has No Expiry Date. My last slide, friends. Diabetes is the sexual health tsunami of our century. Erectile dysfunction is prevalent and the earliest marker of coronary artery disease. PD5 inhibitors are effective. Today, beyond medicines, ED can be managed. L-arginine supplement and fenugreek is a boon. Activate serotonin, autophagy, and hormesis. Diabetes remission is a fact and not a myth at all. Enough studies to prove. I have so many patients who have remitted their sugars for the last 5 years. So I can boldly say diabetes remission is a fact. PRPs, exosomes are tomorrow's safer cure for erectile dysfunctions. Hence, erectile dysfunction is a correctile dysfunction. So love each other unconditionally, love yourself, love your partner, and try to reverse the metabolic, give a U-turn to your metabolic syndrome. If you do so, friends, sex really has no expiry date. Thank you all for your love. I'll be happy to answer any questions you all have.
Great, Deepak. I must, with the chairman's permission, I must tell you it has been absolutely fabulous. When I met you in Bombay 1 week back, I again re-invite you. You said, "Who says I'm not coming?" I'm so happy, Deepak, that you came and you conquered. Thank you very, very much. And I'll hand over the session to chairperson again to take it forward. Thank you.
Thank you, sir, for the lucid presentation. And as sir has said, erectile dysfunction is correctable dysfunction, and lifestyle modification is the key most of the cases. And sir, एक चीज बताया, दाग अच्छे हैं, स्ट्रेस कभी कभी अच्छे हैं, मतलब सर जैसे बताया. So sometimes you have to take stress to have a correction in erectile dysfunction. Most of the thing sir has taken care in diabetes care as well as erectile dysfunction care. So nice, sir. We'll be waiting for you in the panel discussion if you permit. We'll go to the next session. We'll go to the next session, sir. Without much delay, it's an interview managing diabetic retinopathy across all socioeconomic segments of the population by Dr. Alok Kanungo. Sir, are you there, sir? Hello.
It will come. 1 second.
Over to you, sir, Dr. Sir Alok Kanungo, for interview.
Stuti. Welcome to National Update on Clinical Diabetes, NUCD 2025. In this session, we have the privilege of having Dr. B.N. Das, an alumni from SCB Medical College, All India Institute of Medical Science, RP Institute, and now doing tremendous work in the field of retina and ophthalmology at UK. Based at Birmingham, Dr. Das, welcome to this national program on diabetes.
Good morning. Greetings from Birmingham, UK.
Yes.
Please fire away whatever questions you would like to ask.
You see, you have been working with the top class hospitals, best quality equipments, quality retina service, and people in developed countries can afford it, and immediate and instant service is being provided. But in a country like India, where majority of diabetics, even 50% of diabetics do not know they have diabetes, out of those population, quite a large population do not know that they have any complication or not. They only treat glucose or sugar and think they are being treated. So you have also doing a lot of charity work in developing countries, including India, Odisha. You have donated to local Rotary Club and other things at your level. We congratulate you for that attitude and activity of yours. How do you think in a developing country we can manage diabetic retinopathy and diseases related to eye diseases related to diabetes?
Yes, the most important factor in diabetics, both type 2 and type 1, is the duration of diabetes, which does affect the retina. So retinopathy depends on the duration of diabetes, which is around 8 to 10 years. In the early stages, there may be very minimal changes, which are easily missed, like microaneurysms. Unless one is very experienced, these things will be missed. So the ideal thing that all diabetics needs to have a fundus photograph or diabetic retinopathy screening once a year or once in 2 years. That's what is happening in the UK. All diabetics are checked by the optician by photography, where the findings will never be missed. We can pick up either background diabetic changes or proliferative diabetic changes or maculopathy, which causes visual loss. Now, the good thing in India is there is a new technique with a smartphone, like a mobile fundus phone camera with a smartphone. It's called Remedio company. I think they're based in Bangalore. They're doing very good work. And this is not very expensive. So my recommendation would be all diabetics need to have a fundus photograph at least once in 2 years by this Remedio system, which is quite affordable. It's not expensive like a big fundus camera. So that will be my advice. And here the charity needs to get involved. Like we have raised about £50,000 to buy a vehicle which will have a camera and all the ophthalmic equipment and move from center to center. So in addition to the sort of government departments like eye units, there need to be these mobile units, and which will depend on charities like Lions Club, Rotary Club, and other charitable sources, which can have this ophthalmic equipment like Remedio fundus camera, smartphone fundus camera, which can pick up retinopathy changes. So that's very important. All diabetics who are at least 8 to 10 years of duration must have a fundus photograph once in 2 years at least.
Excellent. Excellent. But there is one question in the mind of doctors that regarding this fundus camera, handheld mobile camera, so what about the reporting? Who will report it?
Well, that has to be reported by, here in UK is the opticians, the optometrists who do it. But in India, I don't think you've got that many optometrists there, opticians there. So that has to be reported by either the ophthalmologist or the local GP or the diabetic physician. They can see the picture and they can see all the microaneurysms or hemorrhages or hard exudates. So it should be reported either by the diabetic physician or by the general practitioner or by the ophthalmologist, or if the cheaper option is to have an optician who can see it, who can report it. So it's much easier to see, identify and report if there is a good fundus camera and good fundus picture of the retina.
Thank you. I think artificial intelligence is going to play an important role where
Absolutely.
these pictures can be sent to a center and
Yes.
a report will be downloaded.
Absolutely. So that's the next step, is artificial intelligence, which will be incorporated into the smartphones or the Remedio fundus camera. So if there is a sight-threatening retinopathy like a maculopathy or macular edema or new vessels on the optic disc or retina, then those will be picked up by the artificial intelligence and will be referred to the nearest eye unit where laser treatment can be done, or intravitreal injections can be done, or steroid implants can be done.
Oh, what are these steroid implants?
These are, there are two implants. There are two implants which we are using now in UK. When there is macular edema, fluid in the macula, that is the cause of the visual loss. So if we see the fluid in the macula by the OCT scan, we have got OCT scans which can pick up the fluid, then we give, there are two types of implants. One is a short acting, which works for 3 months. It's a dexamethasone implant called Ojudex. It comes as an injection which goes inside the eye and the implant stays there. With slow release, the dexamethasone is released and resolves the macular edema. The other one is the Iluvian, which is a long-acting one, is fluoconazole, and it works for 3 years. But that only can be given to pseudophakics, like people who already had cataract surgery, where there is an intraocular lens. Then you can give Iluvian, which can work for 3 years. Whereas the Ojudex is short working, that say every 3 months you have to give injection.
Many persons come to us in diabetes practice, and when we refer them to retina specialist, they are usually with some hemorrhage or exudate.
Yes.
And during hemorrhage, doctors prescribe 2 to 3 types of injections, which are starting from 9,000-10,000 to 18,000 to 35,000 or something like that.
You see, the only time the injection should be considered is when there is new vessels, or there is vitreous hemorrhage, or there is a retinal hemorrhage near the macula. The cheapest injection which can be given in India is Avastin. Avastin is much cheaper, whereas we give here Eylea or Lucentis, which are a bit more expensive. Even here in UK standard, it costs about £1,000. So with the surgeon and with the injection, and it has to be done repeatedly. Every 6 weeks, injection has to be done. But that's only done when there are new vessels and where there is a threat of vitreous hemorrhage. So there, I think in Indian situation, Avastin is much cheaper. You see, Avastin is the drug which is given in bowel cancer. So it comes in vial and it can be distributed into 10 injections, and each injection is much cheaper than Eylea or Lucentis.
Right. So that is a hope for Indian patients. Those who cannot afford Lucentis can also be treated with Avastin.
Yes, Avastin is the ideal, because when we started in UK, I'm talking about 10 years ago, we did the same thing. I must have injected thousands of patients with Avastin. It works equally well. No harm in it. Only thing is it's not licensed by the company. So that's why legally you cannot give it, because there is no license for that use. It's only licensed for the use of bowel cancer. So that's a bit of a trick by the pharma company. But in Indian situation, I think it can be used. And so far as I know, in India, they're using it very frequently.
Numbers are being used.
Yes, Avastin is a good drug. I can recommend that, because 10, 15 years ago, I must have done a large number of patients with that.
Dr. Das, our Indian diabetes practitioners, I should say physicians and diabetologists, not endo. So they need to tell the patient that your eye is in this stage or this stage of danger. So in a general practice, if the fundus camera is used, this mobile camera, I think doctors can be taught how to interpret it and how to go on. What do you think of this?
Yeah, absolutely. Here, even in our clinics, now our nurses are doing it. You know, the nurses and the photographers, they are doing it. And once there is artificial intelligence, that will tell you when to send to an eye surgeon. So that's the way we are going. And my advice and recommendation is this Remedio, which is developed in Bangalore, will be much cheaper for Indian condition. And it's very good. Remedio, I have seen images. The images are not bad. So if one can use this smartphone fundus camera like Remedio camera, and then the GPs and the diabetic physicians can easily see the images. They can pick up when there is a microaneurysm. They can see when there is a hard exudate. They can see when there is macular edema or when there is new vessels. And those are the patients who need to be sent to a BR surgeon or a eye surgeon with a retinal interest. Then one can consider about the intravitreal injection either with Avastin or to give laser. That's another thing is the organ laser. We can give focal laser for macular edema or steroid implants. So those things, that's the way we are slowly moving. But my recommendation would be that the future is this Remedio smartphone camera, fundus camera in India. And also there is a role for all the charities like Lions Club and Rotary Club to help here. And we are doing it. Like I'll be in India next week. And in Bhubaneswar, the Rotary Club of Bhubaneswar and our Rotary Club here in Birmingham, we have combined and we got an international funding for £50,000. So we are going to start a project in Bhubaneswar and I'll be there for a few days from next week. Yes.
What should you recommend to our state government or state governments in India that they should do in the public health centers and the PSCs and CSCs and those places?
Yes, I think my recommendation is the Indian youth, the young people are very good in IT. So they can be trained like photographers with the AI to take the fundus photograph with the Remedio camera, and then the AI will tell when the patient needs to be sent to an eye surgeon. So that's the way we are going.
Great. So this can be suggested to state government.
Yes.
So you do not require, you always do not require ophthalmologists.
No, you don't. You don't, not in the initial stages. And that's what's happening in UK. In England, every patient is photographed by an optician and a medical photographer. So we don't see them. They come to us to the clinic when there is a problem. And that will be picked up by the artificial intelligence in 2-3 years' time.
Right. Excellent. So this will definitely discuss with the state government to take it forward. And during that course of conversation, if your help is required, we'll connect you to the state government.
Yeah, it's the role of National Health Service here in England. When these diabetics are having photographs or retinopathy screening, a specific company has got contract from the NHS. That's the health department of the government of UK. So they provide funding to these private contractors for photographs once in 2 years or once a year. And then the optician has a look at the images. And when there is a problem, the optician will refer them to the eye clinic. Then only we see them.
Excellent.
Otherwise, we don't have capacity to see all of them. There has to be a problem before we can see them and treat them.
Absolutely.
Yes.
And I would like to, our patients also, those who listen to this and our doctors, that what are the precautionary measures that a diabetic from the day one he diagnosed should take to delay and prevent retinopathy?
It's the good and steady control. We don't want that yo-yo fluctuation, one day high, the next day low. So it's a good, regular, steady control of blood sugar. That's the important bit. And second thing is to treat the other things like associated hypertension, blood pressure, heart trouble, to watch for the diets, to have a chat with one of the dietitians, see what's the best diet for them. But the most important thing we have noticed is the associated hypertension or high blood pressure must be treated, must be detected, and there should be a good and steady control of diabetes. We don't want fluctuation of blood sugar. That's one of the factors which causes retinopathy. But the important thing is the duration. If somebody has diabetes for 8 to 10 years, there is 99% chance he'll have retinopathy, like microaneurysms, small hemorrhages, dot hemorrhages. So there, the Remedio fundus camera will come into action. So there should be a fundus photograph once in 2 years, good, steady control of diabetes, associated features like hypertension, heart disease must be controlled. The patient must have a discussion with the nutrition, the dietitian or the nutrition specialist regarding the diet. So these are the things which they need to keep in mind. And also cholesterol, to keep the cholesterol, lipids within right control.
Very nice, Dr. Das. It was nice talking to you. You not only spoke about the high technicalities of retinopathy management, you also educated us about the national scenario and what a state government and private organizations can do, what charity can do. Thank you very much for joining us. And we thank you on behalf of National Update on Clinical Diabetes.
Yeah, my greetings and best wishes to all the physicians and the patients who are listening. Merry Christmas and Happy New Year.
Thank you. Thank you so much.
Thank you.
Namaskar.
Thank you. Thank you.
I think
Thank you,
this
sir.
was great interview, Alok. I think Shrikant, you also feel no great interview and getting 50,000 pounds with 50 lakhs for a project in Bhubaneswar. I think Alok, you have greatest potential to affect it also in our field, Alok. You see, I think the world, if you give a good project on the diabetic retinopathy and diabetic retinopathy screening prevention in Odisha, he's your friend. He was 1 year junior to me in the college, 1 year, and he looks different. He has totally changed. But he was 1 year junior, very promising boy. Over to Professor Shrikant to carry it forward. We have got a few minutes left, 20 minutes left for the discussion. Shrikant.
Thank you. Thank you, sir. We have gone with so many nice sessions. Erectile dysfunction, depression. Probably this is the time for intervention for the panel discussion. I think one of my co-chair is not there. You can be there for us. Dr. Sau, you can join with us, sir. The other speakers, Dr. Siva Prasad, Dr. Giovanni is there with us. I hope so.
Dr. Sangamitra is there.
Sangamitra is there. He's a famous retinologist. And Alok is there. Alok does a lot of work in the psychosocial aspect of diabetes. Alok is here. Please continue, sir.
Why please stay with us.
I think they are not with us. Are they present?
You can ask questions, whatever you want to ask.
Yeah, good evening. I'm there.
Okay. Is it a session on retinopathy or we'll talk on all this because other the speakers like Dr. Siva or Dr. Giovanni would be there, I think.
I think, Shrikant, I will suggest Dr. Professor Sangamitra will speak about retinopathy or comments. You can start with the questions on the psychosocial aspect, depression, and things like that. Siva is also there. Both of you can discuss the questions that you have made. Then we'll pass on to Sangamitra.
Yeah, how to differentiate my question to Dr. Siva, how to difference between diabetic distress and depression. And my question will be, what will the red flag sign when the patient, a diabetologist or a physician or a endo to refer to a psychiatrist? What are the red flag signs?
Thank you, sir. Am I audible?
Yes, yes.
Yeah.
As I was mentioning, diabetic distress is quite common, and most researchers understand it as a reaction to having diabetes, especially over a long time. So it is not a mental disorder per se. So what it means for the practitioners is that apart from HbA1c and glycemic parameters, we need to ask the patient. We need to be confident about asking those questions. How are you doing? What is your state of mind like? How are you managing your illness? And are you sleeping well? And how is life going on? And giving an opportunity to patients to open up and speak about their psychosocial factors, that will definitely go a long way. And they need to be educated and counseled a lot. So that can be handled by the physicians and the diabetes care team. Of course, if the doctor is busy, then maybe you need someone else. It can be done by a nurse, or even a trained social worker, or a psychologist if possible. But if the criteria for depression are fulfilled, I also mentioned common screening tools during the interview. So if depression is picked up, then it makes sense to refer to a psychiatrist for further assessment and management.
When to suspect a case of diabetic distress?
Pardon me, sir. Can you repeat the question?
When to suspect a case of diabetes
Yeah.
with distress? What are the signs that will yield that this patient is probably a case of diabetic distress? And do you think whether the dementia, which is also a part of this forum, when they are attached, how do you deal these cases?
Yeah, that's a very good question, sir. Like supposing in the course of treatment, we find that the patient is not able to adhere to the prescription properly, and good glycemic control is not being achieved despite a good prescription. And more obviously, during interaction, it looks like the patient is worried a lot and is concerned about, how am I going to live with this illness? How am I going to manage everything? So there can, be all these clues that are picked up during the interaction. And if the opportunity is given to the patient to maybe speak to a counselor or a social worker after the initial consultation with the diabetes specialist, that can also help us pick up the issue. And yes, presence of dementia can complicate matters further, because if you diagnose dementia either through the clinical interview, then that will require a lot of further assessment and management by preferably mental health care professionals.
Yes, what in our day-to-day diabetes practice, what I have observed, if you talk little closely to the person and interact, senior elderly people, after some questions, they start crying. There is a unmet need. Their children may not be taking their care. Their finance is not adequate. They have sufferings which they are not able to go for surgery and other things. A lot of stress, distress is there, and a close interaction with the physician or diabetologist brings it out. And you can always, what should we give in addition to diabetes treatment in those patients? Mood elevators, sleeping tablets, what are the things you recommend?
Sir, if it is just diabetes distress, then actually medications might not be needed. It can be managed through very patient education, counseling, addressing their needs, allowing them to speak. And if a social worker or a counselor can interact with them during the routine follow-up sessions. So, for such situations, medication or referral might not be required. Of course, if there is insomnia, then like I was mentioning earlier, safe drugs such as zolpidem, melatonin can be tried. But when there is a suspicion that this is more than diabetes distress, there is a depressive episode. Of course, there are popular screening tools also which will clearly tell us that this is more than diabetes distress. There is some depression. Then it might be a little difficult for the medical team to handle it in terms of time, manpower, and all that. And in such a case, referral would be recommended. Of course, it's not that SSRIs can be prescribed by any physician, provided we have the time and the confidence and the expertise, we can. But when there is an element of doubt, it is better the diabetes care team refers to a psychiatric colleague. And the experts actually say that psychosocial care should be embedded within the physical care. Of course, referral within the same hospital to another department or to another clinic, that would be recommended. And sometimes the patients might wonder, why am I being referred to a psychiatrist? Why is a psychiatrist required? So that will also require some time. The primary diabetes care team must explain to the patient, see, we feel that you have a little more than diabetes distress. You seem to be having some depressive symptoms. So it will help you and it will help your diabetes management also if I refer to you to a psychiatrist.
Thank you, sir. Srikant, to Sanghamitra.
Question for Madam Sanghamitra. How often you use steroid, as sir was saying? How practical often steroid use in retinopathy in India and Odisha setup? And my other question will be, pre-diabetes are also associated with retinopathy at some study stage. What is your take on that? How can we manage them?
Thank you so much for the question. So first, let me just clarify some of the things as told by Dr.
Can you be
Das.
visible? Can you be visible? Can you make your video on if possible? Otherwise,
Yes.
Thank you.
So I will just clarify some of the things that Dr. Das had already said. I quite agree with the duration of diabetes that he said, and along with the other systemic parameters that go on to increase the diabetic retinopathy chances. What he said about the Remedio camera, handheld camera, there are other devices also that are available that like your smartphone can be used with a small attachment to the slit lamp, which is much cheaper, about 25,000 you can get that, and that is widely available in with Amazon also. And about the AI incorporation, probably India is a pioneer in that with Shankar Nethralaya, Dr. Rajiv Raman, and Arvind Eye Hospital, Dr. Kim has been pioneering with Google Sundar Pichai to do all these studies on AI with diabetic retinopathy. And they have found out also that they can predict the patients having diabetic retinopathy, how they can, they'll have cardiac ailments in how many years, they can predict that too. About Avastin, so Avastin is actually not approved by the government. That is why we do not practice it rampantly. We have many biosimilars available in India, and they work equally good. If what he said about Lucentis and Eylea, we have many biosimilars at almost 1/3 the price. So we go along with biosimilars because they are been approved by the government. And about the Iluvien, we do not have Iluvien in India. So the only the steroid that I'm going to answer next is only Ozurdex and Tricot or triamcinolone acetonide we have in India. And about the government associated program, we had the Sunetra program that was going on with the previous government. So there is already a study that is going on, diabetic retinopathy study with the government going on right now. So coming to your questions on how often we use steroids. So steroid is usually is given as a second choice in many of our practices. That is so because steroids increase cataract. And so in pseudophakic, probably that can be the first choice, but in phakic patients, we usually avoid it. And it also goes to increase in your intraocular pressure. So that is why it is usually taken as a second line of treatment. And in those cases where your anti-VEGF or anti-vascular endothelial growth factor have not acted properly, or there is a large amount of macular edema that is present. Steroid usually doesn't have any role in high-risk PDR or in vitreous hemorrhages. There usually we give anti-VEGF. I just couldn't get your second question, sir.
Some of the pre-diabetes are also said to be have some retinopathy, like less than 7% cases. So what is our take on that, and how to treat those cases, or only sugar control is the only treatment policy, like lifestyle modification?
So the treatment of diabetic retinopathy is only if it is a center involving, like if there is a CSME, that is clinically significant macular edema, where you have fluid in the center of the macula. Only those cases we treat, or those cases of high risk proliferative diabetic retinopathy are the cases that we treat. If those pre-diabetic usually do not have that amount of retinopathy, if they do not have that amount of retinopathy or macular edema, we usually do with a diet control.
With the permission, sir, I want to ask one thing. The Remedio, madam, as you rightly said, costs about, it was cost about 2 lakhs. Now they have made the price quite high.
Correct.
Now, just wanted to ask you, this small attachment which you're talking about, I have seen them to the to be put your smart phone. Do they are they also non-mydriatic, madam? Non-mydriatic camera, those Amazon attachments?
No, usually they do not give you a very good with non-mydriasis.
Okay. So you have to put mydriatic drops.
Yes, yes. So
And
we
how
have
robust they are?
actually now many of the centers and in Odisha also, they have mobile vans where they have all the attachments, the fundus camera, the slit lamp, and an indirect. Along with, we have a lot of young doctors coming up, ophthalmologists coming up, and lot of centers producing optometry. So we have abundance of all this. So there's no dearth of this in our state.
Because Ophthal, unlike Alok Kanongo's specialty, Ophthal has been a blessed specialty, whether it is Arvind, whether it is Shankar Netrala, whether it is what is that called in Hyderabad?
LV Prasad. LV
Prasad, all over the world. I'm sorry, madam, in jocular vein, you have the mafia to help you. We don't have any mafia to help us. No, we have. Madam, the second thing I want to ask you, the very simple question. Madam, you do PRP only in case of progressive retinopathy, or you do it also background? I was also told that macular edema, you also do PRP. Is it correct or wrong?
So to answer your first question, PRP in high risk PDR or in those high risk PDR, usually we do PRP if there is no vitreous hemorrhage. And those we do not have high risk PDR but are at a risk, like they stay in a far off place, or they have a severe NPDR and they're uncontrolled for a longer period of time. The chances of going to high risk PDR is much more. So in those cases, we go in for a pan-retinal photocoagulation. And for macular edema, we do not give pan-retinal photocoagulation. We do focal laser or a grid laser. That is to the macular area. Sir, you're muted.
We have a molecule called pioglitazone. It is credited with or discredited with having macular edema. Have you seen very often macular edema with pio?
So we have seen some of the patients, though we haven't really analyzed them. But yes, we do take a history of pioglitazone.
Yes, sir. Over to chairman, sir. Sir, please take over.
Madam, what is the borderline? When to send to a ophthalmologist? Which grade?
So we have been always complaining about diabetologists not referring the cases or not educating the patient. That is the first complaint that we all ophthalmologists do have it. So it is because the patient usually comes to you first. They do not come to us first. So there has been a great stress on educating the diabetic patient, as in your previous talks I have heard. So that is of foremost importance. And any patient, as Dr. Das has already said, with 10 years of diabetes, almost about 90% of type 1 and 60% of type 2 patients have some amount of retinopathy. So we usually do not know type 2 patients when they had the retinopathy. So we ask the diabetologist to send the type 2 patient as soon as they are diagnosed. And then they can have a follow-up according to the stage of diabetes that they have, retinopathy that they have.
Beginning of the treatment, there has to be a retina, renal, and cardiac assessment to know the baseline of the patient and over which yearly it can follow. I think I follow that.
Correct.
Madam, what is the sensitivity of the mobile instrument you shared about that mobile instrument is available?
So mobile cameras, they're quite sensitive. And these mobile vans, what happens is that supposing the vitreoretina surgeon doesn't have to go along with them. So and internet is widely available everywhere now in India. So that is a very cheap thing that they take the photograph, send it to the base hospital, and there we have vitreoretina specialists or fellows who can grade the retinopathy. Immediately we can send the photographs and they can be called to the base center if they need so.
Professor Srikant, this is practiced very widely in our country today.
Correct.
We use the Remedio camera and that is linked to the AI. But at the end of the day, Professor Sagamitra has to be there because we always take a second opinion. Final, am I correct? We take a final opinion from the ophthalmologist. Even if the field has been reported upon by the AI, we always take a senior ophthalmologist's opinion, especially the ones which are on the gray line.
Yes. So I think other speakers are Deepak is not there. Sipraka sir has told Surajit is not available. I think Sanghamitra has addressed the topic very nicely. Professor Das, please conclude.
I think sir, this has been a very good session with a very classic interview by Professor Siprakash and a very important also interview with Vichitranda Das and a very clear depiction of the sexual dysfunction by Dr. Deepak Jumani, my student and great person today. And the panel discussion has been also exceedingly well done. Thank you, Sanghamitra Madam. Thank you, Siprakash. And thank you, Professor Srikant, for being here amidst us and giving us encouragement. A great session, madam. Madam, in
Thank you
every
so much.
invite you. Thank you, madam. Thank you, Sib. Thank you, Sikant sir. We'll
Thank
pass
you.
to the next session.
Thank
Dear
you, sir.
friends, we will pass on to the next session. It's my great pleasure and honor. Exactly at 5:30 we're starting. So can I invite the first session? This is the last session of the day, and this is on the nutrition and exercise. And I am delighted to inform you that two of my great seniors, Professor Vijay Mishra is my senior. I have got Dr. Shishir Kumar Mahapatra, who is a very famous physician of our state, very well read, a very well communicator, and has already been he is currently chairman of the RSSDI Odisha chapter, and I met him in the last month in Bhubaneswar. And my senior, Dr. Vijay Mishra, who when I was in Unit 3 and in the cardiology, Professor Vijay Mishra had actually taught me. Thank you, sir, being here. I could not talk to you on the first day. And we are handing over the entire session to Professor Vijay Mishra and to Dr. Shishir Mahapatra. And we have very famous speakers, and over to them. Thank you, sir. Thank you. Hello?
Vijay, sir, are you there?
Yes, sir, he is here.
Shishir, sir.
No, they will start now. Sir, Professor Mishra and Professor Mahapatra, you can kindly start. Then we'll have one recorded. Shall we start, sir? Vijay?
So Dr. Mishra has logged in, but he is not answering.
Okay, give it to Shishir Mahapatra.
So he has not logged in.
He has not logged in?
No.
But we are starting in time, 5:30. They thought it may be late, but we are absolutely in time, Alok. That's a good thing. Can you call Dr. Shishir? You have his phone number?
Please call Dr. Cyril Salis. Hey, Dr. Vijay Mishra is calling me.
Then he must be. Ask him to join.
Sir, ଆପଣଙ୍କ sound ଶୁଭୁନି? Stuti, Professor Vijay Mishra is on muted. Kindly
Sir, I
unmute.
have sent him the request to unmute. He has to accept that request.
He told me that he is not. ମୁଁ କହିଦେଉଛି। ସାର୍ ଆପଣଙ୍କୁ ସେଣ୍ଟରରୁ ଆସିଛି ମେସେଜ ଆସିଛି ଯେ ଆପଣ
ଅନମ୍ୟୁଟ କରନ୍ତୁ ବୋଲି
କରିଦିଅନ୍ତୁ ହେଇଯିବ। ସାର୍ ଆଉ ଥରେ ଜଏନ୍ କରିଦିଅନ୍ତୁ ସେଇ ଲିଙ୍କରେ ଆଉ ଥରେ ଜଏନ୍।
Dr. Shishir Mahapatra join କରିଛନ୍ତି? Hello?
ଜାଣିପାରିନି।
Stuti, has Dr. Shishir Mahapatra joined?
No, sir.
Can you call him? You have his number?
Told me that he may or may not be joining.
He told you? Acha.
But Vijay sir must come.
Has Vijay sir unmuted Stuti?
Re-logging.
Because we have two recorded things, Shadil Salis and also with Dr. Sanjeev Panda. Then we have one talk by Dr. Rucha Mehta, and then we have the panel discussion. Very simple agenda.
Sir, है कि? हाँ. He has joined.
He has joined Stuti.
Yes, sir, he has joined again. I have sent him the request to on his video and audio both. He has to accept the request.
Yeah. कह दो unmute कर देवे. So कह देती है. Unmute कर देवे और video on कर देवे. Please unmute and.
अगर recording in progress कोईला.
सर हम कह दियो unmute पर click कर देवे और start your video पर mute कर दो.
Sir,
Sir is here. Sir, good evening, sir. Ashok here. My sincere regards.
Oh,
Sir,
yeah.
Ashok here, sir. Ashok here.
Thank you, Professor Das, Dr. Kanungo, for the invitation. Actually, I am trying because last 3 sessions I am there, but it is muted. So all right. So actually, this is the last session of the proceeding of 10th, 11th NUCD, and both Dr. Kanungo and Professor Das have managed it very, very extremely well. There are a lot of, and this is the last thing is the nutrition and exercise. So actually, these are the two most important pillars of lifestyle changes in diabetes. And if you just see the nutrition therapy, because what is our goal? Our goal is to achieve and maintain the body weight. And we must, through diet, also attain the glycemic goals, lipid goals, and blood pressure goals. And this is again, now we must also need the individual nutrition to be given by the dietitian. And diet is a very pleasurable thing. So the person should not think that with the diabetes has become, has got a curse so that he is not able to take diet properly. But the pleasure of eating is to be maintained by the dietitian with the conversation with the patient, because this is an individual need. And for all this, we require good education and support. And then the physical activity or exercise is a very, very important aspect. And we know that 150 minutes of exercise a week at ideally 30 minutes up to 5 days a week or twice a week, that as per the need you can give. And particularly you must do the aerobic and resistance exercises. But very, very important thing is that exercise program, before starting the exercise program, you must have to see your fitness. That should be, because it is again, many persons with elderly diabetic with the comorbidities have a lot of problems. So naturally one has to look after that very well. And you must know the contraindications of exercises, particularly the which we discussed now also, the advanced retinopathy and uncontrolled diabetes, uncontrolled blood pressure. Again, these people and the person those are not able to maintain their stability and balance. So one must have to categorize them, personalize them with their what exercise they should do. So with this, actually, I will like that we have speakers who can talk, and the first speaker on the session will be Dr. Shirley Salis, who has been introduced earlier also, and she is a registered dietitian and has a certified diabetes educator, insulin pump specialist, and a founder and director of Nature Health Solution. She is a regular participant in National Diabetic Clinical Diabetic Update of ours, And with this, actually, I request her to tell a topic that preventing diabetes complication through diet. Dr. Salis.
Hello, everyone. At the outset, I'd like to thank Dr. Kanugo, Dr. Panda, and Dr. Ekedas sir for the kind invitation to be a part of NUCD. My topic is preventing diabetes complications through diet. Now, we all know, and we always tell our patients that diabetes is a silent disorder which can result in serious complications if not kept under control. And therefore, optimal glucose control is what we desire to ensure that we live and our patients live a diabetes complication free life, for which the four main pillars, which is diet, exercise, medication, and monitoring. And today we're all discussing glycemic variability and how it's important to ensure that the person has good glucose control, especially with minimal glycemic variability, to ensure that the person's life is complication free, especially if the person has diabetes or even pre-diabetes today. Now, if you look at all the studies that have been conducted, whether it's the START study and also the What India Eats report, the Eat Lancet Commission report, it clearly states that we in India eat a diet which is predominantly high in carbohydrate. Again, the carbohydrates mainly coming from cereals and also from refined carbohydrates, and our protein intake is less, and therefore we are definitely very high in terms of our carbohydrate intake, especially coming from our refined carbohydrates, and therefore resulting in a higher postprandial blood glucose levels because of the high glycemic index as well as glycemic load of the foods. Now, even the Cures study has also shown the similar findings, wherein refined cereal consumption was very high, along with accompanying oils and salt, which contribute heavily to the glycemic load as well as all, to the metabolic syndrome per se, resulting in complications in the long run. Now, elevated glucose levels, especially we are seeing in our clinical practice where people are consuming a lot of unhealthy snacks, which is, HFSS as we call it, which is high fat, sugar and salt, especially in the evening time as snacks or even at dinners. In fact, dinners have been replaced by snacks, which they, patients think are light snacks, but often we see that they are, high in refined carbohydrates as well as high on fat as well as salt. Even the breakfast items, most often we see that the breakfast is high in carbohydrate, especially, and also low in protein with minimal fiber in the breakfast item, resulting in high postprandial blood glucose levels. And again, if you look at the dinners, because they are very heavy, often we see that people are more controlled in terms of the eating through the day, but dinners become very heavy and also very high on the carb load with lesser protein and fiber intake, resulting in elevated fasting glucose levels. And because of that, the entire day, the glucose levels are high because most of the people are consuming small, frequent meals. I wouldn't really say that they would think that it is small, but often we see that the glycemic load of these meals is pretty high and consuming them very often because they think that if you have diabetes, you are supposed to eat every 2.5 to 3 hourly, which keeps them in the postprandial elevated state most of the day. And today we know that high postprandial levels are a causative factor for cardiovascular disease, and therefore it's very important to keep the fasting as well as the postprandial glucose levels under control. Now, how do we manage? Very simply is when we talk to the patients is one is we tell them to take a smaller plate, which is a 9-inch plate, fill half the plate with non-starchy vegetables, 1/4 of the plate with cereals, millet and starchy vegetables, and 1/4 of the plate with protein group, which in our country, dals come in between the protein as well as the carbohydrate. By doing this, we're improving the diet diversity of the meal, we're improving the nutrient density of the meal, ensuring there is protein and fiber in every meal, and also the glycemic load of the meal can be brought down. Having done this, we then follow with the reducing the glycemic index and the glycemic load of the meal, for which again, consumption order, which is the food order, that's starting the meal with fiber, protein, and then having the remaining part of the meal, has shown to improve the postprandial blood glucose levels. Cooking techniques, trying to use more unprocessed, unpolished cereals and grains, food combination, making sure that we are eating a well-balanced diet, which has got a good combination of, healthy carbs, more complex carbs, protein, fiber, and healthy fats, ensuring that this can break down the glycemic index as well as improve satiety, therefore resulting in lesser amount of meals. So portion control resulting in improved postprandial blood glucose levels. When we're looking at fruits, again, we ensure that the person is choosing fruits which are slightly unripe, again focusing on seasonal fruits, and the timing of fruit again becomes important. The portion of fruit again becomes very important. Adding vinegar and lemon or anything tangy to the food is shown to lower the glycemic index of the meal. So these are some of the strategies to help improve the glycemic index and therefore arrest the post-meal glycemic spikes, therefore minimizing the risk of complications related to the high postprandial blood glucose levels. Now, when we're looking at the dietary patterns in India, the recommendation by the CAST study is, and what is shown is that frequent intake of fruits, green leafy vegetables, and other raw vegetables and nuts, along with a higher dietary diversity score, was associated with the lower prevalence of diabetes and hypertension in South Asians. And therefore, the focus on balanced nutrient intake, portion control, supports good glycemic control, focusing again on low GI, low GL diets. Again, not very low carb. I mean, if you're looking at very low carb diets, it has to be done under strict supervision of a medical team, which includes the doctor as well as the dietitian, understanding the pros and cons, looking at the baseline levels, and again, the duration of time, and ensuring that the kind of carbs that are the fat and the carbs, the quality is, something that we need to look at. Energy restriction, yes. Studies have shown that reduced energy intake, reducing the carbohydrate, and improving the protein and fat in the form of healthy fats in the diet can help improve glycemic control in diabetes by lowering HbA1c. Now, this is, again, if you look at our Indian diet, it is predominantly like very close to a Mediterranean diet. And we're looking at something which is, like a modified Mediterranean diet to suit the Indian population. Again, when we're looking at, whether it's a Mediterranean diet or the DASH diet, and today we have a combined, which is known as the MIND diet, which is Mediterranean DASH intervention for neurodegenerative disorders, and the New Nordic diet, which is again very close to the Japanese kind of, intake, as well as the Mediterranean diet. Now, what does the diet entail? It's locally grown, predominantly plant-based foods such as fresh fruits, vegetables, mushrooms, legumes, nuts, seeds, and whole grains. Focus again on complex carbohydrates such as whole grains and pulses. Emphasis on low GI, low GL. Using skim milk dairy, skim dairy products, fish, eggs, white meat, and Nufa oil in moderation. Low amounts of fat, especially saturated fats, meat, processed meats, sweets, and avoid processed or ultra processed foods. Reduce salt consumption, limit alcohol intake, vitamin D supplementation in case of deficiency, and at least 30 minutes of daily physical activity per day. Again, this is shown to improve cognitive function, and therefore the MIND diet is definitely, we have a lot of evidence to show that it definitely helps to improve cognitive function. Whether you look at the Mediterranean diet, the DASH diet, or the New Nordic diet, there is enough evidence and meta-analysis to show that it helps improve glucose control, blood pressure control. It helps in dyslipidemia management as well as reduces cardiovascular disease risk. There is a lot of evidence today in terms of plant-based diets, and we know that today, even if you look at the international guidelines, they are focusing on advocating a more plant-based diet with minimum consumption of, non-vegetarian foods, especially coming from your fish or lean meat. But plant-based diets, there's a lot of evidence to show that it does help in improving glucose levels, blood pressure, reduces inflammation, dyslipidemia management, and reduces cardiovascular risk. Now, very important is that if a person chooses to be a vegetarian or vegan, where they avoid even dairy products and a lot of other foods which come from non-veg sources, it is important to look at what is the amount of protein that they're consuming, because if it is not really planned by a qualified dietitian, we do see that the protein intake anyways is less in our population. And then when they turn vegetarian or vegan, without really focusing on protein in every meal, there could be a protein deficiency. And therefore it has to be, the focus has to be on including protein in every meal, because one is it helps to improve satiety, as well as it also helps to meet our protein requirements. other nutritional deficiencies that could arise by a vegan diet, such as vitamin B12, B2, niacin, iodine, zinc, calcium, potassium, and selenium needs to be again taken into consideration. And while planning the diet, we have to ensure that we definitely put in foods which are a good source of these nutrients to ensure that there is no nutritional deficiency that is arising because of these kind of diets. However, there's a lot of evidence on plant-based diets in reducing the risk of, related to all your metabolic syndrome. Now, there is a lot of people say that, my weight is high, but then I'm metabolically healthy. But there is evidence to show that a metabolically healthy, obese individual can, turn into a metabolically unhealthy individual if he continues to, live an unhealthy lifestyle. And therefore, it's very important, again, to ensure that the person follows a healthy pattern in terms of lifestyle, whether it's physical activity, stress management, sleep, as well as the right nutrition. Now, when we're looking at dietary fats, especially when we're looking at diabetes, and we know that diabetes is directly linked to cardiovascular disease, and therefore their focus, while we're improving, or reducing the amount of dietary carbohydrates and looking at the quality of carbs, improving the amount of protein in the diet, again emphasizing on the quality of protein, dietary fats also becomes very important. And therefore, when it comes to fats, again focusing on quality and quantity of fat, approximately trying to keep it to say 20 to 25% of calories coming from fat, Mediterranean style eating pattern, which is rich in MUFA and PUFA, low in saturated fat, which is less than 10% of daily calories, and less than 7% in case of dyslipidemia. Where we are trying to reduce the carbohydrates and still meet our calorie requirements, then the carbohydrates that we're reducing can be replaced by healthy MUFA fats to meet the calorie requirements. But very important is to focus on the quality of fats. Food rich in omega-3 fatty acids, such as fatty fish, 200 grams per week, and nuts and seeds. Again, nuts and seeds are a low, they do not contribute so much of carbohydrates, but they have been shown to improve metabolic health, especially in terms of cardiovascular disease. And today we have a lot of evidence, whether it's almonds, walnuts. There's a recent study published by Dr. V. Mohan and group on pistachios, which have shown that it definitely helps in, improving metabolic risk profiles, especially in terms of weight, whether it comes to diabetes, cardiovascular risk profiles, etc. Again, very, very important is when we are prescribing nuts and seeds, we have to tell them to have unsalted nuts and seeds, because mostly that we see that people have salted nuts or, salted seeds, which will actually increase the amount of sodium intake in the diet. The N6 to N3 ratio should be between 5:10:1, where we see that the current consumption, the ratio is around 20:1, and therefore improving the amount of N3 in the diet becomes important. So therefore, omega-3 food sources, if you're looking at plant sources, there is walnuts, there is chia seeds, there are flax seeds. These can be incorporated in the diet. Again, we have to keep a tab on the amount that they're consuming, because they're also very dense in calories. Use of vanaspati should be avoided, negligible trans fats, and very important is reheating and refrying of cooking oil should be avoided. Now, when we're looking at the oils, again, if you look at India, we're very diverse as a country, with north, south, east, and west. You look at the oil consumption, it's very, very different. So again, depending on the regional preference, so if it's like North India or Northeast, you can look at maybe mustard oil. The eastern part of India, again, mustard oil. The southern part of India usually uses gingerly oil. Western part of India would use, rice bran oil or groundnut oil. So again, depending on which part of the country we are from. So these are the recommendations from NI and ICMR, which is, a combination of oils, or choosing to use blend oils, which are readily available in the market. In case of ghee or coconut oil, which is again used as a fat source in most of our Indian cooking, then restricting that to, within the saturated fat intake becomes very, very important. So in case we're recommending, say, 4 teaspoons of oil per day, then 3 teaspoons coming from your oil and 1 teaspoon can be from ghee or coconut oil, to make sure that it is within the saturated fat budget. Again, when we're looking at eggs, today we have evidence to show that eggs with the yolk is safe for people with diabetes. And again, not exceeding, because we see certain people that who would overdo even eggs, maybe take 8 to 12 eggs a day, especially if they're following a very, very low carb diet. So again, telling them as to what is their budget and how much of egg they can consume in terms of egg yolk. And they could definitely add more egg whites to add to the protein and meet their protein requirements. Now, high fiber is again very, very important, especially if you want to prevent cardiovascular disease and also overall for metabolic health. And therefore, looking at fiber from all your whole grains, fresh fruits, vegetables, nuts and seeds, and all your locally available seasonal vegetables. There is enough fiber that we can get into the diet. India consumes, we have seen that the consumption of fiber is deteriorating over time because the kind of food that people are consuming, more and more ultra processed packaged foods, which are low in fiber, and therefore the focus has to be on including fiber with every meal, because it also helps to blunt the post-meal glycemic response. And how much fiber? It is recommended to consume at least 25 to 40 grams of fiber per day. But very important thing that we need to remember is that whenever we increase the fiber, we should also increase the fluid intake, because if we increase the fiber and do not increase our water intake, it can result in constipation. Again, too much fiber in a meal may also hinder nutrient absorption. So anything in excess is not going to be good, and therefore it has to be done in moderation and gradually increased. Now we come to the salt and the sodium. Now there is a lot biscuits, our chips, namkeen, pickles, which is mostly commercially available, papads, etc. They're loaded with salt, and therefore, when we're looking at sodium, we have to focus on where is the hidden salt. So again, a lot of your sauces, etc., would also have sauce. So this, education and empowerment is very, very important when we are counseling our patients. Now, what is the amount of salt that we recommend per day? It is 1 teaspoon per day. This is what most guidelines suggest, which is around 2,300 milligrams of sodium per day. And this is coming from all the foods, not only the added salt, but we're also looking at salt coming from all the packaged, processed, ultra processed food that we are consuming. And there is enough evidence to show that we Indians definitely consume far too much more salt than we are, supposed to be consuming. Again, today, right from the Kumamoto study, as also the UKPDS and the DCCT trials, we know that fasting blood glucose control is extremely important, because even at a blood glucose level of more than 110 milligram per DL of fasting, it can increase our risk of diabetic retinopathy. And therefore, glucose control is very, very important. And therefore, we're looking at good control of fasting, postprandial, minimal glycemic variability to ensure that we help our patients to live a diabetes complication-free life. And therefore, reducing retinopathy risk through diet, there are certain nutrients which definitely help, like antioxidants, lutein and zeaxanthin, your omega-3 PUFAs, your dietary fiber, zinc, vitamin C, E, A. These are antioxidants as well as anti-inflammatory nutrients. Now, how do we get them? One is following the Mediterranean diet. Again, if you look at our Indian diet, it's very similar to our Mediterranean diet. Lots of, fresh fruits, vegetables, your nuts and seeds, whole grains, pulses, etc. Fish consumption wherever possible. Again, making sure that the fish is not fried, and we're having fish either in steamed form or curry form to make sure that we're also preserving the essential nutrients which are good for health. Your lutein and zeaxanthin coming from your green leafy vegetables, turnip greens, broccoli, pumpkin, peas, corn, avocado, red bell peppers, etc. And if you look at it, most of it is something that we consume on a daily basis. Again, very important is to look at the economics. If somebody cannot afford an avocado or bell peppers, it's not mandatory that we would prescribe it. We have to definitely look at the socioeconomic status of the person. The intake of oily fish at least twice a week was associated with a nearly 60% reduction in risk of retinopathy. But again, the way the person, makes the fish is very, very important. So fried fish is definitely not going to be helpful. It has to be steamed or, in a curry form with minimal oil, and definitely salt restriction. Now we're looking at preventing renal complications. And the first thing that comes to mind is when we're looking at anybody with, slightly elevated creatinine levels, or even we're looking at, people with high uric acid levels, the first instruction that is given to most people is to stop protein or reduce protein intake. Now, if you look at our Indian population, especially when we take dietary recalls, we see that the protein consumption itself is less. And we have enough evidence to show us that there is deficiency in terms of protein intake. We see around 0.4 to 0.5, maximum 0.6 grams of protein per day that an individual, most people would consume. And therefore, instead of actually saying reduce protein intake, review the protein and improve the quality of protein would be beneficial. And today we know that hyperuricemia is not only because of high protein. In fact, it is a part of metabolic syndrome, and mostly because of high fructose corn syrup, high fructose intake, as well as dehydration or even high alcohol consumption. So all these need to be looked at. Definitely focusing on reducing the amount of refined carbs in the diet, especially all your packaged cereals, etc., which would contribute to the high fructose corn syrup, which could lead to high uric acid levels. When we're looking at, preventing renal complications, again, very important is to have tight glycemic control, tight blood pressure control, lipid control. So the ABCs of diabetes has to be under control. Again, we're not looking at very high protein intake because, again, we have a very, extreme population where some people would really restrict protein and not really eat enough protein, whereas we have another section of people who go to the gym, and the first thing when they go to the gym is the trainer will tell them to have a lot of have 2 to 3 scoops of protein a day. So again, this has to be under, recommendation from a qualified professional who understands, what is the kind of workout the person is doing and how much protein really we need to give this individual. Again, monitoring protein intake becomes important, and the guidelines suggest that around 0.6 to 0.8 grams per kg of body weight per day is good enough. You really don't need to go very low unless the person is on a keto analog, etc. Again, plant-based protein is what is preferred because it is more protective to the kidney. So even when we're looking at, renal, we're focusing on a more plant-based diet, which is known as the PLADO diet. Controlling the salt intake, limit the salt to less than 5 grams per day, around 1 teaspoon, avoiding packaged and processed, I would say more ultra-processed foods like bread, biscuits, pickles, papads, all your ready-to-eat and packaged snacks, which are high in salt. Again, advanced glycation end products. Now, this is extremely important and gaining a lot of relevance today is because modern diets are largely heat processed and as a result contain high levels of advanced glycation end products. They're also naturally present in uncooked animal-derived foods, and cooking methods, especially like grilling, broiling, roasting, searing, and frying, will actually result in more age formation. And therefore, these are things that we really need to look at. Now, how do we reduce the dietary age? It can be achieved by increasing the consumption of legumes, low-fat milk products, your vegetables, fruits, whole grains, fish, and also reducing the intake of your fatty meats, especially, your processed meats in the form of sausages, salami, ham, etc., that people consume, your full-fat dairy products, and highly processed or ultra-processed foods. Again, dietary age can be reduced by adapting healthier cooking methods such as poaching, steaming, stewing, and boiling. The use of acidic marinades such as lemon juice and vinegar before cooking can also be encouraged to limit the dietary age generation. Now, very, very important is most times we see that when people want to eat healthy, they would start opting for grilled meat or grilled fish. Now, again, when you actually expose a barbecued meat or barbecued fish, now when you expose the meat to direct flame, the juices from the meat will actually interact with the flame and produce something which is called as PH, which is polycyclic aromatic hydrocarbons, which is known to be atherogenic and carcinogenic. And therefore, it's very, very important that when we counsel people, we have to tell them the healthy methods of cooking and what can they add to the food to help to reduce the dietary ages and also preserve the nutrients in food to be able to get the anti-inflammatory and antioxidant benefits. Now, this was again an interesting, study which was done by Dr. V. Mohan and team, where they showed that the low dietary age diet exhibits improvement in insulin sensitivity and reduction in inflammatory levels compared to the high dietary age diets. Hence, this is the first study in India which has shown that low dietary age diets could be a potential strategy to reduce diabetes risk and overall improve metabolic health. Gut microbiota, we keep talking about it, and we know that it definitely has a huge influence in reducing inflammation and associated metabolic abnormalities, and therefore focusing, when we're looking at a diet, focusing on adequate prebiotic as well as probiotic intake. And honestly, from our dietary sources, our traditional foods, like for example, if you're looking at the eastern part of India, we have pakala, we have panta bhat, we have kanchi, we have certain pickles which are homemade. All these are good sources of probiotic. And again, prebiotic, we have onions, we have garlic, we have, raw banana, etc., which are a good source of your legumes, etc., which are a good source of prebiotics. So if you look at our traditional Indian diets, we do have, prebiotics and probiotics, which are a part of our Indian diet. And therefore, very important is to encourage people to stick to their traditional Indian foods, whether they come from any part of the country, whether it's north, south, east, west. We have so many of our own traditional recipes, which are very, very healthy and definitely help to improve your metabolic health and also gut health. While we are focusing on all this, very important is to focus on waist to height ratio. We know that BMI is redundant and people may have a healthy BMI but not have a healthy waist to height ratio. And today the focus is on, keeping the waist circumference in check, because waist circumference itself is an indicator of, all your lifestyle diseases as well as risk for other complications such as cardiovascular disease, etc. And therefore, keeping the waist to half the height is something that is very simple for us to, do in our clinic, and also tell our patients to do at their homes. So to conclude, the key messages is optimizing glucose control, blood pressure, and lipid, which is the ABCs, is very, very important. Following healthy dietary pattern, consuming more home cooked meals, deleting all the apps where you can order food, moderation in carb intake, looking at definitely improving the quality of the nutrients, whether it's carb, protein, and fat, improving the amount of protein quantity as well as quality, even looking at including healthier fats in the diet, following the healthy plate method. The correct food eating order helps to manage blood glucose levels, improves satiety, keeps the waist in and waist circumference in check, as well as the weight in check. The dietary patterns such as your Mediterranean diet, the DASH diet, the MIND diet, which is a combination of Mediterranean and the DASH diet, the new Nordic diet, the plant-based diets, which are all very, very similar. And again, like I mentioned, they're very similar to what we usually eat in our country. They have shown to reduce complication risk in addition to glucose control. Very, very important is portion control. Always we tell our patients to eat till they're 80% full and 20% keep your stomach empty. That really helps in terms of improving the blood glucose levels as well as keeping the weight. And most importantly is the body fat and the visceral fat in check. Adequate dietary fiber intake and salt restriction to help lower cardiovascular disease as well as all the other complications arising because of diabetes. Ensuring sufficient protein intake, salt restriction, reduction of high fat, sugar, salt foods, ultra processed foods will help in lower renal complication risk in people with diabetes. So thank you so much for your patient hearing. The RSSDI NIN 2025 guidelines, so to say, is going to be now published very soon. And we have covered a lot of these aspects, all aspects of nutrition, whether it's type 1 or type 2 diabetes. So it'll be a good reference point for you to refer for your patients. And Diet and Diabetes Simplified, a book that I have written, also covers a lot of aspects on nutrition related to diabetes as well as, nutrition for overall health. So thank you so much for your patient hearing. I'll be happy, if you have any questions, you can definitely write to me and I'll be happy to answer them.
Thank you. Thank you, Dr. Sarli, for giving a beautiful review of the dietary management of diabetes complications. And kindly stay on for the panel discussion, which Dr. Ashok Das will take up. And we will pass on to the next speaker, Dr. Richa Mehta.
Dr. Rucha Mehta.
Is there?
Yes, she's there. She's in live.
Yes, I'm here. I'm here.
Yes.
But I don't know, my video is not, I'm trying to load, my video is not loading. I don't know why.
All right. So she is
The
going
video
to
is
talk
on,
on
but
dietary management of obesity, which is the order of the day. And the India in the world is going becoming obese, and we expect some information from you how to control obesity through diet. And she is MD, DM, and FACP, and consultant endocrinologist and director cardiometabolic department of Apollo and INMO Clinic Ahmedabad, chair of research ethics committee at Mujibhai Patel University Hospital, executive committee member of All India Association for Advancing Research in Obesity, RSSDI working committee member for writing the obesity guideline for the RSSDI consensus panel. So international consensus guideline writing group for nutrition, insulin resistance, and obesity, and polycystic ovarian syndrome, publication guidelines, RSSDI international guidelines, and research interest in diabetes, obesity, and pre-diabetes and insulin resistance. Dr. Mehta has rich experience on obesity management, and she will be giving us a lot of directions regarding dietary management in obesity.
Joe, with your permission, I may like to also mention that my dear friend Rucha is a sports enthusiast. She does run multiple marathons. We are not able to see you, Rucha. Where are you?
I don't know, sir. I'm trying to load the video. Can RX events? My video is on, but I don't know.
Can you make the video loaded? So once the video is loaded, I must tell you that Rucha is a great sports enthusiast. She does a lot of marathon, half marathon and full marathon. She has also done marathon in various parts of the country, including Pondicherry. But most important thing, Rucha is out and out a clinician. She is American board certified, Indian board certified, and she's a very famous endocrinologist globally. But her interest in the diet, obesity management, and physical activity is infectious. Is your video loaded now?
It says host has stopped my video, so I don't know. Can RX events start my
Ma'am, I
video?
have sent you the request to start the video again.
I think, Rucha, you have to start your video again. Start video.
But I don't have any. Where is the request? I don't see the request.
It will be there.
Ma'am, can you log in again?
Will be delayed, right? So let me do this. Let me finish the talk and log in again when I get to the panel.
You'll be able to go to the slides second. Your slides will be projected. Your
Slides, I will. She
Yes.
wants me to
No,
log
I don't
in again,
know
but
slides able to share because
Should
we
I
want.
project the slides, ma'am?
no, I can project the slides, I think. Here.
Yeah. But just
Yeah,
project.
my screen sharing is started. Yeah.
Yeah.
Can you see my screen now?
Of course, yes.
Okay,
Of course.
great. All right. So I think we'll just in the interest of time, because we are running behind, I will try to do my video at the end again
Can you
when we
make it
get to the
full screen?
panel.
Can you make it full screen?
Yes, sir. So good afternoon, good evening, everybody, and thank you for such a kind introduction. So, yes, I like to think of myself as being different, that in spite of being an endocrinologist, I really take it to heart that for all of my patients, we try to incorporate lifestyle changes. In fact, last night I did a night marathon, so I was up all night. We did 50 kilometers running. So it has been an interesting day, and this is right along the track. So the topic given to me in 15 minutes is very broad to talk on the nutritional management of obesity. So I like to think of this as a teleological talk wherein I have tried to put together what should be our approaches. What do you mean by nutritional management? We're not talking simply about weight loss, but a comprehensive, holistic approach for all our patients. As we know, responses, just like to medicines, can be variable to dietary and lifestyle changes. With the same diet, one patient might lose 5% weight loss, the second patient might lose 10%, and the third patient 20%. And it is impossible for us to understand this heterogeneity of response, whether it is to GLP-1 or whether it is to a nutrition or lifestyle intervention. So as clinicians, we need to understand this. And really what I feel is troubleshoot and see what works best for each patient. So that will be the crux of the matter, is teaching you how to approach the nutritional management, because that's the best we can try and do in 15 minutes. So as you all know, the global prevalence of obesity is increasing. More than 1,000 million people in the world close to are living with obesity. And in India alone, as you can see, we have 135 million people with obesity. And the highest number that is we think will be impacted is children. So by 2030 and 2040, more than 30% increase in the number of children being impacted. So we really need to take strides and understand better how we can work on this obesity pandemic or epidemic. Fortunately, as we know, we have made strides in labeling obesity as a disease. So we as clinicians can start thinking better what we need to do. Now, we also know that many paths can lead to obesity. So it's not simply genetic. We all like to say, are your parents genetic? Is there a family history? But it's not simply that. In fact, the epigenetic perturbations, which result in increased energy intake and decreased energy expenditure, that's all we used to think of it as. But now we know there are biological controls, psychological stressors, social impacts, Swiggy, Zomato, all these platforms where you can order food easily. We eat just for social reasons. We have beverages for social reasons. Many medications and other endocrine reasons that can lead to weight gain. So we need to understand all of this and put it into perspective when we design even a nutrition plan for our patients. And hence, we need to move away simply from the energy balance model, though we cannot completely ignore it. We need to better understand the homeostatic regulation of appetite, as we know, that we eat when we are sad, which is, we might call that a stress eating. We eat when we are happy, which is what is known as hedonic eating. So it's not always in response to an oral trigger for hunger or that we are hungry. So hunger and satiety are two different things. I'm not going to go through this complex slide, but bear it in mind when we start dealing with our patients with weight loss using a nutrition approach. We need to understand all of this. And I like to teach my endocrine students that no longer is it just the 6 hormones made from the pituitary. The adipose tissue is the largest endocrine organ in the body. And I think the barocrinology is going to be a newer vista wherein we all need to better know how to approach our patients. So in the next few minutes, I'll talk to you about what should be your approach to your patients, macronutrient versus the calorie approach, and some of the newer concepts of protein first, intermittent fasting, and gut health. I had full confidence in my previous speaker, Cheryl, that she would go into details with a nutrition approach about the kinds of fats, and she did just that. So it was more in keeping with diabetes. So, what I thought is we should talk about the ecology of obesity as in a context setting, diet and environment, what works, the gut microbiome, meal order, and we cannot incorporate nutrition, as Dr. A.K. Das just pointed out, without thinking of other lifestyle factors such as sleep, nutrition, exercise, and stress reduction. So let's start with a typical patient. Mr. A is a 28-year-old who comes to us in clinic, and we see this kind of patients not infrequently with a BMI of 38 kilogram per meter square, and he desires weight loss. Now, also, he doesn't want to spend too much. Okay. What do you think he does? He has already tried on his own. Obviously, by the time he comes to see me, he's already got a Fitbit, he's downloaded some application, he has followed some free nutrition advice, he's been doing intermittent fasting, maybe because he thought that is good. Now, finally, by the time he signs up for a program, it's been that he has really ruined his metabolism by trying these various fat diets or many other things. So then what do we do? And he's trying to ask you, not just for weight loss, but what should I eat and what works in the long term? Is it carbohydrate, protein, fat, or fiber, or is it simply reducing the calories? So, of course, we know from this wonderful article that there are several principles of dietary prescription, and that's what we should be focusing on. Should we restrict his calories? Should we select the macronutrient? And is it really a change in mindset and a correction in eating behaviors? So, again, if you look at this, let's talk about low calorie diets. Generally speaking, when we start doing this, we think of causing a deficit of about 500 to 750 calories in the usual intake. Most of the guidelines will tell you that you have to use a 55 to 65% calories. Protein should be at least 15% and fat about 20 to 30%. I'm going to show you several different approaches how we can do this and where do these recommendations come from. Now, in my mind, understand that this seems very good as a maintenance diet. But when you're trying to get patients to lose weight, you have to be more creative and more innovative. Because in our practice now, we see patients who are more than 100 kilograms all the time. So here is a very nice meta-analysis looking at what works. So you can see they compared several diets, which was low carbohydrate versus high protein, low fat, something known as a paleo diet, a low glycemic index diet, and intermittent energy restriction, which is intermittent fasting, the Mediterranean, vegetarian, and the DASH diet. Let's just simply look at the first two columns, which is weight and BMI. And you can see that in this particular study or meta-analysis, they found that the low carbohydrate and low fat diets did very well. Most of them caused some amount of weight loss, but the highest weight loss was seen with these two. And most of this, bear you in mind, were slightly lower calorie than ideal intake in all of these patients. So is this true? Of course, we don't know for sure. And what is low carbohydrate in the Indian context? What is more important to me is understanding how this works. So I was glad to be a part of this article that we wrote explaining that when you start looking at carbohydrates, what happens is we just showed that the low carbohydrate diet works the best. It leads to an improvement in your gut microbiota, reduced inflammation, improved insulin sensitivity. And by this, it helps not just in improving diabetes and glucose variability, but by mechanisms far beyond insulin sensitivity and metabolic endotoxemia is going to do this. Similarly, improving the kind of fats in your diet, improving protein sources, especially plant sources, do much better than animal sources of protein. Now, dietary fiber, which is the new kid on the block, you want to ensure that at least 30 to 40 grams per day in men and women. And this should be viscous fiber, which is readily fermented. And all of this will cause improvement not simply in weight, but also in insulin sensitivity, lipid metabolism, reducing inflammation, and far-fetched improvements in maybe metabolic health, mental health also. Now, what are these ultra processed foods that Cheryl also spoke to you about? So, what I really liked is understanding the NOVA hypothesis. What has happened is that we have moved away from our traditional dietary patterns, and this has been replaced by ultra processed foods. And this seems to be driving the pandemic of obesity. So, what I have done in the next 5 minutes, I've taken the low hanging fruit just to show you what the complex meta analysis stems from. What is the simple 5 things you could advise your patient? Number one is I ask them to get away from packaged and ultra processed foods and move to real and whole foods. To explain better, food is classified into 4 different categories. So, unprocessed or minimally processed foods, which you can see are legumes, vegetables, fruits, starchy roots, tubers, beef, chicken, eggs, chicken, milk. Processed ingredients, when we start getting into salt, sugar, vegetable oils, butter, other fats, you cannot live without them. Then we have further processed food item. So this could be bottled vegetables, bottled foods, syrups, and ultra processed foods, which have zero to non-nutritive values such as cokes and ready to eat formulas and drinks and other such things. So we need to stay in the green and stay away from the red. So I think having this in your clinic as a handout for your patients to see while they're waiting to seen by you would be a huge step forward. The second part of the story, my second takeaway today, is the protein leverage theory. Dr. Raubenheimer and colleagues. I'll explain this slide to you very simply. Now, when we were hunter-gatherers, that's where we all started out. What did we used to hunt for? We used to get up in the morning and go hunt we used to hunt for protein. Now, what he leverages from that is that we are all seeking protein. So if you get up first thing in the morning, and we know protein is about 20 to 30% of our calories daily, if you take that early on in the day, your body will stop looking for other empty calories. So if you could put protein first early in the morning or protein first before the beginning of each meal that would lead automatically to a reduced overall calorie consumption. If we can leverage this knowledge, this is the protein leverage theory, which will lead to protein prioritization. And as you can see, such a time as we reach the target of 15 to 20% protein, we keep eating. So we could modify human behavior simply by using protein leverage as one of our important mechanisms for our patients. Dr. Alpna Shukla and colleagues have also shown that eating protein first reduces glucose excursion. So you see in this particular study, wherein they gave the patients first, there was a lesser spike in the glucose along the blue line. You can see there was a lesser insulin spike and there was an improved GLP-1 spike if you give protein first. In this particular study, they said to take the protein about 30 minutes before the meal. Don't think that's feasible in any population. So what we must do is we must try to be more realistic and maybe just have a meal order pattern wherein they prioritize taking fiber and protein at the beginning of the meal. Now, along came the new kid on the block, time restricted eating. Watching the clock to treat obesity. Dr. Veradi and colleagues have put together this beautiful article which talks about the 4-hour time restricted eating, 6-hour time restricted, meaning you eat for 18 hours, you eat for 6 hours and don't eat for 18 hours. What I find more realistic in the Indian context is a 12-hour window to a 14-hour window of eating. And we tell our patients to stop eating 3 to 4 hours before they go to bed. And when they get up in the morning, when they start, say, at 8 o'clock, they need to be done by 6 to 8 o'clock in the evening. And this has led to reduction in body weight, which is sustainable of 5 to 8%, improvement in diabetes, PCOS, and improvement, more importantly, what we focus on, improvement in fat mass, reduction in visceral fat, and a maintenance of lean body tissue. Probiotics or the gut health is where all of this is impacting. So we now truly believe that eating ultra processed food, eating all the time, eating late at night affects what we know as an epigenetic perturbation and the host gene expression, which leads to a release of endotoxins, which are then causing a leaky gut, which impacts metabolites and host health and disease. Microbiome directed interventions will be the new thing of the future. So, for now, we have several untargeted. So, as Dr. Das mentioned, you may not have known that exercise of any form for 15 to 20 minutes per day can improve your gut bacteria. Individualize or precision nutrition, fecal microbiota transplantation. But in the meantime, all we have to offer to our patients is prebiotic, probiotic, synbiotics, and postbiotics, which are in your kitchen, and you need to learn how to use them using your friendly nutritionist to guide you. Now, in the future, hopefully, we will have more targeted microbiome directed interventions, such as bioengineered commensals, drugs targeting selective microbial metabolism, phage therapy and CRISPR therapy, and this may mitigate obesity, weight gain, and also diabetes. Now, hence, I conclude that yes, diet can be used to shift the microbiome by increasing fiber-rich foods, increasing plant foods rich in polyphenols and phytonutrients, increase plant diversity, and fermented foods. So the last part of my talk will be about other factors that will impact obesity and lifestyle changes. So the good news, my friends, is that adherence is more important than meal plan type for weight loss success. So don't get caught up in, do I do an Atkins diet? Do I do the Weight Watchers, low fat? The diet that you works for your patients, that they are able to feel good on, they are able to maintain and sustain with a 5 to 10% weight loss, is something that, if it's consistently followed, could translate into a larger weight loss success. Now, you couple this with exercise, physical activity, sleep maintenance, cessation of alcohol and smoking, and you will have a 15 to 20% weight loss. The ADA has also put forth that what is more important is meaningful and mindful motivation for your patients, wherein we facilitate positive behaviors and well being. And as Cheryl mentioned to you, I'm also a part of the RSSDI nutrition guidelines, which will be coming out anytime soon. So let's ask our patients to do simple things like sitting or breaking a prolonged sitting, stepping, increasing their step count by 10 to 15%. sleep for 6 to 7 hours is a minimal, but increasing that will help. Now, when we talk about 150 minutes of moderate to vigorous activity, we forget the term moderate to vigorous and we only write 150 minutes. If they are going to do mild activity, then it needs to be almost up to 300 minutes per week, and slowly training them how to get into moderate heart rate zones. Strength training. If you do this, you will have an improvement in losing of fat and improvement in lean mass. So I think all of this needs to be combined so that we have, as you can see over here, all of these protocols can improve not just the weight, but also it's going to improve A1C, blood pressure, lipids, depression, and quality of life. And in the long term, as I was asked to say, what is the management of obesity? My approach has always been that when the patient is sitting in our waiting area, we ask them to fill in a detailed recall. Our recall sheet runs into 2 to 3 pages, wherein we ask them everything about how much water they drink, how many hours they sleep, what time they stop eating. So, a detailed questionnaire. And then we customize based on their choices and lifestyle. And we develop in our patients a macronutrient understanding. We make them calorie conscious, but not counting their calories all the time. A holistic approach, because once we start the nutrition program, we also start working on all angles. And last but not the least, in order to sustain what we have achieved, meaningful motivation on an ongoing basis is the need of the hour. I believe that's the last slide. And so for our patient, can you really ask him to give up his thali and switch to just a smoothie? I think what's better is to just reduce portion sizes, make one meal look like the top or the bottom, add in exercise, and then slowly get him to understand how can he get better at what he's doing. I thank you very much for your approach, and I'm going to try to see for the panel if I can have my video come back on. Thank you so much, everybody. I think I'm right on time at 14 minutes.
Yes, thank you, Richa. Very nice. And
Brilliant
yesterday,
lecture. Thank you.
45 kilometer marathon, and today you had a marathon expression and the basics doctors should know.
I think,
That is
Ruchna, it has been one of the best talks of the entire meeting. Rucha,
Thank you,
can't we
sir.
see you? Can't we see you?
Yes, sir, I'm going to log out and log back in is what Sutri is asking me to do.
We
So let me
we'll have
try
no other
that.
interview. But
Yeah,
Rucha,
yeah.
to make a long story short, me and Alok, and of course our chairperson, sir, my senior in the medical college, my elder brother, congratulate you absolutely from the core of our hearts for a very, 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 very great deliberation, practical, clinical, useful, impactful. I mean, we can follow it. Sir,
Thank you so
with your
much, sir.
permission,
Thank you.
I spoke this over to Sir Vijay, sir.
Then that is actually the brilliant talk, and we will be getting more information again on the panel discussion, and probably we'll have to go to the Dr. Kanungo's interview.
Yeah, with Dr. Sanjeev Panda. Yes.
Namaskar. I am Dr. Alok Kanungo. I welcome all of you to the National Update on Clinical Diabetes 2025, Nucd 2025. Today we have a very important guest who has proved that exercise and active life gives you fruitful life. And for diabetics, this is very, very important. So we invited Mr. Sanjeev Panda, Additional DG Police of Odisha Government, who leads a very active life, regular routine exercise schedule, and cycling, jogging, marathon, everything. And for superior quality of exercise, he is onto it. Welcome, Mr. Panda, to this session.
Thank you, Dr. Kanungo. This is nice to be invited for this.
Yes, because our listeners are doctors and dietitians and lifestyle coaches. They are all listening to us, and quite large number of doctors have joined, And they would like to know that being a additional DG in the police, how can you still continue your exercise schedule and keep yourself so fit and healthy? What is your daily routine?
Yeah, time is a constraint for every one of us. But if you love something, you like to do something, you'll find time for that. Time is flexible. So if you like your daily routine exercises, you love them, you'll obviously find time for them. And everybody says exercise is good for diabetes, overall health. That's that is a easy suggestion actually. But doing exercise as the daily routine and that too you start liking it. That is the challenge. How to keep doing exercise, being motivated, and to make it part of your daily lifestyle. That is the challenge for all of us.
People love games. They play tennis, they play football, they play badminton, but they do not want to run on a blank road where they are just doing it for doing sake. So that is as very rightly you have told.
And that is true. Basically, playing any games is also interesting. No denying fact about it. Basically, one should adopt some kind of game. But again, when you play games, most of the games are high impact exercises. So obviously, many people cannot afford to do high impact exercises. So in that case, basically jogging and cycling or swimming, they become better choices. Otherwise, if your knee is permitting, you are healthy, then nothing wrong in doing sport, any kind of sports. But in any kind of sports also, if you are doing cycling, running, they complement each other. They are not diagonally opposite. Basically, to become a better player or fitter player, you require strength training, you require a little bit of jogging, you require a little bit of cycling. They basically complement each other.
Both anaerobic and aerobic exercise
exactly.
are always required.
Exactly.
As doctors, we divide our patients into up to 30 years one group, 30 to 50, 60 years another group, and those who are retired or 60 plus another group, and 80 plus are fourth group. In early young diabetics, we can advise anything to do and they do it. But the second group, which is most important and more diabetics, that is 30 to 60, they always have some explanation that I'm busy, I'm not able to do, and all those things. And they always are busy in work. What do you think about them? How can they do it?
Yes, 30 to 60 is, as you said, it is the most, and basically they are important persons in the society. They are doing more work. But still, if you want to avoid diseases, then you have to have an active lifestyle. And that has to become part of your life. It should not become as if you are doing the exercise for the sake of it. And to make it interesting, that is the most important thing is that exercise should become interesting. And to make it interesting, it has to have a social connect. Like if you are doing alone, it becomes boring. You leave it. Suppose you buy a treadmill and keep it in your home. Even if it is a costly one, 5 lakhs, 10 lakhs, and after a month, it will just become a dead piece. You won't do it because you are no more motivated. So for doing exercise, if you have a social connect, you have a group of friends, and you enjoy doing exercise with each other, share with each other, then it becomes fun and it is sustainable. So basically, we should have a small group of friends, like-minded, so that we keep on in the morning. You basically engage with each other, share with each other. The exercise should become fun. Then only it is sustainable.
Yes, that is why in urban areas nowadays we find yoga classes and park walking. People are walking together, and that is real motivation. Others should follow that also.
And one more thing, basically there is no age to start exercising.
Right. Basically, age is just a number. At any age, one can start exercising. Many people think they have become 50, they cannot do exercise. These are all myths. One can start doing exercise like brisk walk, jogging, cycling at any age. Even in our club, we have people who have started their activities at the age of 62, and now they are running marathon, 42 kilometers. They are doing cycling, 1,000 kilometers. So there is no starting age for doing exercises. This is
60 plus people are doing this.
Yes, there are many, not one. There are many. They started their active exercise after 60, and now they are doing 42-kilometer marathon and 1,000 kilometers cycling.
You have gone from Bhubaneswar to Tibet, or
Yeah. We have done quite a big number of things. We have done cycling from Bhubaneswar to Bhutan, Patak to Kathmandu, then Vietnam to Cambodia, then multiple times from Manali to Leh and Khardungla in the Himalayas. That is our cycling. And every year I run 1 or 2 full marathons, that is 42 kilometers. So that is, and to do a marathon, you have to have a training for about 4 to 5 months. That keeps you engaged. And once you follow a routine, it becomes part of your lifestyle. Then you have, as I said, you have to have a group of friends with whom you should enjoy the exercise. Then only it will become interesting and you will do it. And if you are doing alone, it becomes as if you are doing some kind of task. Then you will obviously leave it. How costly equipment you buy at home. You have to get out of your home.
Yes, in many international conferences, diabetes conferences and national also, the organizers are now organizing 5-kilometer, 10-kilometer marathon for all participants. And many people are joining, out of which almost 30% are diabetic. So it can be done at any age with any disease. If you accept heart problem and something like that, or joint problem, it is a doable thing. For maintaining such good health, what is your diet?
Yeah, basically the natural diet is the best diet. I eat almost everything, balanced food, home food. And in addition to that, when I do long exercises, during that time, basically one has to be slightly conscious of taking protein-rich diet. I won't say protein supplement, it is protein-rich diet. So protein-rich diet, being doctors, you know, it is basically as a common man, we know the eggs, the sprouts, curd, fish, chicken, all these things one can easily eat, that is available. Just we have to be slightly more conscious about taking more protein in our diet. One need not take protein supplements, that's not needed if you are taking a balanced diet with slightly focus on more protein-rich diet.
You also balance on fat. Healthy fat you take.
Yes, since I'm doing exercise, I have to take slightly fat, but basically one has to be slightly conscious about more protein intake. That's all.
And you don't leave rice. You
continue. I eat everything. It has to be in a measured portion. You cannot take too much, but one has to take everything in proportion.
In your department, you must be seeing people who are younger than you becoming unfit. That means they do not do proper exercise and other things.
Naturally, as I said, basically, since most of us are in very important assignments, and such assignments don't basically give you so much of time to do exercise. So you have to find time to do exercise. And when you will find time, only when you give importance to the exercise. And you will give importance to the exercise only when you enjoy it. As I said, basically enjoying the exercise is the key to everything. So once you start enjoying the exercises, whether it is swimming, whether it is running, whether it is working with friends, or whether it is badminton or tennis, basically have a social connect, have friends, and do it together so that it is sustainable and doable and fun.
In India, many people have got diabetic foot problem. They are neuropathy and all those things in diabetes. The walking becomes little difficult for them. They can do in-house yoga and other things, or some exercises at home also they can do.
Yes, yoga is basically one of the wonders, and one can easily do yoga also at home. But again, I will not recommend anything at home, because anything at home is boring, and it becomes, then you start not doing it. Then obviously go out of your house, form a group, do yoga, so that you enjoy yoga also.
Excellent. Your police force is so fit, mass. How do they keep their fitness? Only by doing regular exercise, daily morning exercise, or what is their golden rule? How the police and army are so fit?
The police also, like when we join the service, whether it is constable or IPS officers, the training is very rigorous, and they expose to you all kinds of games, etc. But not necessarily all the people, all the officers or men, they stick to the exercise regimen. So most of them, they stick to it because they know they have to work for long hours. Unless they are fit, they cannot do their job properly. So they maintain their fitness. But many also, they don't neglect, and because in police we go through lots of stress, long working hours. So many police people also, they become victims of diabetes, hypertension. So since this job is more taxing, so it is necessary also to do exercise regularly. This is also equally applicable to the doctors. They undergo too much of stress because of their job profile. So whether it is police or doctors, where the work hours are more, when the stress is more, one has to find time. Here it is more important to find time to do some kind of exercise so that you remain fit. And once you remain fit, there is another advantage also. Like if you are not fit, you will take so many leave during the year because of your illness for treatment. And if you are fit, you will be very alert in your office. You can finish the work in less time. Your efficiency goes up, and you don't take leave for the getting ill. Rather, you can take that leave for going for a vacation or going for some activity like running, marathoning. So that leave can be utilized in a more productive way rather than staying at home and being sick.
One of my last question is, suppose you have a nephew who is 20 years, you have a brother who is 45 years, and you have an uncle who is 70 years. To these three group of people, what exercise you will advise? What should they do?
For a person of about 20, it's very difficult to advise because they don't listen to any advice. They feel exercise is wastage. And so that time it has to be self-motivation for him. But slightly mid-age people, it's easier to advise because they must have come across some kind of problem by that time. And everybody can do exercise. Only thing, somebody has to tell them they're capable of doing exercise, like running. Like many people, we start exercising with them. In the beginning, they don't know how to run 1 kilometer, 2 kilometers, but somebody has to make them believe they can do it. Then after that, it becomes natural for them. So basically, everybody can run, but somebody has to make them believe they can run. This is the whole process. And the person who is 70, again, basically, we cannot say he can do very rigorous exercise unless he has a background prior to it. But certainly, walking, swimming, these are low impact exercises. They can easily be done by any people of any age group. And basically, when it comes to running or cycling, like somebody has to make you believe you can do it. And everybody can do it. This I can tell you from my experience.
Thank you, Mr. Panda, for such a wonderful interaction with us. Many thousands of doctors are listening to you, and many young dietitians and others are also listening. They will be really inspired because your theme was inspiration. If you are motivated, you can do anything and you can run 42 kilometers marathon. So that's just motivation, and for that you have to have physical fitness. That is what the communication for today's interview is, that anything is possible by everybody, provided they are motivated and fit. What your last word?
And again, my last word will be try to make fitness as your part of your lifestyle and start enjoying the fitness program, whether it is sports, whether it is running, whether it is cycling, so that it is enjoyable and sustainable. And the focus is basically to make it more social. You have a group of friends so that it is enjoyable and doable and you enjoy. So unless you enjoy the fitness program, you are not going to do it. So my only advice to anyone is enjoy the fitness program. So then it is doable. So that's all. Thank you very much.
Thank you very much on behalf of National Update on Clinical Diabetes. We thank you, Mr. Panda, for your time. Thank you.
Thank you. Thank you. Thank you.
Namaskar.
Namaskar.
I request us to moderate this session.
Yeah.
Or Rucha ma'am, Cyril if possible. Dheeraj Panda is one of our very bright young doctor who also does marathons. Dheeraj, have you joined?
No, sir. Ma'am won't be able to join.
Dheeraj.
Dheeraj. Rucha, let me start the question with you, Rucha. I am really extremely happy that you could join virtually, even though our invitation to Pondicherry to come in person, face to face, is very close, and we'll be meeting soon.
Yes,
Richa,
sir.
I really appreciate very much what you said, and I'll be asking question at random, and we have about 15 minutes time. So by 14 minutes, as you rightly concluded, we conclude. And
Thank you, sir.
my first question to you: out of all the things that people do today, I have found keto diet is not useful. I'll have very fast questions, because I have found people do keto diet and develop severe vitamin deficiency with angular stomatitis, sclerosis. You know whom I'm meaning. So it is great hazard. What is your opinion of the keto diet?
Yes, sir. So as I was mentioning what I showed in the slide in the meta-analysis also, we showed a low carbohydrate diet. So the difference between a low carbohydrate and keto diet is the amount of carbohydrates. The absolute amount of carbohydrates in a keto diet goes down below 50 grams, which as we know is not sustainable in the Indian phenotype prototype at any point in time. The low carbohydrate diet is about 125 to 130 grams per day. Again, which I think is not sustainable in the Indian prototype. Having said that, when we put our patients on a low carbohydrate diet, it is more to make them understand how many carbs they are eating, and we do it for a short term of about 10 to 14 days and with a very one-on-one interaction on a daily basis. In any diet, if we don't pay attention, so these are the macronutrients. When you're saying so low carbohydrate diet, you're talking about the macro. Carbohydrate is one of the macronutrients, fat and protein, and fiber are the other three macronutrients, as I like to call them now. Fiber I've included there. Micronutrient deficiency is what causes all these other complications that you talked about, this angular stomatitis, the chelosis. Doesn't matter which diet you put the patient on, whether it's a low calorie, simply cutting out calories, or low carbohydrate. We must always be cognizant to check their levels. And even if we don't check, we always give them a multivitamin, a B12, a D3. Because so we are talking about patients who are 100 kilogram plus. So we have a 1 year intervention sometimes. It's not, just an intervention for 3 months to lose 5%. We have to try and get them to lose 10, 20 kilograms, which could take anywhere from 3 to 6 months to 1 year, and sometimes they'll take a break and come back. So through all this, we make sure we are replacing all their vitamins, even including checking their iron levels, if necessary, giving iron supplementation through the IV. because very often they are not absorbing very well. They have so much gut dysfunction, as I showed the microbiota picture. Why some of this is happening, that they don't absorb the micronutrients. So it's not just the diet, it's also what the whole phenotype has gotten spoiled. So we need to reset all of this. So I think that's my answer. So
Absolutely. I just want, I told you I'll be asking questions random because what is useful for my audience. The second one is TRE, time restricted eating. And that's easily doable because, in Indian system, we call it IKS, Indian knowledge system, we had their Vaishnavites who take food very early in the evening. I don't know about the Gujaratis in Ahmedabad, but do you take food very early in the evening? If you take food early about 7 o'clock and don't eat till next morning 8 o'clock, does it constitute a good TRE?
yeah, so time restricted eating is something that like I said, I really believe in. But if it causes stress, it's not for you. So if someone told me that don't eat only in 6 hours, I'll be so stressed out. I think that stress will make me have all the negative hormones. I need to eat 10 to 12 hours a day, and I like to spread out my meals. So as we said, we customize, and what we have found, now we have data on a lot of patients also in our own practice, is that a 12 to 14 hour, eating for 12 hours to 10-hour eating window does better. So if, for example, in India, we get up at 8 and we like to have a cup of tea, and as Sir earlier, Mr. Panda, the IG said, do everything as a group activity. That is our Indian psyche. So we like doing that. We like having not just exercising or walking in a group, we like having our tea with our friends. And then also at the end of the day, as you said, no, we want to keep something good and start with protein, end with protein is what I didn't show because I don't have enough data to show that. But yeah, so time restricted eating, 14-hour window to fast is good, 10 hours to eat, 12 hours if you can't do 14 hours.
Yeah.
So
I think Alok, you can chip in whenever you want. My one of the next important question, Rucha, to you is that how did you get interested in this in India or in United States? Was there a good friend who really motivated you?
So I think that's a very nice question, sir, because when I first moved back, so I was into running myself, but in the US, we always had very well-trained nutritionists and in the clinic, and people could be referred to a lifestyle program because the insurance would cover it.
Yes.
Now, when we move to India, very often the patients, even if you'll say go and see the dietitian, either they don't want to pay extra or they don't want to spend the time, and they say, "Nee, doctor, aap hi de do
In a
diet."
lighter vein, I'm told some of the dietitian to the film actresses and Ajrich as Rucha Mehta, they charge
No,
a fee of 25,000. Is it true?
more than that, sir, a lot more. The
Hollywood, more than
25,000 is to see
US.
their subordinate, yeah.
They charge
But
quite
so
a
what
bit.
I'll tell you is, in India, I think it's a very doctor-driven society. The
Absolutely.
patient will ask every doctor, or doctor saab, khana kya hai? They'll ask, what can I eat in the end? I think most of you, Dr. Kanugo, you will also say, right? That your patient will say, what about, can I eat this? They'll start asking, and then we don't have time because you have 50 patients waiting. So we just give them a very generic answer. So I think when I first moved to India, I started realizing I didn't have the dietitians when I was at Apollo. So I started first I made some generic diet for thyroid, for diabetes, for somebody who wants to lose weight. Then I started realizing that that's not going to work. And now in my clinic, we have almost 7 to 10 nutritionist dietitians. So that is how much importance I give that. Two of
Absolutely.
them are certified physiotherapists who have done nutrition certifications also, who are physiotherapists. So we are really focusing heavily on the lifestyle approach now, and that has been. But it started with me giving diets. Even when I was sitting in civil hospital, I would just tell them to ek meal nahi khana hai, raat ko roti nahi khana hai, like very simple changes that we could adapt. And I started seeing bigger impacts. Patients started liking when their insulins would go down or things would get better, they felt better. So I think that's where it started, was more of, working with the Indian
But
clientele and seeing
I
what
really
works.
appreciate your teamwork. I mean, the team you yourself constituted and started has paid off well. But many practices in India are solo. What should they rely on? I mean, they don't have team. So what should they rely on? Some
Yes.
printed
So I
format,
think,
videos.
yeah. So three things that I always tell when I'm giving this talk to clinicians, when I'm asked to do it is, number one is they need to understand nutrition a little bit. So we start off with the basics of what are macronutrients, what is micronutrients. Number two is, of course, for any diet to work, you have to eat a little bit less than what you're expending. So we cannot get away from the calorie balance model still. Number three, when they are waiting to be seen in your waiting area, I'm more than happy to share our diet and exercise and lifestyle recall, which is about 2-3 pages, as I said. Fill that out, have them fill it out, and you'll be surprised even if you don't do a lot of intervention. Timing your medications, because sometimes we'll write, okay, glimepiride BD. What is BD? They are my eating 8 times a day. Which 2 meals of the day? So I think understanding the 2 largest meals of the day and then giving some medicine also with breakfast, which goes till lunch, and lunch, which goes till dinner, because we eat 6 meals a day at least, if not more. So I think you'll be surprised how much better you do even writing not just the nutrition prescription, exercise prescription, but also your medication prescription will get better. So I think very simple 3 things. But then, of course, you'll have to, like I started in the beginning, having handouts. So I think the easiest meal to replace in India is breakfast. So I didn't get into meal replacers, but whenever we get into that, is if they are eating fried food or aloo parathas, depend idli, sambar, dosa, we can switch that at least. It doesn't have to be using just a protein powder. It could just be okay. That meal you're going to replace with sprouted moong, mixed chana, something healthy, and a fruit. So you standardize that 200-calorie meal is standardized. And then telling them at least to start increasing the step count after a month when they come back, resistance training, and having access to a physiotherapist for most of our patients who's motivated. And you don't have to make them bodybuilders. They can all just start with functional training, conditioning, balance. That is what more our patients need. Yoga, whatever works. We have to figure out, the recall will help you figure out what they like.
Yeah, I would ask one very important question. One of the Mohan's paper, in which I am also an author, we said that eating too much of rice is the responsible for increased diabetes in South India. Rice with more Colombo, rice with rasam, sambar, curd, and so many times rice. In small quantity rice, quantity becomes more. Do you believe
Yes.
in that? Do you believe in that?
So in any plate, the Dr. Mohan also wrote that logarithmic paper. If you can reduce carbs only by 20%, that would work. And I think we need to do a
He said,
real-time
and
study
replace
on
that
that.
by 20% protein. He said that will take
Protein
away
or
diabetes.
vegetables, yeah. Fiber and protein, I think, will
Yeah,
be
he
king
said
in
that.
the
I
future.
should not talk about
Absolutely, sir.
non-veg protein to Rucha. Rucha is absolute veg. Yes, correct.
No, sir, non-veg, I mean, I'm not, but I have full understanding of non-vegetarian protein options also, of
How did you
course.
manage in the United States so many years?
So in the United States, with vegetarianism, you mean?
Yes.
Oh my God, I think United States is more vegetarian than India. In fact, it's going vegan now, right? So I think we are trying to adapt to the Western culture, whereas they are adapting to our culture.
Oh, very good.
So
Coming back to
yeah.
Mohan's paper, you believe in that if you cut down 20% carbohydrate and take
So in
that
fact,
much.
I had a good chat with Dr. Mohan recently, and he said, "Why don't you do the study and I'll support you?" And we take up patients in different parts of the country, at least the 4 corners,
Yeah.
and try to cut
He
down
told me
the.
that he mentioned to me your name.
Oh,
Yeah.
great! I'm glad
Yeah.
to hear that, sir. Thank you.
I'm the co-chair for the India DAB study. So that's why he told me that we want to have an extension, ask for grant. I have to sign it. He said, yes, your name was figured very prominently there. The
Great,
other
sir. I'm
thing I
glad to
want
hear
to ask
that.
you, do you mean to say that the white rice or the red rice makes a difference?
Yeah. So we have found in at least our.
My family, my children take only basmati rice, and my wife will not at all like to cook twice, once for me and once for the children.
Yes. So I think, the point is well taken. So there are 2 things with different food components: satiety versus the glucose spike and the fat gain. So we are talking. So we have seen, yes, red rice, which is little as unpolished the rice is. You have lesser glucose spikes, which will translate to hopefully lesser insulin spike and less fat gain. But if for satiety value our patients cannot switch, we limit the number of times they can eat rice in the week, and we limit portion control. Then on birthdays and special occasions, of course, we allow them to have some fun, but we'll give them a medication or like a carb blocker just before that. So like Voglibose, Acarbose works very well in helping with that.
I think I was very much impressed by your, yes. So Alok.
Richa, there is a rice available in the market and with some reputed houses, diabetic rice. How do you say it is low glycemic index rice?
Yes,
What
sir.
is
So I
the
think yeah. So
science?
food labeling is a whole topic by itself. So this is, we have to be very careful of these food labels, and we tell our patients not to really get into this till we read how it is done, the process. So this low carbohydrate rice that you're talking about is generally, it depends on which, again, so many out there. For example, I'll tell you a lot of the processed bars you will eat, drink or eat will say zero trans fat. So there are norms by FSSAI. So if you can reduce the trans fat by less than zero point 0.1 gram, you can write zero, but it still has trans fat. So if you eat more chips, you'll have in one serving if it's less than this much, but the whole bag together has trans fat. So food labeling is again, sorry, I hope nobody from FSSAI is listening, but if they are, they can contribute. So same thing with this low carbohydrate. If you can get it below a certain percent, you can get your food label to write that. So we have to be careful what it's reading. So it's better to use cooking practices to reduce glycemic. Like, for example, freezing the bread, freezing foods can reduce carbohydrate. That is a scientific process. Washing the rice, a couple of times together. Those are scientific processes.
That we do.
But just the food labeling is it's an art, I guess. So, yeah.
I think somebody told me, Rucha, that if you want to cut down the oil, just any oil you take, cooking oil, you just calculate 750 grams per person per day per month. So the if you have 4 people in the family, you don't consume more than 3 liters of oil. Does it apply for the cooking oil?
Yes, so cooking oil, in fact, we now, as I think Cheryl also mentioned, what's important is not, it's also about when you start using it at a high temperature, it gets oxidized. And that's what's starting to cause the free radicals, and it's not good for you. So in fact, we are asking that you use as little as oil as possible. And because in India, we do the high flame, the tadka. We put our little spices in there, the ajwain and the jeera. So what we need to do is put as little as possible. As soon as that is cooked, now you can cook in water and then maybe you add the oil at the end so that is healthier for you because good fats, using good olive oil or good fats, like she showed some of the oils over there earlier, they are good for you. But you don't want to oxidize the oil or use it at a high flame is what is important.
You advocate olive oil, but
No,
I
no,
did buy 850 per liter olive oil. Now it is 1,000
no,
rupees.
and it's expensive. It's not indigenous to us, but for the affording people and who are getting it, you cannot get away from knowing the benefits also. We have to be,
Correct. Absolutely. And
level, yeah.
Rucha, I have seen when I advise, they don't buy. But when the cardiologist advise after their first tenting, they buy.
Yes.
So that is the.
So that's what I said. So if we are convinced, that's why I said in my last takeaway, if you saw, I said educating ourselves because we are sometimes shooting in the dark as doctors, unfortunately, or even I think from school it needs to start. To make these changes, advocacy and policy making needs to start in the schools. We are taught how to do everything, but not taught what we should eat or how to cook or anything like that. So some basic understanding needs to start in the medical school for doctors also. Just like because we need to understand our food products better. It is going to have a huge impact at every level. And as earlier Mr. Panda also said about exercise, yes, he said, so like having a friend, having a buddy waiting for you to exercise will make you more committed and accountable. So accountability is important. I think we need to be accountable somehow to our patients that for your better outcomes, we need to know what to prescribe to you for food. Yes.
Last 3 minutes left. I understand you are quite busy and we have been here with us. It's a blessings for us. Last few minutes for the physical activity. So, marathon, forget about marathon. We've been running for 3 to 5 kilometers. For many of us is not possible. We walk very fast. I don't know what physiology behind it. Walking fast on the beach is quite possible on my part, but marathon is very difficult. And as Panda said that you have to prepare for every marathon for last 10, 15 or even a month, you have to prepare for the marathon. Is it true?
Yes, sir. So whenever you're training for any event, if you're going to run a marathon, so we train a lot of athletes, in fact, runners and all over the country. So we have been fortunate to work and it's really amazing to see the level that India has gotten to in the last 10 years that I've been here. We train all our runners, but also I would talk more about the non-runners. We train them to in aerobic zone. So what we do is nowadays most of your smart watches can give you your heart rate or even your phones and everything.
Tapes
So
and
we
all.
teach them to train in aerobic zone. So there are zone 1, zone 2, zone 3, and zone 4. But the easiest is the Borg's perceived rate of exertion. So for example, when you're walking briskly, are you able to complete sentences? If you can sing a song, we always say while you're running, then your heart rate is not so high. But if you're getting short of breath and have trouble finding words, you're running too fast. So what we train them is a couple of things. Is one is the aerobic zone way. rate of perceived exertion. And number 3 is also we'll do the run walk technique by Dr. Jeff Galloway. So for example, so if you're say walking briskly, you can first warm up for 10 to 15 minutes till your body feels warmed up. After that, we'll just ask them that, okay, run for 30 seconds. Now, again, walk, but not all out. Walk, run slowly or jog for 30 seconds. Then walk again for 5 minutes. Then slowly, you can increase the running interval from 30 seconds to 1 minute to 2 minutes. But the walking in between allows complete heart rate recovery so that there is no strain on the heart. And then slowly over, and along with that, strength training is important for a runner because it's your entire body weight is pounding on the ground. So making sure your ankles, the weight bearing joints are trained. So a lot of these things go in. That's why the training, if you're going to run a marathon or even a 5 kilometer next year, I start training my patients, and these are patients who are 130, 160 kilograms, diabetics, patients with heart attacks with stents placed. And I still tell them we'll train you because that is cardiac rehabilitation. That's how we teach them heart rate zones. And we train them over 6 months, good attention to nutrition, sleep, smoking, all of that, everything. So
last 2 questions, we teach our patients, you must be doing that also for this 100 plus weight patients. We ask them to walk and walk for, as you rightly said, 150 minutes a week, but not a slow walking, with a good pace of walking. Do you believe in walking?
Sir, I believe in walking absolutely. In fact, I think there is no better aerobic activity than walking. So if I need my patients sometimes to lose weight, I tell them to stop running and start walking. Because in running, your heart rate is likely to go up. Now, there's a nice graph and nice work done by Dr. Matthew Riddle, who has written the exercise sports guideline also. And if you can keep your heart rate 180 minus age, you are in aerobic or fat burning zone. And we have a huge amount of fat stored in our body. You'll use fat as a source of energy. But if you start running and your heart rate starts going high, that's when you'll start using glycogen, and glycogen is stored in muscle, and you will get having some muscle loss also. So fat burning, the most aerobic activity is walking, especially for women, for men, for all ages. And you can do a little variations in walking, which will train your heart also. So we can do a lot with walking. Yes.
I just said walking, then running, walking, then running.
Yeah. Yes. Yes.
The last question, which is a very difficult question. You may not answer that. The thing is like this, that, with the advent of this anti-obesity drugs, not singling out any single one, that takes away the hedonic pleasure. You said eating pleasure. Remember, you said that eating.
Yes, sir, absolutely.
And eating in sadness. I am very believer in that. Second thing, I wanted to know that these drugs produce a lot of sarcopenia, take away the hedonic pleasure of eating, for which we live. You live for science and work. We live for eating. So,
also, even I live for eating.
so hedonic pleasure of eating, and the issue that you have to continue this drug lifelong, but vis-a-vis having the things you have put before us, exercise and nutrition, and losing optimal weight through that. Which one will you prefer and why?
So your question is which I prefer GLP versus what's the other option, sir?
Physical activity and nutrition.
I mean, so of course, I don't think one can go without the other. So I'm going to give a very politically correct answer. So I think when the GLP-1, so I think I want to explain this sarcopenia with GLP. I'm not convinced that we are getting so much sarcopenia as they are promoting. Whenever I see a patient with very high amounts of body weight, GLP is approved for patients with BMI more than, we are using it in higher weight patients, right? Their fat levels are so high because we do regularly body compositions and DEXAs in our patients.
I want to ask you, do you use DEXA for everybody, or we are using one of the BCAs?
Yeah, we use BCA, in-body BCA, we are using in the clinic. Yeah. But then there are a lot of patients
from the body start. I'm not advertising for them, costing about 8 lakhs.
Sorry. Don't. Yeah. So, bioimpedance plethysmography, let me call it. Yeah.
But the one which is affordable is about 8 lakhs, and that one using in our clinic is okay. I'm not using DEXA. DEXA is available in the institute, but that will cost.
DEXA, a lot of patients come, because of health checkups. So people have DEXA nowadays. Okay. So we can see in that. Now, whenever you see the body fat in that, it's very interesting to see that the muscle is also having what we call IMCL, intramyocellular lipid. When you start losing weight, you cannot predict which fat will move out first. You're not going to move visceral fat first. You will move fat from the muscle and the subcutaneous area, right? Subcutaneous fat has no blood flow. So very often intramyocellular fat has blood and will go down first. When you see this muscle loss, if it's more than 20% in a 1 year period or more than 10% in 3 months period, then I would call it sarcopenia. But that 10% we will see in all patients. And that 10 to 15% could just be fat mobilizing from the muscle. So we really need to think of this as a grain of salt. And so when we start GLP-1 and people start losing weight, and this is when they have failed diet lifestyle or they don't want to, then they get more active and they're able to work out. So I think also in India, what works is GLP-1 holidays in between. So say you use it for a month or 2 months, they get some weight loss. We give them a little holiday so they can eat, they feel better. And it really helps to keep the metabolism high. Because if you eat too low for more than 3 months, if you stay on 1,000 calorie diet and we do a calorie intake every time they come in to see what they're eating, then your metabolism, as I like to say, gets, very low. You reset your hypothalamic set point. So all of this is sort of thought about, and my dietitians, we do a training every week to make them understand this. So that is sort of where you have to make sure that you're not ruining their metabolism so that, we are making sure that everything gets better.
Rucha, thank you very much. My words fail to. Sir, is telling something. Chairman, sir, Vijay, please. Sir, Professor Mishra.
I am there. Thank you, Professor Das and Madam Mata.
I mean, it has been fabulous. Rucha, your presence, your diction, delivery, and the contents of 14 minutes talk and another 14 minutes of interaction has
Thank
been
you so much.
absolutely fabulous. And me and Alok and our current session chairman, Professor Vijay Mishra, we will put on record our sincere appreciation. We'll be getting back to you soon. Thank you very, very much. Have a great evening. And
thank you so much.
We'll meet in Ahmedabad. Thanks to Bansi.
Yes, sir. And then you have to call us for the Pondicherry Marathon so that I can run with Panda, sir.
I told you my
sir.
apology at the beginning. It will be done this year.
No, sir. Thank you. Thank you so much, Dr. Alok, also for a wonderful meeting and enjoyed the session thoroughly. Thank you, sir.
Thank you, Rucha. Thank you. Thank you. Really happy to meet you and great. I think I'll hand over the session to Sir Bijou, sir. You preside over this valedictory function session only for 10 minutes. Now it is 7:15. I think Alok has given time up to 7:30. So in 10 minutes, we'll have a very, very short valedictory. And sir, can I ask Bijou to chair, sir? Bijou can chair the valedictory function and we will start.
Valedictory function. Professor Ashok Das is the person. We will be there.
No, sir, I just wanted to say that, you see, doing a conference is like a school. Because, sir, I believe in Sri Aurobindo, you know that, sir, I come to ashram. I came for ashram here. So you have opened a lot of schools, mother schools in Orissa. And I'm in the managing committee, but virtual, I never go, of many schools. If you open a school, sir, today up to 5th, next year you have to open 6th, next year 7th. Like that, doing a conference for the first time 11 years back, Alok had thought of it, he had informed me, and we did well. Now, year after year doing it up to 11 years is a great feat. And let us give a big round of applause to Alok, who must have done this 11th edition of the Nucd, because it is not easy. Am I correct, sir? Like every year one class is added. Every year you have to do something extra to get the love of people. Second thing, in the valedictory, there are 3 aspects. The other aspect is I would like to put on appreciation on the behalf of course, Alok will speak about it after I have stopped, of the great help done by the USB, Sanofi, the Novo Nordisk, Boehringer Ingelheim, Sankolta, and Medley, Kids Diabetes Center, and Exeltis, I said, Kanungo Diabetes Center, and the Kids Hospital. And in the valedictory, it is our duty to put on record our sense of appreciation. Alok will speak about it, and we really, really, really thank you for the help you have given. And none of your help will go waste, because they see the third last thing I want to say, the science that is discussed in the meeting is a very high order. So, am I correct, sir?
Yes,
Sir?
yes.
Very high order. The speakers were very good. The topics were absolutely contemporary and challenging. And the last session, you see how much of enthusiasm speaking about it. I have to invite her here. I have not done it, so she's मुझे नाराज है. So Dr. How flowing the people have come here with lot. See the Shiva Prakash, Dr. See Deepak Jumani, see Dr. Sikand Dhar, see the people from the. I would like to that ophthalmologist Sangeeta, na? Sangeeta or no Sangamitra.
Sangamitra.
You see what the motivation they have to teach. Am I correct? So it is
Yes,
I will put on without taking anybody's name. For the entire faculty of this meeting, I will raise a toast. I don't have anything in the hand. I'm raising a toast and putting on record and will be conveying our heartfelt greetings. Alok will convey the heartfelt greetings and appreciation and our love and greetings for the high science, how clinically, practically effective lessons they've given to the masses. And if that is followed, that will make a dent in the college. And the simple last thing I should say, it was a great moment when they started 11 years back, sir. Over the 11 years, this has continued well, progressively increasing, and new things we are adding, and we are making it as far as possible close to what we are needing today. And me and Alok promise there is no end. There is endless progression for the NUCD. Over to Alok. Alok will speak about the book and speak about his heartfelt matters for this conference. Alok, you have 5 minutes.
Respected Professor A.K. Das, but for you, this NUCD would not have been complete, would not have grown so well. And this time, the topics are so well chosen, and particularly the speakers are chosen. They are the best in their life, and they all brought bench to the bedside. And that is the most important thing, that research, all those knowledge came to clinicians, and the day-to-day clinical management will definitely become little better for those who have heard these sessions. I thank all faculties personally, all delegates.
They are the people. Because they are there, we are here. Because they are there, we are here. Thanks to the 3,600 faculty who have delegates who have joined.
My mentor, my brother, and at 11 p.m. and he will be telling me, making this paragraph, eat it. Yes. Jayant Panda, Sambit Das, and many others, all the Dr. Vijay Misra sir, and blessings from Professor K.C. Samal, Niranjan Tripathi sir, K. Misra sir, and everybody, Saurabh and Mamta.
Absolutely. That I should mention. Mamta, your opening sloka was fabulous. We also saw you sitting with Alok in the opening session. You must be watching it on a different computer. Your support for this meeting through and without Alok also great. So we congratulate you and thank you. You are my younger sister, so I will not do namaskaram, but I thank you profusely. And Saurabh, your idea of this interview and the panel discussion has made the all difference to it. Saurabh, thank you very much. And before I forget, Stuti, can you show your face? Your beautiful face we saw very rarely. Stuti,
Sure, sir.
can we see? We want to thank you, my sister. Please show your face. Stuti, we are really thankful to you. You single-handedly, on behalf of the Hardik and the RX events, did this program, multiple interviews, did this program for all the 2 days, reminding people, calling people, and what you did not do. I mean, I'm really very thankful and very appreciative, me and Alok, for what you have done for this meeting. Thank you. And not
Thank
a
you so
single
much, sir.
thing
Thank
went
you so
wrong.
much.
Not a single thing went wrong, Stuti. Thank you very much. I'll
Thank
meet
you
you
so
in
much, sir.
Hyderabad while I'm there next month. I'll meet you there. Thank you very
Thank
much. Alok will speak about you. Alok.
The
Alok,
others,
muted. Alok.
his wife, for being with us whenever we have wanted them. So I thank from the core of my heart RX Events and his team led by Stuti for our conference.
Thank you,
And
sir. Thank you so much.
can I see the slide of sponsors?
Sure, sir.
You must have marked there are only 5 companies, 6 companies we have taken help from because they have come forward with their offers, academic support, and that is why we accepted them. We did not ask a single company to support us this time. Otherwise, you will be happy to know we did not ask any company who was not interested from their side. Heartfelt thanks to Farida ma'am, Prasant Tiwari, Lina Tiwari, Jogendra Singh sir, Rupesh, and the whole team of USP for being with us, and everybody, Sankar. So they have really spread the fire. Sanofi, Dipankar, and everybody in the team have really helped us. Nova Nordics from Vikrant Sotria to Amar Aithal to Manish Malhotra and the team, they have all helped us unconditionally. And a new company came this time. They have the appraisal product and they did very well.
He spoke very well. He spoke very well yesterday.
Very well. He is a silent supporter. Don't want anything in return. Academics and research that company, and I thank you, research, for everything. And Boringer Engelham, the international company which has given glycerin to the market, they are also with us, and I thank all of them. My staff at Kanungo Diabetes Center, Clinic, and Hospital, have they have supported us at every stage. I thank all of you. So Sanjay Swai and he's the technical head supporting the platform. And I thank Stuti and Hardik and above all, Saurabh is the architect of this. My my love for him. So Bijay sir, 2 minutes or 1 minute, your questions. Devarchan is there. He can speak few minutes, 1 minute. And if anybody else
Then,
is
sir, we can start. Alok suggest let Devarchan speak first. Then, sir will give the last word. Devarchan. Dr. Devarchan, you can speak one sentence for a minute.
No, he has left.
Left. Then,
He's
sir,
also
you can.
out.
So, Vijay sir, what's
I must thank everybody, but I must thank Professor Das and Dr. Alok Kanungo, for which that the 11th edition of the Nucd is extremely successful, and particularly I must the scientific team headed by Professor Das actually has selected brilliant speakers and with brilliant slides actually, and then the uh, panel discussion and question answers are extremely good and useful to the practicing doctors and also to the various levels of doctors also. So naturally, this pattern seems to be much better than a physical meeting where people are not there in the hall.
It was
And
suggested by Saurabh.
this is good.
Correct,
I
Alok?
must.
Saurabh suggested
And
this.
actually, Dr. Alok Kanungo is acceptable to all. That is the reason to whom he has approached or given a message. Everybody has cooperated. That is actually he is one of the popular figures.
Ajata Satru and the smiling face and friend of
I, I must also give my respect to Professor Samuel, Professor Niranjan Tripathi, because they are with the advancing age, giving the blessings and coming. And then Dr. Kanungo's family, as you have already told,
yes, exactly.
Mamta madam, and actually her melodious voice and giving the invocation song and other things actually is much more better. They are constantly helping Dr. Kanungo. So Dr. Kanungo has a lot of well wishers and friends, both in and local physicians, family, and then the pharma company, and then all these made.
I must
things
also mention that many of the speakers Alok only has brought. Great, Alok.
So with this, I thank everybody, and the 11th edition of Nucd is a grand success, even if they are in a virtual mode. Thank you.
Last word for the team Nucd. Last word, and I need to thank Bhauja and your children for their inspiring support for me disturbing you at the late nights.
Anytime. Thank you.
Thank you. Good night.
Good
Wish
night.
you all happy new year, and then the coming January again, the 12th edition will should come up with a much better outlook and a much better scientific agenda. Thank you, Professor Dr. Kannan.
Thank you, Alok. Thank you. Stuti, you can dismiss from the meeting.
Sure, sir. Thank you.
Okay.